This Sunday morning, we all of us have gathered here for a very important cause. Protect breastfeeding, a shared responsibility. Today's meet, we get to ponder on the world's natural eighth wonder, that how useful and fruitful is breast milk. Come on, let all of us come together and think. So today, may I call upon Dais to inaugurate this ceremony. May I call upon our Mayor Madam, Dr. Aboli Madam will escort Yannam Madam. Our Mayor Madam Yannam Channam. Mrs. Srikancha Yannam, please come on stage, Madam, for inauguration of the function. Please be on the dais. Our previous past president, Mrs. Rohini Deshpande, Madam, please come on the dais. Senior pediatrician from Sholapur, Yajurvedi sir, please come on the dais. We begin with the lamp lighting ceremony. I request all the dignitaries on the dais to come forward and light the lamp. The Abde sir may also please join them. Shubham karoti kalyanam arogyam dhan sampadaha shatru buddhi vinashaya deepak jyoti namostute.
Shri Guruve Namaha. Tasmai Shri Guruve Namaha. Tasmai Shri Guruve Namaha.
I welcome all the delegates for this conference. The President of Solapur Obstetric Gynec Society would like to address this meeting.
Respected teachers, seniors, and colleagues. Today, we have gathered here for our first physical meeting of this year. It's a hybrid meeting, but there are physical attendees too. I welcome all the speakers of the Pediatric and Gynecological Society. I welcome the mayor who has found time, her precious time, and has come here to attend this meeting. Now, lactation and breastfeeding, as we know, is a natural and physiological process. But if not cared for properly and if not handled properly, it affects the maternal and neonatal outcome. In our day-to-day OPD practice, we have so many parameters to assess our ANC patients and many investigations to do that we find very little time to counsel the patients on the breast care and preparation for lactation. And even after the delivery, we are so much relieved that the baby has cried, the mother has delivered, there's no PPH, and the doctor, the patients, the relatives, they are so much relieved that we do not pay attention to the instructions to be given for the lactation, and we just give the common instructions to the patients like लगेच पाजायला घे and so on, and we don't pursue the important activity of breastfeeding immediately after the delivery. Also, we do not know the specific instructions to be given to the patients in different conditions, like preterm deliveries, if the baby is IUGR, if the baby is shifted to the NICU, if the mother has a failure of lactation, and if she has any breast problems. So these should be handled immediately after delivery. And there are many such situations we come across. There are conditions. I had a condition where the baby had a cleft lip and a cleft palate, and the baby could not take feeds immediately. Later it was operated and the baby was fine, but the mother said to me, बाळ प्यायलंच नाही आणि माझं दूध सगळं बंद झालं बघा. So at that time, it clicked to me that at the time of the delivery itself, I should have given some specific instructions to the patient so she could have continued her lactation. So to guide us on this topic, we have a team of renowned pediatricians and gynecologists. Dr. Rohini Deshpande, renowned gynecologist from Solapur. We have Dr. Mangala Vani, who will be arriving here soon. And she has spared her valuable time and is coming to Solapur. And we have pediatrics speakers from the Pediatric Society too, renowned speakers, Dr. Sheetal Gandhi, Dr. Poonam Jadhav, Dr. Shakira Savaskar, Dr. Hemant Sate, Dr. Mohan Shegar. And we have also senior consultant from our society, Dr. Yajurvedi sir, here as a chief guest. I welcome you all. I also welcome the chairpersons, Dr. Kohli, Dr. Shobha Shah, Usha Dundore, Dr. Vijay Pawar, and our panelists, Dr. Varsha Kirpekar. I welcome all of you, all the delegates, all who are attending on the online, and who have spared their valuable time to attend this CME. Thank you, all of you.
Thank you very much, Abuli Madam, for throwing light on whoever the delegates and the chairpersons today. Can I call upon Dr. Rohini Deshpande Madam to speak a few words?
Good morning, everybody. Respected First Lady of Solapur, Mrs. Yannam. Very nice to see you here, Madam. Our President of Solapur Obstetric Gynecological Society, Dr. Aboli Belankar. Secretary, Dr. Archana and Prajakta. and president of IAP, that is Indian Academy of Pediatrics, Dr. Shetty. Unfortunately, she is not here, but Vice President, Dr. Mrs. Arkal. It gives me immense pleasure to be here today for such a good cause of discussing on various issues which are related to lactation. I appreciate the gracious presence of our chief guest, Dr. Yajurvedi, and all the senior consultants who have taken time off to contribute to this webinar. I give all the viewers best wishes for this breastfeeding. It is as challenging as being at Olympics. And I feel that, every aspect of lactation has to be addressed in a very serious way. I remember way back when I was a student, and maybe I was in England in 1986. And when I went to OPD, as a senior houseman, we had one questionnaire where we were asked that we should ask this question to a woman who is getting prepared for labor. And the question was, how do you want to feed the baby? And I was really amazed at this question because I never expected that such things should be really addressed too. Because only 25% of women, they were breastfeeding at that time. Maybe this was an affluence in the society, maybe urbanization, maybe they thought probably that it is a very painful phenomenon, or maybe from aesthetic point of view. So this really actually, it alarmed me of the situation. And today here we are still fighting on this issue of baby-friendly hospitals. And that wave has really come to India as well. We know that from ancient time, breast milk has been given immense importance. And we all know, and we are very fortunate to be in India, that, around 95% of women are breastfeeding, but those 5 to 10% who have difficulty, we have to help them out to make the successful breastfeeding program. And now that we know that its immense advantages on the women's health, on baby's health, makes it even more practical that, we have to get trained. And our future generation of doctors also have to get trained and counsel the patient in such an effective manner that this becomes a very successful program. So I give you best wishes for this program. And I'm very happy that all the faculties are going to talk on various issues. Thank you very much, Dr. Aboli, for inviting me here. Thank you so much. Have a great day.
Thank you very much, Rohini, madam. Yajurvedi sir would want to say a few words.
Office bearers of Indian Academy of Pediatrics and Obstetric Society of Solapur. I first of all congratulate you all for arranging this CME on lactation, because obstetricians and pediatricians have to come together to tackle this issue. I really doubt, Rohini told me just now, importance of breastfeeding, but how many obstetricians examine breast during ANC? I really doubt. I really doubt, because the breastfeeding practice should start in ANC period, and then it should be carried forward for further things. Breastfeeding is so important that it is for well-being of the child and his future. It is said that the childhood-born adult diseases means the child who is going to get older and older, and he will catch the diseases, but the seeds are sown when he was in childhood. So childhood-born adult disease, this is a new concept. And to combat this, breastfeeding is very, very, very important. The topics are chosen so nicely and various speakers are able to guide us that I congratulate again OBCGY Society IIP Solapur, and I am really honored to be here. And Aboli Velanikar Sarita invited me yesterday. So I really thank you very much. Thank you all of you. Thank you so much.
Thank you, Yajurvedi sir. Now I call upon the chief guest of today, Yanna Madam, to please say a few words.
व्यासपीठावरील सर्व डॉक्टर्स मान्यवर, उपस्थित सर्व मान्यवर, आज या ठिकाणी ब्रेस्ट फिडिंगचं माहिती ऑनलाईन आपण सर्वांना देणार आहोत. ज्या मुलांना आईचं दूधच महत्वाचं आहे, त्यांच्यामुळे बाळ चांगला आणि तंदुरुस्त राहतात. आत्ताच्या काळात आईनं बाळाला दूध द्यायचं कमी झालेलं आहे. ते सर्व डॉक्टरांच्या माध्यमातून जास्तीत जास्त आपण प्रसार करून ते मुलांना कसं पाजवणार आहे, आपण त्यांना माहिती देऊन सहकार्य करावे. तुम्ही चांगलं काम केल्याबद्दल तुम्हाला शुभेच्छा आणि माझे 2 शब्द संपवतो. धन्यवाद.
Thank you very much. All the dignitaries, may they please take your place. We'll start with the lecture sessions. For the first session, the chairpersons are Dr.
मॅडम खाली ठेवू दे.
We will start with the first session now. The chairpersons for first session are Dr. Dattatray Kori. He has completed his MBBS from VJMC Sholapur in 1990. He finished his MD Pediatrics in 1995 from VJMC, worked as pediatrician in Solapur Municipal Corporation for the past 20 years till 2015. Since 2015, he's working in his own Mukta Nursing Home, a maternity hospital. He has been SAP President 2020 and Vice President SAP in 2018. Welcome you, sir. Our other chairperson for today is Dr. Shobha Shah. Shobha Shah Madam is a senior obstetrician gynecologist. We know her very well. Welcome you, Madam. I hand over the mic to the chairpersons for the first session.
Good morning, everybody. We are going to start the first session. And Dr. Sheetal Gandhi is well-known pediatrician from Cholapur. I will request Dr. Kori to introduce him.
Welcome, everybody. Today, we are going to start with our first section. Our Dr. Sheetal Gandhi sir is going to start the first section on antenatal and infant nutrition effect on the brain development. So, Dr. Gandhi sir is practicing a consultant pediatrician since last 30 years in Solapur. He has completed his MBBS and MD pediatrics in 1986 from VM Medical College, Solapur. Since then, he is practicing as a consultant pediatrician. He was honorary professor of pediatrics from in VMMC Department Medical College, 1999 to 2009. For 10 years, he worked as honorary professor. At present, he is PG teacher for MD and DNB, and he was elected as National IMA professor last 3 years back. And in his undergraduate days, he was a topper in physiology, biochemistry, and general medicine subject. Apart from that, he is well known for his musical hobby. He is Sangeet Visharad violin and Sangeet Alankar violin. So I request Dr. Sheetal sir to start the first session.
Hello. Good morning, everybody. And thanks to the Obstetric and the Pediatric Association office bearers and organizers of this wonderful program today. My topic for today is brain development and maternal and infant nutrition. Yes. Well, we know I'm happy to see the obstetrician and pediatrician sitting together at the dais. And we know the friendship, they are good friends like this friendship of Tom and Jerry. Well, it is up to you to decide who is Tom and who is Jerry. And the grand person, Mr. Hippocrates said once upon a time, let medicine be thy food and food be thy medicine. So I think there can't be any more apt sentence than this when it applies to the brain development in the child, especially in the womb and in the immediate perinatal period and the postnatal period. Well, these are some of the great personalities we ever see in the day-to-day life. The Mr. Rajnikant, then if you want to become a musician or a IITian or a journalist or a head of the department, or maybe a mathematician or a doctor or athlete and hockey player. Yesterday only we got the gold medal in the Olympics, and or maybe a backbencher. And then this is a different breed and more intellectual than anything else. So all the roots of these, as Dr. Yajuru sir already pointed out, they lie in the womb and in the immediate postnatal and antenatal and perinatal periods. Well, we have plenty of brain development diets. available in the market, but then they are not of any use for the patient. Well, coming to the some of the basic brain matters, we have around 100 billions or more of neurons with connections of more than 50 trillions, and with a capillary network of whooping 400 miles with surface area equivalent to about 100 square feet. And the basic wiring is determined by the genes, but the nutrition makes a lot of difference. And in early infancy, the connections, they increase 20-fold times, mainly from the external stimuli and the stimulation from the atmosphere or the environment. Now, this is just to recapitulate the brain development, which we have learned in the first year of our MBBS. In the first trimester, the neural tube formation and the neurogenesis, then the phase of neural migration starting from the 12 weeks or onwards, then structural completion by, say, basic structural completion by 28 weeks, and then synaptogenesis and the migration, and the myelination begins in the third trimester. So this is a rough idea. Well, just see the, this is the graph which I want to show. During brain development, around 2.5 lakhs of neurons may be added in 1 minute. So that is the magnitude. And if you see the graph, the first graph, the upper graph is a bit comparison between the male brains and the female brains. The males always have the blues, the females are in pink or red. So if you see the weight wise, the brain of the females is 10% less than the males. But if you see the lower graph, brain weight compared to the body weight is more among the ladies. And if you see the according to the age, the percentage of the brain compared with the age, it goes on diminishing. So by adulthood, it is just around 3% of the body weight. So mainly the development is there in the early years of life. As you can see in this graph, it is by 2 years of age, 80% of adult size is achieved, and by 6 years of age, 90% is achieved. And the principle is use or lose it. That applies for the brain and all phases of our life. The early experiences, including the deprivation, emotional deprivation or the sensory deprivation, they play a major part in the brain development. And the parents, as we know, they are the first stimulus for the baby. Now, which are the factors which affect the brain development? There are plenty of factors, like say genetic composition, the main thing, then the maternal mental status, environment, socioeconomic status, the family education, antenatal events, perinatal, postnatal events, we know very well, then prematurity or LBW. And the most important thing is the nutrition of the mother as well as the baby in the postnatal period. Good nutrition, why it is essential? It is essential for development. The overall development, physical, social, emotional, cognitive, linguistic. And what happens if there is a prolonged malnutrition? There can be a direct effect which can cause a structural brain damage, or there can be indirect effect in the sense that there may be decreased stimulation and decreased motor activities, so impaired mental development. And the one thing one must note that the timing, dose, and duration of the deficient nutrition, they decide this equally. For example, if there is an iodine deficiency in the latter years of life, it may not cause that adverse effects as they may be caused in when the child has an iodine deficiency in the antenatal period. So that will have a prolonged effect like that. So malnutrition will have multi effects on the brain. It will affect the cognition, learning, behavior, thinking, communication, social adaptability, physical development, everything. Well, Aristotle's, he said, there is reason behind everything in the nature. Why the humans are delivered vaginally and why the humans are breastfed? We never ask such questions, but then there are some answers in this coming slides. Well, our health and the brain development, it depends mainly is what the mothers eat during the pregnancy and lactation, how the baby is delivered, vaginally or by cesarean, what is the baby feeding in the first 2 years of life, and what a person eats throughout his life. Mind well, the brain development continues throughout the life. So it may not be structurally, but the functional developments and the rearrangement, they occur throughout the life. Well, the factors which modulate the gene expression. Now, the gene expression nowadays, what is called as epigenetics. So this epigenetics is mainly affected by the body composition when 80% of it is already pre-programmed at conception. If you see the biological parents, the babies, they mimic the biological parents and not the adopted ones. And the maternal dietary factors, they play a major role, especially the macronutrient deficiency. Among these, the proteins are important and the fats are important. And the micronutrient deficiency, all the vitamins and the minerals like iodine, iron, zinc, magnesium, manganese. There may be many more which will come in the future, which will affect the brain development. At the DNA level, what happens is the DNA metabolism and the repair, it gets affected because of dietary factors, which act as either as cofactors or enzymes, or they act as substrates in the metabolism. And there will be a gene diet interaction, which will affect the genetic code. So you see the micronutrient deficiency may be there, which will have an effect on the DNA repair. There will be gene diet interactions, or there may be oxidative stress, and there will be interaction with the genes. So it is gene oxidant interaction. So that will lead to a DNA damage, which in turn will cause birth defects or maybe brain malformations, the mental retardation and cognitive and other problems. Well, food choice. Yeah, this is another concept coming nowadays. The flavors, they play an important role in the food choices in our life. How? The flavors, they are combination of taste, smell, and chemosensory stimuli. Flavors, they are determined by the innate factors or inborn factors, the environmental factors, and the learning experiences. So you see what is happening, the flavors in the amniotic fluid. So what the mother is eating, there would be a flavor in the amniotic fluid, which will affect the taste because the fetus is swallowing the amniotic fluid. The flavors in the breast milk, they will affect the nursing baby. Flavors of the weaning foods, they will affect the weaning infant. And the flavors of the adult food, they will affect the food of the child or the eating of the children. So throughout life, it is important that you concentrate what your child is eating. Now there is this is microbiota gut-brain axis. This is affected, as I said, with mode of delivery. When the baby comes out, the baby gets a vaginal flora of the mother. So that is you can call it as inherited from the mother, and which will play an important role further in the life of the baby and in the development of this brain. So there are the diet which we are taking. There will be some modifications which are known as neuroendocrine immune modulators. They will affect the microbiota, and sometimes this may get deranged. That is what we call it as a dysbiosis. So in this dysbiosis, this will affect the GIT as well as the brain. And you may get some GIT problems like ulcerative colitis, Crohn's, or the irritable bowel syndrome, and plenty of other problems. Or in the brain, you may have autism, then the behavioral disorders, ADHD, the depression, and many of other problems because of deranged gut-brain axis, which is called as a dysbiosis. Now, this is in some further details. If one is interested, he can go. And the main important point is mTOR. That mTOR signifies a mechanistic target of rapamycin. This is a major growth regulator. Now, the plenty of brain development depends on these mTOR levels. They should be at a very constant level. A rise in the mTOR levels is also bad. A fall in the mTOR level is also bad. And this will be affected because of many of the dietary factors. So that is just in a brief about what the dysbiosis is and what is the gut-brain axis, so which will affect the brain development. Then we have plenty of neurotransmitters already in our diet, which we don't know probably. So the neurotransmitters, as we know, they play a role in the structural and functional integrity of the nervous system, and more than 50 neurotransmitters are already been identified. You just see this is some of the list. The aspartic acid we get in peanuts, potatoes, eggs, and grains, and the choline. Now, choline is a molecule of interest nowadays for the brain development, which promotes the acetylcholine, and which is found in eggs, livers, and soya. And they are found in the eggs, meat, milk, and legumes. So all these dietary factors, they will promote the neurotransmitter synthesis in the baby if the mother is consuming, or if these are given in the immediate infantile period or in the first 2 years of life, they will affect the brain development. Now coming to the iodine, well-known factor in the well-known factor to obstetricians as well as to the pediatrician, which will cause a brain damage in the baby. Cretinism is just 1 to 10%. That is what we see. But if you see some mental damage, which may not be identified as because of iodine deficiency routinely, that counts to around 5 to 30%, and 30 to 70% with some learning difficulties and other scholastic backwardness, they may be because of this iodine deficiency. Now, if you see during pregnancy, the maternal T4 takes care in the first 3 months of the organogenesis or the neurogenesis of the baby. So for the neurogenesis, the baby is dependent on the maternal T4. So that is why it is important that one assesses the thyroid early in the pregnancy and starts treatment if it is required. And after first 12 weeks, the fetal T4 secretion starts, which may take care of the baby's brain development. So these are the timeline events because of iodine deficiency. If the iodine deficiency is there in utero, there may be abortion or there may be endemic cretin. Now this endemic cretin, there is a mental deficiency, there may be deaf mutism or cerebral palsy. Then if in the neonates it occurs, there may be stillbirths, there may be increased mortality and congenital hypothyroidism that we see. Then preschool age mental deficiency, psychomotor defects, school age goiter, and then adults, as we know, multinodal goiters and other things. Well, coming to iron, antenatal adequate supply of iron to mother is very important. That will give sufficient iron for the development of the neurons, then the development of the dendrites, synaptogenesis, synthesis of the neurotransmitters, and the myelination. Maternal anemia in the first 30 weeks of pregnancy, that gives a high incidence of autism and ADHD and other problems in the baby. Baby brain is already severely deficient before the diagnosis of anemia is made. So it is not just important. If you don't find anemia, that doesn't mean that you should not give supplementation to the mother. So it is better to give, and it is, I think, routinely done by all the obstetricians. Strategies to prevent this: yes, you supplement the at-risk mothers. Delayed cord clamping is another policy, or iron supplementation may be required right from birth, which the pediatricians usually don't know. Then iron deficiency during infancy, the timing, dose, and duration of the deficiency is very important. And long-lasting and irreparable damage can occur because of iron deficiency in the baby. But it is also noted that the iron therapy, it doesn't improve the developmental outcome consistently. So again, the timing of the therapy is very important. If you are starting earlier, the better. If you are giving late, say maybe after 1 year, if you are giving iron supplementation, it may not work properly for the brain development of the baby. Well, there is a recent interest in the zinc as a biofactor or a main important molecule involved in the brain development. What is a biofactor? It is any material which has a significant biochemical function. Now, what this zinc does? Zinc transcripts for what are known as the zinc finger transcription factors. Now, these ZNF factors, they synthesize the ZNF proteins, which directly regulate the gene expression, or that is known as epigenetics in the CNS. And this gene expression decides on the neurogenesis, and they also decide on the embryonic stem cell fate. Apart from this, zinc is also needed for the action of the DNA polymerase, which is again involved in the brain development. And zinc is also involved in the programmed apoptotic neuronal pruning. Now, this programmed neuronal pruning is important because there will be excess of neurons added during the antenatal period, which need to be abolished. So what zinc does is it causes the neuronal cell death, which are not required. So these are some of the ZNF proteins and the brain regions which are involved in the development. So there are names of the ZNF proteins. They are involved in the development of the hippocampus and olfactory regions. They are also involved in the development of thyroid hormone receptors, retinoic acid receptors, vitamin D receptors, like that. So So the symptoms or the problems because of zinc deficiency can be multifold, right from the CNS malformations or the neuropsychiatric problems, and they have got a role in the neurodegenerative diseases, as already pointed out by Yajurudi sir, the childhood roots of adult diseases, Alzheimer's and amyotrophic lateral sclerosis. And one must remember that zinc overdose is also neurotoxic. So zinc is neuroprotective as well as neurotoxic. So one must be very careful about the doses and the duration of the zinc therapy. Then vitamin B9, we know that is folic acid deficiency. Everybody knows neural tube defects. Now, recently there has been interest about this folic acid. Now, as you can see from this graph, the folate, the reduction in the neural tube defects because of folate supplementation is just 0.8%. While if you are giving the mother methionine plus choline plus betaine, all three plus, they cause a more severe reduction in the neural incidence of neural tube defects. So they are finding this combination better than supplying the folic acid alone. Now, the role for vitamin A and vitamin D well known. Vitamin A derivatives like retinoids, they are involved in again gene expression and the neurodifferentiation. While then D deficiency, the pediatricians are now finding a role in the ADHD, language development problems, and schizophrenia patients. Now coming to the omega-3 and omega-6 fatty acids, the omega-3 family main, these are essential fatty acids, the alpha-linolenic acid, the food sources, flax seeds, the walnuts, and the green leafy vegetables. And these omega-3 fatty acids, they synthesize the DHA, that is docosahexaenoic acid. While if you go to the omega-6 family, it is linoleic acid, which ultimately synthesizes the arachidonic acid. Now, both these families, they are mainly important constituents of brain cell membranes. And apart from the breast milk, they are abundant in the breast milk. Apart from breast milk, they are available directly from food also. So one can feed the baby in the infancy on the first 2 years of life and even thereafter with all these dietary sources. A word about this DHA. Many of the infant formulas, they are coming with DHA. Now, there are two schools of thought that it plays a role and it doesn't play a role. So there is nothing you are losing by giving this. It may not be working, but you are not losing anything if you are supplying this. It is the most abundant fat in the brain, and it is crucial for the development of brain and the eyes. And the mother supplies during pregnancy, and the breast milk also has abundant of this molecule. And the deficiency will, as already seen, may cause a cognitive impairment and neurodegenerative disorders. Well, oleic acid, another polyunsaturated acid. This is monounsaturated omega-9 fatty acid. And this is the main component of the nervous system. It is found in the olive oil or the soybean oils and avocados, nuts. And supply of this is very essential for the myelination. The low essential fatty acids in the umbilical cords, they correlate with the low birth weight and the small head circumference and low placental size. The omega-3 and omega-6 fatty acid imbalance leads to many problems in the later life. It is important that they maintain the ratio of 1:10. If omega-3 is 1, the omega-6 has to be 10. The imbalances will cause more problems than the absolute amounts of these acids. And this imbalance can be corrected by eating more of the omega-3 rich fish oil or the flaxseed oils, then eating less of sugars, avoiding trans fats, and avoiding the hydrogenated oils. They are rich in trans fats. Another molecule of interest nowadays is acetyl L-carnitine. Now, this crosses the blood-brain barrier better than the regular carnitine. The importance of carnitine, I think the pediatricians know better than the obstetricians, as we are encountering many of the inborn metabolic errors where carnitine deficiency is there. So we supply them with carnitine. So this acetyl L-carnitine is a better molecule. It's a powerful antioxidant, and it increases the acetylcholine, which is useful in Alzheimer's and other hypoxic brain damages. The main food sources, meat, fish, poultry, and milk. What it does, it preserves the genetic information, and it increases the nerve growth factors and maintains the myelin sheath, and it decreases the damaged fats like say lipofuscin. So that is useful in the prevention and treatment of free radical diseases like Alzheimer's or Parkinson's. Now, coming to the infantile period, say breast milk magic, everybody knows and everybody understands the importance of this particular very important aspect. If you see the babies who are exclusively breastfed, the interhemispheric connections and intrahemispheric connections, so synaptogenesis is increased multifold because of breast milk. The constituents of breast milk. In the preterms, the breast milk improves the structural connectivity. And it is important to note that even in the preterm babies, the mother milk composition, it changes according to the gestation of the baby. Not that it will remain same like the full term, the constitution of the mother milk is not same for the preterm mother milk and the full term mother milk. So it is ready to take care of the baby's requirements even in the preterm babies also. So most of the times one doesn't need to add any human milk fortifiers or anything for the infant feeding for the preterms. Well, nutrients in the breast milk and the maternal bonding which it creates, it does create a beneficial effects on the IQ. They are rich in LCPUFAs, that is long chain polyunsaturated fatty acids, and the breast milk cholesterol. We are all worried for the cholesterol, but it is important to note that breast milk contains cholesterol of the tune of 100 to 150 milligrams per liter, while the infant formulas, they just contain 0 to 4 milligrams per liter. Now, this cholesterol is very crucial again for myelin synthesis. So coming to some food sources, as we know, vitamin A, dairy products, then the liver, eggs, green leafy vegetables, and deep yellow vegetables. Vitamin D, sunlight, the best source in our country, all the fish, liver, and egg yolk. Then for the all these B vitamins, they play a role in the infant brain development, mind well, all the B vitamins, and their deficiency does cause neurological problems in the child. So mainly the good products are the milk, legumes, whole grains, then some lean meat and fruits. So these are some of the good products for the supply of these vitamins. Sorry. Then for iron, yes, we all know that they enrich grains and cereals. Then the poultry, liver, fish. For iodine, seafood, salt, eggs, cheese. Zinc, we know that the whole grains, peanuts, fortified cereals, they are important. For DHA, the dietary supply is egg, beef, fatty fish, and algae. And for choline, again, peanuts, dark green vegetables, and red meat and eggs. So this is in short. So what we see in the future may be that like beer bars, Dr. Munna Bhai would say the brain bar, which where the pregnant Karina may come for a demand of her brainy nutri cocktail, and which will make her baby as witty as Churchill, or as intelligent as Vishwanath Anand, or as studious as Madame Curie, and as innovative as Edison. So you wait and see for this Brainquilla appearing in the market. Well, so take home message, pay close attention to maternal diet and help encourage the breastfeeding as much as possible. Prefer the foods with lower saturated fats and trans fats. Micronutrient supply must be adequate and sufficient and very timely, and all the vitamins, and they decide what your child should eat. The mother or the family has to decide what the baby must eat. And they must lead by example. It's not that the parents are eating the fast food and they want the baby to eat something which they are not eating by themselves. So that won't happen. And balance the food with physical activity. The last line is very important. The physical activity, we take it as one of the mega nutrients nowadays, not just macronutrient, it is mega nutrient. And point for the obstetrician, of course, they must be practicing even during pregnancy. The mother can work out for 30 minutes a day. So 150 minutes per week. It can be very well done in most of the pregnancies. So of course, you are the better judge. But and that can be done 30 minutes a day. It need not be just continuous. One can break like 10 minutes 3 times in a day. The mother can work out some simple brisk walking, or whatever exercises she is doing, or even sports also, they can continue, most of the mothers, if there are no contraindications. So at the end, to find or to define the optimal nutrition for the brain development is as difficult as finding a perfect husband. Thank you very much.
Thank you, Seetal sir, for the nice and informative lecture. Any question from audience, especially PG students?
Preparations to the newborn apart from the breast milk.
I'm sorry.
Would you recommend any preparations to be advised for the newborn apart from breastfeeding?
Which preparations you?
No, you just mentioned that like say, iron supplementation or iron supplementation.
Yes, yes. For the infant, if you say, so routinely the pediatrician they advise iron from 2 or 3 months onwards. If it is a preterm child, maybe the baby would require the iron earlier also. So that is one thing. Then apart from that, about iodine, if there is a history of say hypothyroidism in the mother, or if there is any thyroid problem in the mother, we immediately assess the baby for the hypo or hypothyroidism mainly in the immediate neonatal period. And we have to make a follow-up, and depending on the reports, especially of the TSH, that is the main guiding principle for the thyroxine therapy. These are 2-3 things. Then about the multivitamin drops and other things, for a full-term child, they are not required.
Vitamin D?
Not required. If you are giving vitamin D for the baby without calcium, if at all any pediatrician wants to give vitamin D, it must always be given with calcium, and that too with calcium phosphate, and that too in a ratio of calcium phosphate 2:1. Why? Because the phosphate is also equally important for the bone development, and especially in the preterms, it may cause a osteopenia of prematurity. If there are plenty of pediatricians, they must be knowing this. And this ratio, maintaining this ratio is important to cause a optimal absorption of the calcium as well as the phosphorus. And vitamin D, if it is given alone without calcium and phosphorus, it will cause what is known as a hungry bone syndrome. The main role of vitamin D is to maintain the blood levels of calcium. So sometimes it may happen if you are giving only vitamin D without giving calcium supplementation. So it may resorb the bone from resorb the calcium from the bones. So that is how the patient may in fact develop a osteopenia, and it may cause problems rather than any benefit. So just giving vitamin D is not sufficient. And most of the calcium preparations in the market, they already contain vitamin D. It is not that they are without vitamin D. So you don't have to give any extra vitamin D for the baby. No, multivitamin drop, they are no more recommended for a normal full-term baby. What you need to supplement is some calcium phosphate preparation. There are plenty of them available in the market. Calcium carbonate can help in the calcium supply, but because there is no phosphate, most of the preparations they are with calcium carbonate in the market. Why? Because the calcium carbonate is the cheapest mineral available in the market. Calcium phosphate is a costly one. So that is why most of the companies, they come out only with calcium carbonate. So it is important from the for the obstetricians also, and for the pediatrician to also see what is the formula, molecular formula, whether it is calcium phosphate, whether it is calcium lactate or something like that. For the adults, it may be if you are giving only, if your intention is to give only calcium, any preparation would do. For pediatrician, it is important that they should give calcium phosphate as much as possible.
Like one quick question. What we learn from obstetrics textbooks that the baby grows at the cost of the mother.
Absolutely.
So if we have a mild or moderate anemic mother,
Yes.
it wouldn't affect the anemic status, iron status of the child. But in your slides, you mentioned that a lot
Yes.
about iron.
Yes. Yes. As I said, it is like Newton's third law of medicine. For every statement in medicine, there is equal and opposite statement. So if I say anything, there would be definitely equal and opposite statement. So, but anyway, you are not losing anything if you are giving iron to the mother, even if you don't find any anemia in the mother, because the requirements are also increased during pregnancy for the iron. So she may not be clinically overtly iron deficient. So there is no reason why she should develop iron toxicity also, because you are not giving only in therapeutic doses or maintenance doses. So even that applies even for the energy and the other macronutrient like say protein, carbohydrate, and fat supplementation for the mother during pregnancy. See, it is mainly our mother-in-laws which force the daughter-in-law to take more and more diet and she eats twice of her requirements, which is not required, obviously, as you know. She just needs to add just some 200-300 calories per day extra, that too from second or the third trimester. First trimester, she doesn't need to add any more calories or proteins to her diet. That you of course must be knowing better than me. But then that is how our mother-in-laws they act. But the good thing about the mother-in-laws is they are following the Indian traditions. So they are usually taking good care of their daughter-in-laws, and they give some good food, which is needed. So twice as healthy food is required during pregnancy, not the twice amount of the pregnancy.
Thank you very much. And I'd like to appreciate your slides. They're wonderful, really. Thank you.
Thank you. Any more questions? Thank you.
Thank you, Sital sir. Now we are going for second lecture. I am going to hand over my Dr. Shah.
Those who are sitting in the hall, everybody knows Dr. Rohini Deshpande. I welcome her. She's a consultant obstetrician and gynecologist in Solapur for last 28 years. Her main interests: imaging in obstetric and gynae, endoscopic surgery for infertility, perinatology, and adolescent medicine. She has contributed a chapter on Doppler in PIH, in hypertensive disorders of pregnancy, and on an overview on operative histoscopy in a book on histoscopy edited by Dr. Osama and Dr. Sushma Deshmukh. She has presented lectures and papers at various conferences at state and national level in Maharashtra, Karnataka, Tamil Nadu, Delhi, and Kerala. She president of AMOGS, that means Association of Maharashtra Obstetric and Gynecological Societies for 2018 to 20. She is past president of Solapur Obstetric and Gynec Society, organizing secretary AICC RCOG West Zone Conference 2014 and 16, organizing secretary of 17th AMOGS Conference 2003 Solapur, other organizational interests, secretary IMLEA 2018-19, secretary of Indian Medical Association Solapur branch, treasurer of Private Hospital Owners Association, editors of newsletter, treasurer, Indian Medical Association Solapur. Her hobbies are, she loves trekking, enjoyed trekking in Himalayas, Annapurna base camp, etc. I think everybody from Maharashtra at least knows Dr. Rohini Deshpande. So I welcome her and I request her to elaborate her lecture on steps towards establishment of good lactation. Dr. Sheetal Gandhi told her what should be done in the antenatal and in neonatal period. And I think now Dr. Rohini will elaborate her on the how to establish it. Dr. Rohini, please.
Respected chairpersons, Dr. Shobha Shah and Dr. Koli, president of our society, Dr. Aboli, and president of IAP, and all distinguished people in the audience as well as viewers. I have been given an opportunity to be with you for this topic of steps towards establishment of good lactation. It's a very basic topic. I must appreciate a very good lecture by Dr. Sheetal. It was very insightful indeed. And now coming back to our basics. Next slide, please. This breastfeeding has always been a very, very dear topic to every obstetrician's heart. And we always make sure that this goes very smoothly. And by the time mother goes home, I think she knows how to deal with the child as well as how to make it successful. This is our Indian thought. But as I mentioned earlier also, that about 5 to 10% or even more than that percentage of women, they really need help. And here we are to actually to understand it in a very better way. Now, this topic has been geared to make all the facilities where women deliver, to make it more baby friendly and mother friendly, as well as to educate them. So we have to start reaching to our masses to make sure that breastfeeding becomes successful, and not only successful, but also it should be a very, very sustained phenomena for at least period of 2 years. Previously, we used to say 6 months, 1 year, but now it is 2 years. And mind you, we have just listened to our lecture by Dr. This Sheetal Gandhi, and he has emphasized the importance of breastfeeding. And let's see how we can do it. Right. So this is the anatomy. It looks complex, but nothing really. You know, the breast mammary glands are very, very unique. And God has been very, very kind to us to have this, you know, to make the reproductive function very, very successful. It has got multiple lobules in it. And these lobules are actually formed by these epithelial cells, which actually secrete the milk. And they are surrounded by myoepithelial cells, and they are connected to ducts. And that is how this mammary gland functions. And it is a complex phenomena that how it works. It looks simple how breast milk comes because nature has been very kind, but it is a unique phenomena. It's actually involves a very, very precise humoral neural mechanisms and interplay of hormones, especially the estrogen and progesterone, which drops after delivery, the placental lactogen, which comes in the foreplay, and the pitocin and oxytocin and prolactin, which actually makes this epithelial glands to secrete more and more of lactalbumin, alpha lactalbumin, which actually gives lactose in this mother's milk. And that is how it becomes very, very acceptable to the baby. And of course, cortisol and insulin are there too as well. There are so many growth factors also involved. And what is important is, as I mentioned earlier, is the intensity and duration of lactation, which is controlled by repetitive stimuli, which is very, very important. And the prolactin is also very essential for this. And the oxytocin is important for the milk laid down. So the expression of the milk is also very important, and that's initiated by suckling. And there comes the importance of skin to skin contact, which is very much emphasized. No other food, mind you, can replace the breast milk because we all know that it is rich in proteins. The colostrum is well known for it, less of lactose and fat, and rich in immunoglobulins, antibodies, minerals, and water too. So it's absolutely a complete food for baby. No need to have any supplementation. It's convenient, cost-free, as compared to these expensive formulas, these feeding bottles, and all this, scenario which is associated with the top feeds. So best of all, it helps mother to also bond with her child, and of course, that actually keeps mother also very fit. And the physical contact is actually soothing to the baby as well. So needless to say. Hence, it is believed to boost the child's intelligence, as we have heard from Sheetal, and the emotional bonding, which takes place between mother and the baby. And in part, it contains several of fatty acids, which contributes to infant's brain. So if you want, he has shown so many slides, where, distinguished people who have really been very successful, like skillful, it all is coming from the breast milk. So it's best to keep the infant on a strict diet of only breast milk for first 6 months, only breast milk for first 6 months. No need to give even water also. And maybe continue it for 2 years as long as possible. That makes the world healthier, smarter, and more balanced. And this has been confirmed by a lot of studies which have come, series of studies from Lancet as well. And it confirms the benefits of breastfeeding in fewer, that is in the form of your ear infections, DI infections, as Dr. Sheetal mentioned, that microbiota, and of course, increased intelligence and probable protection against the adulthood diseases like obesity, type 2 diabetes, hypertension, childhood leukemia, and cancer prevention for women as well and mothers as well. So, you cannot deny all this. So you have to make sure that this important information has to be shared, and we have to act on this. Shared with a lot of your mothers, shared with your colleagues, and this is because it is a far more than a source of nutrition. It promotes the health and well-being of both mother and the baby. So what should be the clinical practices? Because we know that we are into clinical practice. So how do we go about it? How do we make our facility more and more standard so that we achieve our goals? So discuss the importance and management of breastfeeding with pregnant women and their families. Our chief guest, Dr. Yajurvedi, just mentioned that just do a proper clinical examination of the breast and see whether she is prepared for it by doing a simple examination of nipples. Retracted nipple or inverted nipple can cause difficulty. So get her prepared for that. So we have to educate all mothers, facilitate immediate and uninterrupted skin-to-skin contact, and support mothers to initiate breastfeeding as soon as possible within first 60 minutes of birth. In fact, maybe as early as possible. And how do you do that? Nowadays, we practice that as soon as baby is born, if condition of the baby is good, then baby should be put immediately on abdomen. And there is a very unique phenomena, which is called as a baby crawl. Baby will naturally crawl onto the abdomen, and with the smell, as he mentioned, the flavors, it will go to the breast by itself because of the smell. And this phenomena is amazing. So the first hour after birth is called as a golden hour. It's absolutely a golden hour for the baby because of the skin-to-skin contact. So this breast call was described because it occurs when the baby is placed on the birth parents of chest or belly immediately after birth and given time to find parents' nipple and begin to feed on their own. They know how to do it. And this was described in 1987 in Sweden. So you have to capture this moment and start early initiation of breastfeeding. And that's the best start of every newborn. These mothers have to be supported to initiate and maintain breastfeeding at all the times and manage the common difficulties. Not everybody will have just a cakewalk for this breastfeeding. We know that sometimes women are in pain because of episiotomy, because of the pain of cesarean section. They are not able to move immediately, or maybe they are having body ache. And we have to help them on this. Make them comfortable, and maybe sometimes inverted nipples or a cracked nipples, and we have to sort out all these common difficulties that they have. Every facility should make sure that do not provide breastfed newborns any food or fluids other than breast milk unless medically indicated. That's for sure. Enable mothers and their infants to remain together. That's very, very important. After baby is born, do not actually separate the baby from mother. Let her hold. Let parents hold the baby. Let that baby be kept by the side of mother. That's why make the beds, which are recovery beds, they're a little wider so that baby can be comfortably kept, not in a cradle, not with the other relatives, not with the mother-in-law, not with mother, but own mother. That's very, very important. And that practice of rooming in for 24 hours has to be addressed to. Support mothers to recognize and respond to the infant's cues for feeding. Let her recognize when my baby is going to be hungry. She has to be watchful. She has to understand how baby is getting hungry and baby wants feed. So as far as possible, it should be a natural phenomenon. Counsel mothers on use and risk of feeding bottles. If she asks for it, teats and pacifier. We know that sometimes nurses are busy, or I have even seen, with all due respect, in NICUs as well, they are given pacifiers. That has to be really, really, taken, with a bit of pinch. And, that has to be avoided at any cost. Coordinate discharge so that parents and their infants have timely access on ongoing support and care. That's very important. Before she goes home, just, when you say goodbye to her, just ask her, how is her breastfeeding going on? That makes a lot of difference. If she has any problem, she will tell you and you will rectify it. Otherwise, she will come back after 8 days, Madam, mala doodh yet nahi hai. Madam, माझा nipple crack झालेत. It is very sore. So you have to rectify before she goes home. So these are all simple steps. They are narrated by WHO and UNICEF as 10 steps to successful breastfeeding. And we all have to remember, and this poster should not only be there, but that has to be educated to our staff, to mothers and ourselves. Very important. And this is what the message that I want to give today. Maybe it is a simple message, but very important. So what's the outcome of implementing these 10 steps? There is a substantial evidence that implementing the 10 steps significantly improves breastfeeding rate. No doubt about that. A systemic review of 58 studies on maternity and newborn care published in 2016 demonstrated clearly that adherence to these 10 steps impacts early initiation of breastfeeding immediately after birth, and exclusive breastfeeding and total duration of breastfeeding as well. So though they feed for a longer period of time. So the key message and points to take home are: almost every mother can breastfeed successfully. All mothers, particularly those who might lack confidence to breastfeed, need the encouragement and practical support of baby's father and their families, friends and relatives. Health workers, community workers, women's organizations, employers can also provide support. I just want to make a mention here. Way back, I remember that, when I was working in postnatal period, I resumed the work, but there was an entity called as a nursing break. No, that has to be followed. And even today, there is a sort of a notification which comes that those women who are working, those who go back to work, they should be given enough time to nurse the child. You cannot deny her right to breastfeed. You have to make sure as an employer that she's given this. And if not, fight for your rights. So what is the innovation in this? Antenatal hand expression of breast milk. This is something which I really love. If you are suspecting that this patient is going to have a preterm labor, if you feel that she's going to have some storm in her postnatal period, if you feel that I'm going to induce her prematurely, if I feel that I'm anticipating that baby will go to NICU, if I feel or if I notice that she has become critical, so she cannot breastfeed the child. So what is an alternative? Every mother can be given a choice of hand hair expression of breast milk in antenatal period, in later half of pregnancy, towards the term or towards whatever you anticipation. She can hand express, and mind you, I have seen myself that enough quantity of cholesterol can come out. She can do it on a timely basis over the period of 24 hours. And this milk can be stored for 24 hours and frozen for 6 months. So any difficulty is there, instead of supplementing with the formula milk, you can always give antenatally expressed breast milk. The syringes can be of food grade quality. They can be topped with it, kept in a freeze or a freezer. And why might it be useful to express milk while pregnant? So many reasons. One thing is you can use this skill after birth. So she becomes more proficient in that. In case baby goes to NICU, still baby will get colostoms. Still you can avoid formula milk. If breastfeeding becomes challenging, you can still give baby colostrum. It can be stored, as I said, for 6 months in freezer. It lowers the chances of giving formula milk to the baby if it is necessary. So it can also be useful if mother gets some complications of breastfeeding like mastitis or any other problems. So if you are getting induced, it might also help, to get her induced in an easy way. So is the importance of breastfeeding. So we cannot really, it is not that we have to take it with all the understanding. I welcome Dr. Mangala. She's here. I appreciate she's a lactation consultant. Very nice to see you here. So I cannot actually forget this child. You can see here that he's a 13-year-old boy. Little short, looks smart, has got big glasses, thick ones, and cheerful mother there. She was a lady at 27 weeks of pregnancy, had a gestational diabetes, severe polyhydramnias. She went into preterm labor and she delivered a 900 grams baby, this boy, and wanted to save the baby in all possible ways. And she could not breastfeed this child because baby has gone for NICU. She was elderly, she was diabetic. So what was the solution? After some time, her dad, he knew the importance of breast milk. So what he did, he went from mother to mother asking for breast milk, those who were in the ward, and they were very kind enough to donate their blood. They were all tested. So at that time, or even now, I'm very sorry to say that we do not have a milk bank, which I appeal to all the people to, get it started. And he was going door to door to collect that breast milk. And mind you, this boy actually has thrived on this breast milk from so many mothers. So is the importance. And he had a very, very, it took some time in NICU, but still he recovered without major, and it was quite an intact survival for him. So hats off to mother as well as family who supported her, and also the pediatrician. I must say that they allowed this breastfeeding to incorporate in his program of NICU. So thank you very much, ladies and gentlemen, for your patient hearing. Thank you so much.
Madam, the last one slide you mentioned about antenatal expression of the milk.
Yeah.
Yes.
And the last slide you also mentioned that it would help if you are inducing the
Yes.
labor.
Yes. Oxytocin, she mentioned.
Yeah.
Little.
So as an obstetrician, I would be concerned having oxytocin when I want to continue the pregnancy.
Yeah,
Your
but
take
it
on
is
this?
in a later part, like later part of pregnancy where it is nearing term and all that. So it comes in a very minimal quantity. So it is less likely that it will really induce the patient, but it will just aid the process of induction. That is what I meant.
No, my apprehension as an obstetrician would be,
Yeah, I know.
would that induce labor in my patient?
No,
where I don't want to?
not much really. And I think this is one practice that we can really incorporate into our clinical practice. It's not going to, it would be a matter of study, maybe, that to see whether women will really go into labor or not. But very few, the reports have been there that it will really induce. It will smoothen that process of induction. That's all.
Yeah, I can just say something. Actually, this is still under research. This is not something to be done routinely. And it is for the high risk cases, for example, the diabetic patient, where she is going to have a delayed lactation. So in such cases only it is advised. And it is only still few hospitals it has been recommended. We don't do that routinely.
Actually, this is a
correct.
new concept.
It is a
Yeah.
concept.
No, it is not a concept. I just want to say a few words. This is a notification which has been given in Cambridge Hospital, which actually I got it from my daughter because I told her, anything new that you are doing there. So she said that this is what women are doing at the moment. And as you said, it is not rampantly being practiced. So we don't know yet how it will catch up, but it is just a food for thought. Thank you.
Any more questions?
Yes.
Yes.
You said rooming in. I would say bedding in for the baby.
Yes.
Why only in the room? Let it be in the bed immediately.
Yes, yes, surely.
Yes.
What she means that wedding is termed as rooming in.
Yes.
Yes, ma'am. Thank you for delivering such wonderful lecture, ma'am. I have
Thank
one
you.
question. What I have observed or what I am getting in the last 10 years, there is an increased use of infant milk formula in our practice.
Yes.
So what are the reasons or how we can deal such infant milk formula so that we can avoid using the infant milk
Very,
formula?
very good question,
question.
I must say, because this is what often we actually see in our clinical practice. Like we do our best to make mother confident in feeding the baby. But as soon as she goes home or maybe a week after, they usually have this, sort of a questions that I don't get enough milk. That is one thing. Secondly, there are a lot of women surrounding her who are probably saying always giving some negative thoughts to mother, like tula doodh yet nahi hai, baal radte hai. These negative stimuli are also not very important. Everybody has to be more positive. And thirdly, if they get engorged breast or if they have some nipple problem, which also is a very common phenomena, they should come back immediately so that we can give them solutions. And I know that, even in inflamed breast, even in breast abscesses, we have still continued breastfeeding the baby from the other side, which is normal, and treat it, in a least invasive way so that, we give her a very less painful period of that kind of a problem. And inverted nipple, and as sir said, we must examine it so that when they go home and all that, they don't complain of this thing. And thirdly, we must also tell them they are doing sometimes very hot fermentation, some practice, when the breast become very painful. On day 6, day 7, they get a lot of milk. So we have to tell them to hand express it as the first thing and give them ice packs instead of hot fermentation. I know in a woman, they have put so much of a hot fermentation, it has necrosed the skin of the breast. And it has taken ages to heal that process. So these kind of things should not happen. And this is how it fails. And it, of course, needs patience. It needs patience. There is no doubt about that. And we all have to, be in a team to encourage mothers. Thank you. Thank you, Chairperson.
Thank you, madam.
Thank you very much, Dr. Rohini. She has elaborated very nicely the golden hour,
Hello.
as well as rooming and bedding in, then the importance of lactation to mother as well as baby. Once again, I'm very much thankful
Hello, just
to
one
Dr.
minute.
Rohini. Any more
One
questions? Yes.
Regarding the Dr. Anna's question, why infant formulas are more used in NICUs? I think even in the LSCS mothers or even in the NICUs also.
Actually, you have taken this question and we must discuss this also.
Yes, of course, of course. No,
Yeah.
this is a big problem, and this is ever since I started my NICU, and the problem mainly, and my request to all the obstetricians, because they are here now, is to send the mother as early as possible.
Of course, we do that.
That is the
Yes.
that you may be doing, but we
Or maybe transfer mother in utero itself.
transfer the mother
in
after the
utero.
delivery, because what the problem we faced as neonatologists is the not getting the mothers from the obstetrician, because he doesn't discharge the mother for
So
the
there
10
has
days,
to
8
be,
10 days.
yes.
So, and the transportation of milk practically is not possible.
See,
So
as you
earliest
rightly
required,
said,
the
this
infant
kind of a thing.
formula, the pediatrician is compelled to use the formulas, not that the pediatrician wants to use the formula.
See, often we also get, with maybe all due respect, that we also get some feedback from mothers themselves, like when we send a mother breast milk to the concerned hospital, suppose she has delivered in my hospital and she has gone to Ashwini hospital, let's say, for a practical purpose. Then we try and get the containers from them for the breast milk and we send it. Then after some time, she's telling me that this milk is not used, madam. This should not happen.
This should not happen. That
This
is what
should
I'm
not
saying.
happen. There has to be a good communication.
Even the practice of getting the containers and giving the containers, it must be condemned at all the costs.
Yes,
because
so
there
we
is a
can
risk
do
of
that, na?
contamination at every step.
No,
So,
we can also do that. We can give them sterile bits and pieces, like we are also aware of it. That is what I mean to say. Why they should get a container from NSU? We might as well supply them.
Yeah, instead of supplying
so
the
that should be
containers, you
accepted.
supply
That
the
should
mother
be
only.
accepted.
That is my request to you is this:
Yeah.
transfer the mother only.
Of course,
Or
we
send
will
the
do
mother
that, but
only
sometimes
as
it is
early
not
as
possible.
possible.
And good communication
many
and
times
rapport has to be there
The
between
mother doesn't have any problem. Even for normal delivery or even after
Yeah.
seizure nowadays, the mother is usually discharged on day 3 or so. So there should not be any problem, and the obstetric consultant can come and see the mother
Yes,
in the
yes.
pediatrician's hospital.
No
That
problem.
is also possible.
Yeah, we have to have a good
Which is a better
communication.
policy
Yes,
rather
yes.
than keeping the mother with the obstetrician and the baby
No,
with the
no, no.
pediatrician.
Of course not. I agree fully. Thank you. Let's be having a more friendlier at all the levels.
Ma'am, I have a doubt. In bigger hospitals, in the bigger cities such as Mumbai and Pune, where I had worked for a few time, there is a specialized post called as lactation consultant or lactational consultant. So we might not have in a city like Sholapur, but what can we do to provide such kind of a support to the mothers?
Yes,
or
this is
anything?
why we are here today. Like we have to get ourselves geared up, because everywhere Mangalwani may not be there. But we ourselves have get tuned to it. We have to conduct for our staff programs, or every now and then if there is a difficulty, we have to sort it out. So best thing is to get yourself educated at this level. I think for each and every facility, a concerned person and a practitioner should be well versed with it. In fact, WHO and UNICEF, they have come out with a video where they are training people, at all the levels, including doctors, with all due respect to doctors.
Any more?
In the phase of successful lactation, I think the existence of retracted nipple should go straight up. We have time 9 months and 9 days to take care of them, and that will go a long way in protecting the baby and the good baby's health.
Yes, surely.
There is additional problem of big size nipple also, which comes later on. But first problem is of inverted nipples. And there, I would say the husband is of great help to the mother.
Yes.
And he can very well see to it that the nipples become protracted and though not at all retracted. And secondly, I personally feel that there should be one lecture in the last trimester of pregnancy from neonatologist or a pediatrician regarding the need and importance of successful
Yes,
lactation.
educational programs are very well.
And that will go again a long way, and where obstetrician also is there, so that the questionnaire from either side can be very frankly dealt with.
Yes, absolutely right. As he asked, sometimes the small nipples, large nipples, big breast, these are all concerns, but they all can be sorted out with different positioning, latching of a baby in a correct way. This all can be taught to the mothers.
Madam, I have a maybe a small question. Madam, I have a patient now. She's COVID positive. She's delivered. The baby has been taken by the relatives back to Latur. Now she's day 4. She started little bit of milk secretion. Her both the breasts have got congested. Now what should I do? I cannot even suppress that milk, because later when she goes back home, she has to feed the baby. And now if I express the milk and throw it off, this means she'll start.
She's why she's here? You said
she's COVID positive.
COVID positive. Okay. If she's
So
COVID positive, let her do the hand expression till the time that she becomes negative, and later on this phenomena will continue. It will stimulate the breast milk and it will sustain it also. Only thing, it is a matter of waiting for some time.
Can we use capvolin for some time?
No.
Capvolin,
Once you give capvolin, it will going to inhibit the lactation. Yeah. Don't give it.
So better not.
Ask her to hand expression. Yeah, that's fine.
Very nice discussion. And 2 important things. One is antenatal hand expression, this notification. And second is about the milk bank. These 2 things we can keep in mind. And once again, thank you very much, Dr. Rohini.
Now we are going for our third lecture, Kangaroo Mother Care by Dr. Poonam Thakur. She is Assistant Professor in Pediatric Department of Dr. VM Medical College. She has completed her post-graduation from Government Medical College, Nagpur. She was former intensivist at Nelson Mother and Child Hospital, Nagpur. Conducted basic ventilation workshop at Pedicon, Nagpur 2018. Speaker on National Resuscitation at International Pediatric Critical Care Chapter, Nagpur, organized by IAP, Nagpur 2017. I request Dr. Poonam Thakur to start lecture.
Good morning, dignitaries. I'm Dr. Poonam Thakur, and today's my topic is on kangaroo mother care. So this is my roadmap of my talk. Why is it called as kangaroo mother care? Definition and benefits of KMC, components and duration of KMC, who can provide KMC, which infant should receive KMC, KMC position and various methods, monitoring and feeding during KMC, requirements for implementing KMC, when should KMC be discontinued, and don'ts of KMC. So first is, why do we call it as kangaroo mother care? Why kangaroo is selected? That's because the baby kangaroo is called as Joe and it is delivered very prematurely. So the mother kangaroo keeps the baby kangaroo in the pouch and provides some warmth, safety and constant milk supply to the Joe. So therefore, the similar technique has been applied in the human beings. So that's why we have this as similar. That's why the name kangaroo mother care has been given to low birth weight infants, so as to take the benefit. Backs. Yeah, this is the one. So reasons why KMC was implemented. It was first implemented in the year 1979 by Dr. Edgar Ray and Hector, worked in Bogota, Colombia. Circumstances at the hospital where they worked had large number of low birth weight and preterm infants delivered because of poor antenatal care attendance, high incidence of toxemia of pregnancy, anemia and infection, shortage of staff and inadequate equipments. There was high infection and mortality rate because of the overcrowding. Large number of infants who were abandoned by their mothers. So that's why they had introduced this technique of KMC. So in India, KMC was first introduced in the year 1994 in BJ Medical College and Government Hospital at Ahmedabad. This was followed by experiences in the KEM Hospital, Mumbai and at AIMS, Delhi. So what is the definition of kangaroo mother care? Kangaroo mother care is a simple method of care for the low birth weight infants that include early and prolonged skin-to-skin contact with the mother or a substitute caregiver and exclusive and frequent breastfeeding. KMC is of low resource, evidence-based, high-impact intervention and standardized care for low birth weight infant, which like breastfeeding should be a part of routine care. So it can prevent up to half of all deaths in the infant weighing less than 2 kg. WHO guidelines recommend KMC for all the stable babies who are less than 37 weeks of gestation and weighing less than 2 kg. So baby weighing between 2 to 2.5 kg can also take up the benefit of KMC if the mother and the baby both are comfortable. So what are the benefits of KMC? So it like stabilizes the body temperature, promotes breastfeeding, creates a good bond between the mother and the baby, prevents infection and other morbidities, leads to early discharge of the newborn, better neurodevelopment and encourages bond between the mother and the infant. KMC is initiated in the hospital and continued in the home until the infant needs it, and for optimum care of a regular follow-up must be ensured. Preterm infant mortality can be reduced by half by the near continuous application of KMC. So these are again the benefits of the KMC to the baby. That's warmth 24 hours, reduces the infection, multimodal stimulation, quiet sleep, reduces the apnea of prematurity and the oxygen requirement, early growth spurt, better IQ and physiological stability. Now, what are the benefits to the mother? The mother can be more confident in caring her infant in caring her infant, improved bonding between the mother and the infant due to physical closeness between them. Mothers are empowered to play an active role in the infant care, and mothers are enabled to become the primary caregivers to the infant, and breastfeeding is promoted. Now, benefits to the nation. KMC decreases the neonatal and the infant maternal mortality and morbidity. KMC is simple, easily applicable, and cost effective. KMC results in healthier and more intelligent baby. And benefits to the hospital: significant cost saving as well as better outcomes, less dependence on incubators, less nursing staff necessary, shorter hospital stay, improved morale and quality of care, and better survival of the baby. It has three components. That's one is the skin to skin contact, at least 20 hours in each 24-hour period. That's 20 hours in one day is an ideal method of providing KMC care to the baby. Exclusively breastfeeding and close monitoring of the illness. Contraindications for the kangaroo mother care. The most important contraindication is hemodynamic instability of the baby. If the babies are hemodynamically unstable, you can't provide KMC to the babies. But hemodynamically instability means hypothermia, any hypotension or hypertension, if there is bradycardia, recurrent apneas, and the saturation dipping less than 85%, such babies are contraindicated for KMC care. Initiation of KMC. Babies should be stable, as I have already told. And also some babies who are admitted to NICU and are on IV fluid, oxygen therapy, orogastric tube feeding, such babies can also be given KMC for a brief period, so as to encourage the mother, which will improve her breast milk secretion. Duration of KMC. The minimum duration of a KMC session should be 1 hour, because frequent handling may be stressful to the infant. Duration of each KMC session should be gradually increased for as long as the mother is comfortable to provide KMC. The infant in KMC need to be removed from skin to skin contact only for changing of the diaper and clinical assessment according to the hospital schedules till the baby is in the hospital. So the duration is divided into the following. That's a short KMC, which is for 4 hours daily. Extended, that's 5 to 8 hours daily. Long KMC, 9 to 12 hours daily, and continues more than 12 hours daily. Documented on 2 consecutive days or more prior to the discharge. Duration to be counted as cumulative completed hours within 24 hours period. Again, the same thing. Types of KMC, that's continuous KMC. It is the KMC that is given continually both day and night. KMC can be discontinued for a very short period when the mother goes to bath or attends her personal needs. It can be practiced in the hospital or when doing KMC at home. It should always be used where there are no incubators. It requires support from the family members, including the husband. It is ideal type of KMC for LBW babies. What is the maximum time KMC can be done? The maximum benefits of KMC breaks should be limited to less than 30 minutes. Okay, now who can provide KMC? Mother, father, grandparents, and any other adult member of the family who wishes to participate or take care of the child can go for KMC care. But make sure before you go for KMC care, the KMC provider or the participant should be infection-free, should maintain strict hygiene like hand washing, daily bathing, clipped fingernails. There should not be any jewelry in the neck, and all those things should be taken care of. Now, how many staff members are required to supply mother practicing of KMC? For a baby's basic KMC area, assume 1 nurse or equivalent staff for 8 to 10 beds. If the KMC area includes continuous positive airway pressure, phototherapy or palliative area, assume at least 2 nurses for 8 to 10 beds. At least 1 staff member should be present all the time to supervise the mother. These ratios should be modified according to the hospital policies and resources. Which infant should be provided KMC? As it's always told, birth weight less than 1.2 kg, birth weight more than 1.2 kg but less than 1.8 kg, birth weight more than 1.8 and less than 2.5, and the baby should be hemodynamically stable. Birth weight more than 1.8 kg and less than 2 kg. These infants are generally stable at birth. Therefore, in most such cases, KMC can be initiated soon after the birth in the postnatal ward. The neonate weighing less than 2 kg should be accorded priority for initiation of KMC, considering huge burden of LBW infants in our country. Birth weight more than 1.2 kg and less than 1.8 kg, many infant group have significant problems in this neonatal period. It may take a few days for KMC to be initiated. So such infant are initially admitted in the NICU, and then later on, once they are hemodynamically stable, the mother can be encouraged for the KMC care. Eligibility criteria, again, it's the same. Birth weight more than 1.8 kg, start at birth if the baby is hemodynamically stable. 1.2 to 1.8 kg birth weight, hemodynamically stable. It may take few days, but then once the baby is stable, you can provide KMC care to the mother. Less than 1.2 kg, most of the babies go into NICU. But if the baby is little stable, still on oxygen or IV fluids, in that case scenario also, you can provide KMC to the baby. Okay, KMC is effective. Why is it not widely practiced? It's because of the misconception, skepticism, fear, and cultural factor. Most of the people incorrectly believe saving as soon as the preterm is born, they have to be admitted in the NICU, irrespective of the requirement. So the relative themselves are so keen and so much apprehensive about the baby, since they are all precious babies nowadays. Hardly we have 2 kids. So they insist on NICU admission, and that's where we are lagging behind, and we can't, most of them are not aware of this kangaroo mother care, as they're not aware about the benefits of this kangaroo mother care. And skepticism, most of the family fear of caring the small fragile babies themselves. So that's why KMC is not that widely practiced. And the nursing staff also who are there, they're not much trained. Let it be in the government sector or private sector, they're not much trained with the KMC care. So that is also one lagging point where, because of which KMC is not widely practiced. Preparing for KMC, counseling, demonstrate the procedure, ensure full support to the family and KMC support group. Mother's clothing, there should be front open, light dress as per the culture, local culture. And baby's clothing, cap can be there, socks, nappy, front open sleeves, shirt, or the jhabla, what we say in the local language. So this is the KMC position, wherein the baby should be held in upright position with head turned to either of the side. Make sure the nose is not compressed and the baby is able to breathe comfortably. The thighs of the baby should be on the lower edge of the breast. It should be in that frog-like position. And okay, this is the baby's position. Now coming on to the mother's position, the mother first should have a comfortable backrest. She should be elevated to an angle of 40 to 45 degrees, wherein she should be very comfortable to hold her baby in the upright position and to carry out KMC for long hours. These are the various clothings, how you can carry the baby. Now coming on to monitoring the infant. Infant receiving KMC should be monitored carefully, especially during the initial stages, to ensure the airway is clear, breathing is regular, the color of the baby is pink, and he or she is maintaining the temperature. All the above clinical observation and duration of KMC should be duly recorded in the newborn case sheet being used in the unit. Mother should be trained to observe her infant for danger signs like hypothermia, respiratory problems, feeding difficulty, change in the color, so that she can continue monitoring at home. Feeding during KMC. Feeding and nutrition strategies during the postnatal period are very important for ensuring optimal growth and development of LBW infants. The nutritional needs of the infants with similar birth weight may vary depending upon whether the baby is appropriate for gestational age or small for gestational age. Initially, breastfeeding is fixed at a fixed interval of 2 hours and not on demand. To ensure adequate and assured minimal intake, the mother should be explained how to breastfeed while the infant is in KMC position. Holding the infant near the breast stimulates the milk production. She may express the milk while the infant is still in the KMC position. What is required for implementing a KMC? Even though KMC is simple, it needs to be initiated at the hospital under a skilled supervision. So this is most important prerequisite. The mother needs guidance by healthcare profession to provide KMC and optimally breastfeed the LBW infant, starting at the facility and continuing on her own at home. Once the mother goes home, it is important that that she should continue KMC. Community healthcare workers like ASHA, ANM, AWW should ensure that the mother continues to give KMC at home. It is equally important that they should facilitate follow-up visits to the facility for review and problem solving, as this support is crucial for the infant's health after discharge. What all the things are required? Infrastructure, a dedicated space near the special neonatal care unit or the postnatal ward wherein the mother can comfortably provide KMC to the baby. Human resources, the availability of adequate number of trained and willing healthcare professionals who are available 24/7 in the hospital and encourage KMC practice to the mother who have given birth to LBW babies. Information, education, and communication, IEC material, including the video films on KMC in local language for the mother, family, and the community. Counseling of the mother, father, relatives by service provider is catalytic in ensuring KMC practices during their stay at the hospital and after discharge so that they continue to practice KMC till the infant requires it. Community awareness activities should be conducted to maximize the benefits of KMC. A supportive family is very essential for prerequisite for successful KMC. Now, securing the infant, these are the different garments in which you can hold the infant, a tube shape, the tying ones, and a t-shirt, wherein you can keep the baby in upright position between the breast and ensure maximum KMC has been given. Now, the discharge criteria is well with no evidence of infection, feeding well, gaining good weight, maintaining the body temperature, and mother is most important is mother being confident of taking care and ensure counsel them they have to come back for follow-up visits. When should KMC be discontinued? Once the infant is taken off KMC, when the gestation age reaches the term or when the weight is around 2.5 kg, you can discontinue the KMC. By this time, the infant starts wriggling to show that he or she is uncomfortable, pulls out the limbs from the kangaroo garment and cries and fusses every time to the mother, tries to put the infant back in the skin-to-skin contact. This is the time to wean off from KMC. And don'ts of KMC: do not bathe the baby till the baby weighs 2.5 kg. Sponging is enough. Do not frequently handling of the baby is not advised. Do not give bottle feeds. Do not allow the infants to be in contact with sick people. Now, the take-home message: KMC is evidence-based, cost-effective intervention, which when upscaled and implemented across all facilities can save up to 500,000 of newborns. WHO guideline recommend KMC for all stable babies born less than 37 weeks of age and weighing less than 2 kg. Despite the KMC network having been established in India in 1990s, this simple technique is still not being practiced universally across the country. Clear idea to service providers on what exactly KMC and how KMC techniques can be implemented when caring for the low birth weight. That's all. Thank you.
Thank you, Poona Madam. Any queries from audience?
Very nicely talked about this KMC.
Thank you.
But I just wonder, like, whether we are practicing here practically, or you mentioned that it is not widely practiced. So
yes,
what are the
madam.
reasons?
Ma'am, most of them are not aware of it. Like the ASHA worker and the ANMs, what we send from, we monitor the pregnant ladies, the newborns. As we encourage immunization and breastfeeding to everybody, we have not encouraged much about KMC care, ma'am. And since the babies are very small, they're quite apprehensive and they're quite spectral to handle the baby. And that's why I think it has not been practiced most widely. And there are no trained, skilled nursing staff for that KMC, since it's a new entity. So it's still lagging. That could be one reason.
So we will be waiting for a change.
Yeah.
To be transferred from if the delivery occurs at villages, and babies need to be transferred at hospital for the neonatal care. This is a good method of
Yes.
transferring the baby while mother is also transported in the same vehicle and giving conquer mother care.
Yes,
Because
ma'am.
many
Because at
vehicles
least
don't
the
have-
temperature of the baby can be maintained and apneas can be prevented, madam. When the mother breathes, that gives a stimulation to the preterm, and apnea of prematurity can be prevented. This can serve as a good transport method from a rural place till they reach a desired hospital.
In one of your slides, you mentioned should not be giving the on-demand feed. Is it only because of their low birth weight that timely feeding is given and not on demand, or any other reason?
Sir, low birth weight, sir. What I feel, it should be a low birth weight. So we can't wait up to the demand, because preterms hardly demand, sir. They are too small and they hardly demand. So every 2 hourly, once the baby pass urine, you can give the feed to the baby. This is what I feel.
Make it semi-demand for that matter.
Yeah.
If demanded, this one. If not demanded, maximally you can give a gap of 4 hours.
4 hours, yes, sir.
For information of Rohini madam and others who have been practicing this in Ashwini Hospital, for those babies who do not require intensive monitoring, so the mothers are shifted to the side room where, I mean, there is a special room for the mothers whose babies are there in NICU, and in that room we practice this kangaroo mother care. Thank you.
Yes.
We have been practicing kangaroo care, but I personally feel that the mother has to be really educated.
Yes, sir.
If she principally agrees, and that
Yes.
will be done in the obstetric wards in the first trimester, in which case we can always tell her the importance of successful lactation. So also the warming the baby and
Yes, sir.
nothing.
And also the nursing staff also have to be aware
sure.
about the KMC
Follow.
technique and
Right.
encourage the mother, sir.
Agreed. And once we
Uh-huh.
educate the mother, she will happily do that.
Yes, sir.
Otherwise, also those who are educated are very keen in handling the baby and seeing
Babies.
the baby in her own nap.
Actually, you brought out a very valid point. Most of the mothers, they believe still
Yes,
that
sir.
baby should not be clothed.
Yes.
And that has to be really, they have to be educated, because kangaroo, the babies are well protected by the
Yes,
clothes
ma'am.
as well, the
Yes,
woolen
ma'am.
caps and all this. So our mothers, they need to be told. They think that they have some new clothes for the baby.
Yes,
this,
ma'am.
that, you know, and the babies actually, they are covering themselves, but the baby is lying naked
Yes, ma'am.
and getting hypothermia.
With just a cloth wrapped around the body.
Or even
Yes, ma'am.
openly
So that's
exposed.
more, they are more going for hypothermia, especially in winter seasons.
Yes.
So that should not be encouraged.
Such practices have to be, we have to change the attitudes.
That's why this same is.
Yes.
Thank you.
Thank you, Poonam madam.
We have come to the end of our first session. We have timely brushed through KMC, baby crawl, and baby nutrition. Now let's go ahead with faculty felicitation. May I call upon the chairpersons to felicitate all the speakers. First, I would like Shobha Shah madam to felicitate Rohini Deshpande madam. Yeah. Na. I request Kori sir to felicitate Sheetal Gandhi sir. And I again request Shobha Shah madam to felicitate Dr. Poonam Zada. Dr. Poonam. A small token of appreciation for our chairpersons too. I request Aboli madam to please felicitate Shobha Shah madam. And Varsha Kirpeka Madam to please felicitate Korisa. Here we come to the end of our first session. Now we'll be starting with the second session. The chairpersons may please take their seats. For the second session, our chairpersons are Dr. Usha Dindore Madam. She has finished her DCH from Nanded and has done her DNB from Pune. Our second chairperson for today's second session will be joining online, Dr. Vijay Pawar sir. He is very well known to us. He's an obstetrician gynecologist practicing at Civil Hospital. The second session will have topics on challenges in breastfeeding, human milk bank, vaccination, and National Mission Health Program for Mother and Child. Over to you, chairpersons.
Good morning, all. This is Dr. Vijay Pawar. I'll be joining online on this session. Am I audible to all of you?
Pawar sir, can you please
Yeah, I'm
join?
audible? Yeah, I have joined.
We're not able to see you.
Yeah, I am there on the screen. Yeah.
We can see and hear you, sir.
Yeah, thank you so much. Yeah. So thank you for
we can hear you now.
allowing me to join this CME online since it is hybrid CME. So one of the chairperson is offline and one is online. So it is actually really a hybrid CME. So at the onset, I would like to thank the organizer for allowing me to join this CME as a chairperson. First, today's speaker I am going to introduce. We all know Dr. Mangala Vani. So it's an honor to introduce her. She's been coming to Solapur quite frequently, and we have attended her previous workshops on breastfeeding also. So we all know about her, but to start, she's the director of Hirkani Gynecology and Breastfeeding Medicine Clinic, Pune. She's a lactational consultant. I think Solapur also needs one lactational consultant. So it's another upcoming branch that I think many of us can join or try to join it. She was the treasurer of MSR ISAR chapter 14-16. She is a course director of lactational training for from BPNI Maharashtra 2021, and she has also got the Young Scientist Award at the 5th World Congress on Endometriosis. A lot of her big list of her awards. So I think I will invite Dr. Mangalavani to start her talk on challenges in breastfeeding. Thank you.
Thank you for the kind words, Dr. Pawar sir. It's really hybrid, huh? One chairperson direct and one chairperson on the Zoom. And thank you so much, the Solapur OBGY Society and Pediatric Society. for this CME, because breastfeeding awareness is not that much still in India, and we don't see many people enthusiastic organizing, CMEs on the breastfeeding. And Solapur is close to my heart. I mean, I am from VM Medical College, and I am from Solapur. My mother and sister still here, so I always look some reason to come here. So as soon as Aboli called me, I said yes. Actually, I have missed Rohini's lecture, so I'm not sure whether I will be repeating something. But anyway, if there is something repetition, you can just raise the hand and tell me that you go ahead. So I'm not seeing here the presentation. Somewhere? Okay. Okay. So if breastfeeding is not new for our Indian culture, for thousands and thousands of years, our women are supposed to be breastfeeding. It is mentioned in the Vedas, in the Atharva Veda, in the Charak Veda, and it says the qualities of the milk, the sweetness of the milk, the goodness of the milk. And not only that, the longevity, the long term also, it is good for the baby. So, and that is what is the science is now proving. Now, this is a beautiful statue found in the metropolitan city of New York, and it dates from 12th century in the Chola period. So it just says that the importance was there even those days. So this is just, we are finishing the World Breastfeeding Week. In fact, we finished yesterday, the 1st to 7th week of August, to increase the awareness of the breastfeeding and to tell people the importance of the breastfeeding. And it is commemorates the Innocenti Declaration signed in August 1990 by government policymakers, WHO, UNICEF, and other organizations to protect, promote, and support the breastfeeding. So if you see the importance of breastfeeding, the first is the building brains, and I think first lecture was on that. So nutrition in first 1000 days provides the building blocks for the brain development. The baby's IQ is higher. The building health, because not now, even in the future, and in the beginning also, because the colostrum has so many qualities. It gives the immunity to the baby. And building a fair start, nourishing a strong start for all the children. And prosperity. Why prosperity? Because the brain development is good. So those babies do better performance in the schools and colleges, and they have a better jobs in the future. And you see the figures, more than 10 lakhs plus new brain connections per second in first year of child's life. So you can imagine how rapidly the baby's brain growth is happening in the first 1000 days. And more than 820,000 lives of young children can be saved just by proper breastfeeding. And if we invest $1 in breastfeeding support, we get $35. In no other investment, we get the returns like this. And this is a beautiful study published in Lancet in 2013. And it says the preventive interventions to for the under 5, to prevent the under 5 child deaths. And you see the yellow line, that is the longest, and that is the breastfeeding. 13% of under 5 deaths can be just prevented by proper breastfeeding. And the red line is the complementary feeding. And another 7% under 5 child deaths can be prevented by appropriate complementary feeding. Complementary feeding is the subjects that is another neglected very much. In India, recent survey shows that only 8.9% of the children in India get proper complementary feeding, whether the child is rich or poor. That means it is not that we can't afford it. It is just we are not aware what is the right complementary food. So 20% of the under 5 child death can be prevented only by proper nutrition. So we know the breast milk has loads of constituents. Still the research is going on, and still we find new and new. And compared to formula, who has a very few things in it. So breastfeeding is a human right that needs to be respected, protected, and fulfilled. So despite the compelling scientific evidence, political commitment to and the financial investment in breastfeeding is very, very low. Now, these are the recommendations. So initiation within 1 hour, exclusive breastfeeding for first 6 months, and after 6 months with the proper complementary feeding, continuation of the breastfeeding at least till baby's second birthday. So at least is underlined, means at least 2 years. The breastfeeding is recommended by World Health Organization and by UNICEF. And converse and communicate while breastfeeding to enhance the physical and emotional growth of the baby. So the anthropologists have previously speculated that the natural age of weaning is between 2.5 to 7 years. And fossilized teeth reveals early humans breastfed for around 6 years. So 6 years is the norm those days. That is what the science proves. But nowadays, as soon as the child starts eating, we think breastfeeding should be stopped. There are so many benefits, and the longer the breastfeeding is given, the more the benefits. And that is why nowadays the Westerners has taken it so seriously. And we see 4 years, 5 years now, a lot of women, they are breastfeeding there. What is the Indian scenario? Initiation happens within 1 hour only in 51%, means one baby in 2 babies. And exclusive breastfeeding up to 6 months is only 61%. Means we have still very long way to go. So there are so many immune factors. I'm not going to read all those, but if you see the formula, there is nothing in that. And that we have to explain to the mother. And the health workers should know that the mother's milk is so important and how they can help every mother. Another thing is the breast milk contains hamlet cells, a substance capable of killing cancer cells. And that may be the reason there are certain cancers less in the child, as well as the mother is protected from cancer of the breast, cancer of the ovary, cancer of the uterus. And mother's milk also contains stem cells, particularly the colostrum. And you know, the stem cell is the cell which can be converted into any type of the cell. It is called totipotent cell. And that actually travels from baby's gut and enters into the blood, and then probably goes to various organs, and there is a proper development of each organ of the baby, and potentially contributing important developmental attributes. So formula, cow's milk modified with other ingredient. It is just the cow's milk. Now the milk is, mammal's milk is species specific. Means वो animal का milk खाली उसके बच्चे के लिए बनाया जाता है. Now all animals, they feed their own babies. Only humans are looking for some other animal's milk. Now when we think that, you know, that species milk is made for particular that baby, we don't think, do we want our baby's brain to be developed like cow's brain? We never think like that, because they look the same. It has a fixed static combinations, no correlation to increased intelligence, does not have immune boosting qualities, and there are no live cells, antibodies, enzymes, hormones, and there are still so many things. It takes 2 times longer to digest the formula. So that's why the frequency is less. That is another reason sometimes the breastfeeding mother thinks her milk is not enough. क्योंकि बार बार बच्चा ब्रेस्ट फीडिंग मांगता है. एक बार वो फॉर्मूला दिया तो बेबी स्लीप्स फॉर 3-4 hours, and then the mother takes it in a wrong way कि because her milk is less, now with the formula baby is sleeping nicely. And there are so many additives are added. If you see the formula lying in the rack for even 1 year, 2 years, you will not see any kida to it, because those, they understand it is not good for them. There are so many additives added in that, but we don't understand it is not good for our baby. Many practical challenges with the artificial milk. Again, we know that when the mother don't breastfeed, there are so many risks to the baby. particularly necrotizing enterocolitis in the preterm babies and all the infectious diseases. And maternal benefits we have seen, particularly the protection from cancer, protection, for the weight loss, the bleeding is less, but even the postpartum depression for the mother who intend to breastfeed but was unable. So the mother undergoes a lot of emotions, she is angry, she is anxious, she regrets, and that emotions can stay lifelong to this mother, So this baby is just asking, hey, doctors and sisters and all health workers, what are you doing for me? When you are talking, it is so good to me. Are you doing it practically actually? So this is the theme of this year's Protect Breastfeeding, a shared responsibility. And that means the mother cannot breastfeed alone. It is a shared responsibility, and it is between the policymakers, the family, and the society, the employers, and the healthcare workers. Now, I'm not going to detail from everyone. So we will just see the problems, what can happen in the hospital. So initiation is a big problem within 1 hour. There is a less milk in 2 to 3 days that has been again discussed earlier also. Improper attachment and position, the sore nipples, the engorgement, inverted nipples, mastitis and abscess, low milk supply. So let us talk about those things. So early initiation within 1 hour, that and provision of mother's breast milk to infants within 1 hour of birth is referred to as early initiation, and ensures that infant receives the colostrum. And there is also then skin to skin contact. Just by early initiation, 22% of the neonatal deaths can be prevented. That is a very good study from Ghana. And this is a systemic survey. More than 1.3 lakhs children are included. And you can see that if the initiation prolonged than more than 1 hour, between 2 to 23 hours, the neonatal mortality increases to 1.3 times. And if it is initiation does not happen within 24 hours, it becomes the double. So it has such a strong impact on early initiation. And the skin to skin contact, it 8 times more likely to cause the breastfeeding. That was the Cochrane database says. There's a clear dose response relationship between the skin to skin in the first 3 hours postpartum and exclusive breastfeeding at 3 and 6 months. And of course, with that, then engorgement also is less. So warming, feeding, and protection behaviors are intricately, inseparably linked to the right place. Now, if this initiation does not happen within 1 hour, and if it is prolonged, then there is a greater risk of dysfunctional attachment. So why we say within 1 hour it has to be started? Because the labor sometimes long, mother is tired, the staff is very busy completing all the notes and everything. We have many times short of the staff also. But then this baby's sucking reflex is very active in the first hour. And if you put the baby to the breast immediately after birth, you will see that amazingly the baby is sucking, and that there is a imprinting in the baby's brain, here is what my food is. But if we don't do that, then the baby sleeps at a longer stage later on, and then not eager to breastfeed. And in meantime, if we give formula by spoon or by dropper, many hospitals it is given, then the baby understands that it is the ready-made that food comes into the mouth, and then this baby will have a latching difficulty. First hour breastfeeding is the practice most predictive of exclusive breastfeeding in the hospital after vaginal or even after C-section. So what we do in the first 3 days influences the duration and exclusivity of the breastfeeding. And these are the critical ingredient to long-term breastfeeding is adequate milk supply. So first, our colostrum removal strongest signal for future production, not 2 to 6 hours. That means suppose if the mother is and the babies, they are separated. So there has to be manually the colostrum expression regularly.
And if that is delayed, again, the mother's milk supply will be compromised. Now, these are the things, that happen in the hospital that delays the initiation, that immediately the baby is kept in the warmer, the pediatrician then thoroughly examines the baby, and then they do a lot of this suctioning. You think Solapur, there is still practice happening, suctioning the baby's mouth? Yeah, because see, when I go to the dentist and the dentist puts into my mouth, I don't like it. And that baby 9 months in the mother's tummy is safe. It's delivered and so many insults are done to this baby. And when suctioning, sometimes even the delicate mucosa might be traumatized. So this baby thinks anything coming to my mouth is dangerous to me. So they may shut the mouth and they may not even open the mouth. We have seen babies not opening the mouth after the suction. So normal term babies, they don't need a routine suctioning at all. Little bit saliva or secretions, that is okay. Only some indicated like meconium and all. Vitamin K injection, in some hospitals, even I see the bath is been given, weighing of the baby, clothing of the baby, and then we wrap nicely and we give to the relatives. So what we are saying, give the infection to the baby. Because meantime, the mother's, the episiotomy suturing may be done. So everything is delayed. If you ask the staff, they have the knowledge कि we have to start within 1 hour. But actually practice, नहीं मैडम, वो टाइम किधर है हमको? हमने रिलेटिव को बोला था चालू करो, लेकिन वो फोटो निकाल रहे थे और वो फोन पे सबको बता रहे थे कि बेटा हुआ करके. So there are a lot of excuses that are being told. Now, after cesarean section, this is another important thing, how we can initiate the breastfeeding after cesarean. So this is the typical picture that you see, the mother in the recovery, sedated. You can see her clothes, they are not even front open. So there is a question of skin to skin contact, So, and then the baby is gone to the room or NICU, and then it is a delayed cesarean. But instead of that, in operation theater only, if our staff is trained, and this is actually after finishing the cesarean section, but the anesthetist does not give now the sedation anymore. And if we give the baby close to the mother and start breastfeeding, she doesn't need any analgesia. She's very happy. So if you see this mother who is a diabetic and overweight, and still the cesarean is going on down there, but we have put the baby over the shoulders. That is the way it is easy. And you can see how amazing the baby is sucking. So if we start the practices like that, and then again second feed we give once the mother is in the recovery. And then we call the relatives, we tell them also how should be the position. And then yes, breastfeeding can continue even as like a normal delivery. If there is a separation between the mother and the baby, this is a very important position paper, that there is a toxic stress in the baby, and when there's a skin to skin, even the mother's skin temperature is increased so that there is no hypothermia. And there is something called human imprinting. Comfort sucking and formation of nipple preferences are genetically determined behaviors for imprinting on the mother's nipple. So whatever the baby's mouth goes in the beginning, baby thinks that is the normality. So this is the animal studies. So if you see this side, the left side picture, the mother and the babies, they are together. So in that, there is a lot of leaking and grooming happens, and these babies have a low corticosterone levels. There is a low anxiety, and these babies are healthy even as an adult. And there you can see the right side, the babies are separated like our babies in the cradle. So there is a low leaking and less grooming, and these babies have a high corticosteroid level and high anxiety, and even they develop as an unhealthy adult in the future. So early stress alters gene expression with health impact across the lifespan. So that is why even what we say kangaroo mother care or skin to skin contact is that important. This is another important question, that mother doesn't have enough milk for first 2 to 3 days. So what should be done, for the baby's thirst and hunger? But see, the colostrum has a very small amount, few drops to 10 ml. But even the baby's stomach is also small. And that is why even if it is a small amount of colostrum, it is enough for that baby. And if you see the day 1, the baby's stomach is like a marble. And then day 3, it grows more, 15 to 20 ml. And the 10 days, then the baby has 22 to 27. So slowly the baby's stomach capacity increases. So even if it is a small size, it is enough for baby. Another thing, baby has a good glycogen storage at birth. So if that baby keeps sucking, that glycogen gets released into glucose into blood, and it's very less likely that the baby will have a hypoglycemia. That is what the pediatricians worry, even the nurses. So nurses or doctors, they should not press and see how much colostrum is coming. Instead of that, just let the baby keep breastfeeding every 2 hourly in the beginning, and automatically the blood sugar will be maintained. And I'm talking about the term babies. I'm not talking about the preterm babies or low birth babies. So risk of hypoglycemia only to preterm, low birth, delay in onset of feeding, hypoxia, hypothermia, diabetic, and infections. So term babies, normal delivery, we don't have to worry. Even Academy of Breastfeeding USA protocol, that also says the monitoring of blood glucose concentrations in healthy term infants is unnecessary and potentially harmful to parental well-being and successful establishment of the lactation, because it creates the anxiety. And routine supplementation of healthy term infants with glucose water or formula is unnecessary and may interfere with establishment of the lactation. And again, as we discussed earlier, the breastfeeding in on demand, and we should look for early cues and not when the baby is crying. Attachment and position, most of the breastfeeding problems are caused by poor attachment of the baby to the breast. Thus, it is vital to learn how to feed the baby with correct position. So if you see, the other animals don't worry about the latch. Why? Because they are unmedicated births, and there is no mother and the baby separation, and there is an intact culture of breastfeeding. But surprisingly, recently the zoo and circus animals, they do have a difficulty because it has been now more interfered the birth. How many mothers ever saw the baby being breastfed? With the working mothers, now with the nuclear families, there was a Facebook informal poll, and only 50% of the mothers said that they have seen somebody else breastfeeding. So if we don't see somebody breastfeeding, how we expect that mother to even the breastfeed successfully? Now that picture of gorilla, this was again another zoo in the New York, and there once they observed that these gorillas are not breastfeeding. Why? Because there was so much interference, and the babies were given bottle by the visitors, or by the organizers, and then these gorillas were not breastfeeding. So that became a problem. Ultimately, the local human ladies with their babies, they volunteered. They came and sat in front of these gorillas and breastfed their babies. And looking at these mothers and babies, gorillas started breastfeeding again. So this is what, when we see somebody else doing, we tend to do it. So the important step of the fifth step of the BFHI 10 steps, show mothers how to breastfeed and maintain lactation, even if they should be separated from their infant. So very important step. And we know the elements of the good latch. Rohini, have you discussed this? No. Okay. So, the good latch, there are 4 points that the baby should do complete and then maximum areola also should be in the baby's mouth, and the baby's chin touching the breast, and the baby's lower lip is everted. So, and mother also should be sitting comfortably, and the elbow support with the pillows, knee level with hips when sitting. She should be relaxed and the front open close. That's why when we take antenatal classes, that time only we tell her about what kind of clothes she should be wearing. Actually, our traditional sari and blouse is a very good dress for breastfeeding, but nowadays that has become less and less. Holding of the breast C-shaped and not with the two fingers, because that is where again the maximum areola doesn't go in the baby's mouth, and bringing baby to the breast instead of breast to the baby. So mother should not bend forward, otherwise she gets lot of backache and then she may not feed the baby longer. So that is what says the C hold or U hold is better and not the V hold. And there are different positions, cradle hold, cross cradle hold, football, sideline, and now there is a laid back that has been used a lot in New Zealand and Australia by Professor Smiley. And of course, when the baby, once after 6 months and once the baby diet adjusts the skill, the baby can take any position. We don't have to worry. Only in the beginning, we have to teach this skill to the mother and the baby. Like when we are learning the car, learning to drive the car, we have to see so many things. Afterwards, we are talking on the mobile and we reach the destination. It is the same about the breastfeeding. I just like to show the video. How I start this video, the first and the second. So this baby, position was very difficult, getting the position, because you see the baby was so far and, mother was holding with the two fingers. So we can start the next, and then we corrected. The baby is now skin to skin, completely turned, and the mother is nicely holding at the back and not pressing at the head. And the baby nicely started latching. So, the practical experience, the practical learning. Now, I'm an obstetrician, though everybody now recognizes me as a lactation consultant. So, but everyone obstetrician should know all these techniques. Somebody earlier said, because when you are doing the round and the junior nurse is helping the mother and the baby, you should know that she is not doing the right. And you have seen the mother 9 months. So the mothers tend to listen to you more than, the nurse, pediatrician. I don't insult them, but they are new to them compared to the obstetrician whom they know for 9 months. So very important that the obstetrician should have the basic knowledge about the breastfeeding. Again, hand expression when the baby is separated, baby gets colostrum, relieves uncomfortable fullness, softens the breast, and protects and improves the milk supply. So there is a technique how to express the milk, which can be given by the spoon. And in this first picture, you can see the colostrum is very small in amount. So if we try to get into the container, it sticks to the walls only. So we just take the 2 ml syringe and directly take into that drop by drop. And that syringe we send to NICU so that nothing is wasted. So role of milk synthesis is associated with the thoroughness of milk removal, and mother should breastfeed on the first breast first and until the infant seems satisfied before offering the second breast. So normally we say 1 breast at a time. So frequent milk removal is very, very important. That will only improve and maintain the milk supply. And it must be continued during the separation. This is very, very important. So the drained breast make milk faster, full breast make milk slower. So if milk is not removed, elevated intramammary pressure and accumulation of a feedback inhibitor of the lactation reduces the milk production and initiate mammary involution. So breast should not be full for a long time. Now, painful nipples, you can tell me when to stop, I will stop. So common reason, when there is a sore nipples. So, and main reason is improper positioning and attachment. And when the engorgement happens, again, nipples becomes flatter. And it is very difficult for baby to latch there. Sometimes with the tongue tie, that is called ankyloglossia. And in some long labors also, the baby can have a latching difficulties, candidiasis. So management of sore nipple, again improving the latch. If the latch and positioning is better, most of the breastfeeding problems can be prevented. And apply express breast milk to the mother's nipple after the breastfeed to lubricate and to soothe the nipple. And begin each breastfeed on the less sore side. And frequent washing of the nipple and areola with soap and water can cause drying. So some mothers have very, they wash the breast every time before or after the breastfeeding. So that is not needed. Once in a day, whatever the cleaning during the bath happens, that is more than enough. And baby should not be taken away abruptly from the breast while feeding, because that is where the baby's gums are holding the nipple and it may cause the trauma. So again, engorgement, the breast is overfilled with the milk, skin is stretched, nipples become shorter and stretch. So the early recognition is very, very important. And it is a very painful and heavy, the engorged breast. Mother gets fever also sometimes. And colostrum is actually very small, doesn't come out much. It is mainly the vascular and the lymphatic engorgement that gives the trouble. Sometimes the doctors may not give the baby to the breast because there is a latching difficulty, and they give the baby the formula, and then the engorgement exaggerates. So very important, the prevention, frequent feeding, effective feeding, correct latch, and hand expression or by the pumping the milk has to be removed. So that is the hospital graded pump. And the cold raw cabbage leaves, that has some chemical in the cabbage. So the cabbage, the whole leaves just can keep in the freeze and then put it on the mother's breast for 20 minutes, 3 to 4 times a day. Amazingly, in 24 hours, you will see the engorgement is less. So protection of the milk supply in this stage is very, very important. And we should not give the oxytocin or even the bromocriptine. And mother will need some painkillers. And we should not give routine galactagogues on the second day or third day. Again, inverted nipple, somebody said during pregnancy, no, we do not do any preparation during pregnancy. That has been now scientifically proved, because the teeth that is formed in the mother baby's mouth, it is a 1/3 is the nipple and 2/3 is the areola. So even if the nipple is flat or inverted, still the latching can happen. And there are physiological changes in the mother's breast, late stage of pregnancy, during labor and after delivery. So no, and even we should not use syringes to pull the nipples because it is very painful and can damage the nipples. So positioning and latch on, again, breastfeed early and often, achieve deep latch with sandwich technique. So like holding the sandwich. And products designed to lengthen and evert nipples, nipple pullers, that is the picture you can see, the nipple pullers or nipplets. And nipple stimulation before feeding. We can use occasionally nipple shields also, or we can use sometimes breast pumps. The breast pump will increase the milk supply as well as take the nipples out. Actually, there was a one, but that's okay. So mastitis, inflammation of the breast tissue due to infection, and mastitis, 75 to 95% of these cases occur in the first 3 months. Usually unilateral, and the mother will have a fever, chills, breast pain, localized redness. So contributing factors, milk stasis again, ineffective milk removal, cracked nipples, maternal stress, too much breast massage. We have those massage valley ladies, and they really massage in a wrong way, and that actually damages the breast tissue. And if she has a little nipple crack or something, the infection goes in. Restriction from a tight bra, use of manual breast pumps. And there are causative organisms are Staphylococcus aureus mostly, or E. coli also. And the organisms are very rarely. So mother with mastitis should continue breastfeeding. And then again, the prevention, rest, drinking extra nourishing fluids, treat nipple trauma, anti-inflammatory medications, and antibiotics such as penicillinase resistant penicillins. Flucloxacillin we give commonly, or amox or clavulanate combination, cephalosporins, erythromycin, clindamycin, and Cipro and chloramphenicol, tetracycline, they are not recommended. Suppose this patient of mastitis comes after 5 days and she did not take antibiotics properly and could not get enough rest. Now the breasts were red, swollen with area of induration, firm mass, which was fluctuant, and skin over this was red, thin and shiny, and the sonography suggests suspected breast abscess. So what we do normally when we see the breast abscess, we immediately refer the case to the surgeon, incision and drainage, and such a big dressing and the whole breast sometimes covered with the dressing. So there is no question of breastfeeding. And even sometimes the obstetricians give something to suppress the lactation. So that is the end of the breastfeeding story. So no more incision and drainage. What we do, it is just the aspiration, the needle aspiration, that too in the outpatient under the local anesthesia. So it avoids surgery. You can do under ultrasound guidance. I used to do initially under ultrasound, but now with the experience, we don't need even ultrasound. We just do in the OPD under local with a 16 gauge needle, and it avoids separation. There is no dressing, less pain, and easy to continue the breastfeeding. So at my clinic in Pune, in last 2 years, we had 74 cases because our clinic is a referral center for the breastfeeding problems. 71 successfully treated with alternate day aspirations and breastfeeding continued. Now you will say, what is this picture? Now we are doing Lactacon conference in Pune. 4 years consecutively we have done, and in the 3rd year we did the ramp walk for these breastfeeding moms, and she is the one who took part also, and she was a case of breast abscess. We did 3 aspirations, and after her last aspiration, 4 days after that, she took the part in the ramp walk. So she was healthy, happy, breastfeeding, and absolutely enthusiastic. So no more incision and drainage. You please continue with the aspiration and drainage. Insufficient milk supply, another problem. It is a major reason given up by mothers and discontinuation of the breastfeeding, usually in the first 2 months. And up to 80% of the women feel that their milk supply was inadequate at some stage. So there are
last 2 minutes for you, madam. We are running short of time. Yes. Thank you.
Yes. Thank you. So there are many reasons, and we will not probably go detail. But how do we know that the milk supply is enough for baby? So 2 gold standards. If the baby is passing urine 6 to 7 times in 24 hours, or baby is gaining at least 500 grams of weight every month. Now there are different galactogogues. Metoclopramide has a side effect of crossing the blood-brain barrier and causes depression. And we use nowadays domperidone, and we use much higher dose. It is quite safe for mother and the baby. There are a lot of other herbal medicines are used, and Shatavari is the most commonly used, and that is only scientifically proven. So it is the baby-friendly hospital initiative. I think somebody has discussed. So I'm not going to go details. So these are the 10 steps. Antenatal classes, very, very important during 6th or 7th month of pregnancy. And we discuss all the different things that we have discussed. Again, no artificial teats, no bottles. And in the hospital, sometimes practices like that. So they should be avoided. And baby can take nicely by the cup feeding, or there is a supplementary system that also we can use. Nipple shield, the upper one, that type should not be used, the silicone nipple shield. You can see how the baby is close to the mother, and the nipple shield is only temporary. There is something called induction of lactation when mother is not pregnant and she gets the baby via surrogacy. Even in those mothers, we induce the lactation and she can breastfeed. So by shape of this mother, you can see she's a nulliparous woman, but she beautifully starts getting baby. I have even the twins who mother has breastfed for 15 months. And again, after discharge, we should have in the community also support. By the mother support group, mother to mother support group, which we have in Pune, lactation clinics, lot of things in the community also, breastfeeding in public, in the schools also, children should be a little bit made aware of the infant feeding. Very, very important. I think I will stop here and we can take few questions.
Thank you, madam, for your excellent presentation. Any questions from the audience, both online and offline?
I think everybody's probably hungry.
You said breastfeeding at least should be continued up to the period of 2 years.
Yeah.
But I thought otherwise, breastfeeding can maximally be continued up to the age
No.
of 2 years. Beyond 2 years, can I imagine mother giving at least one sufficient feed of milk? Because by that time, the baby's requirement is at least to a tune of 2 cups per day. 2 cups per the feed.
Baby's eating everything now. So baby's milk requirement is not much, but there whatever the amount of milk baby is getting. So there are a lot of benefits, particularly the bonding and security in the baby. It is a baby's need. So as much as the baby wants, there is a one misconception कि अरे बच्चा छोड़ेगा ही नहीं, addict हो जाता है. लेकिन it doesn't happen like that. We have never heard some teenagers still breastfeeding or something like that. When the baby's time is over, need is over, baby stops automatically. I have few stories, but we don't have the time. Otherwise, I would have told.
I agree on both the sides. The baby is intelligent enough to whether to suck or not. That is way, but there is the other side also. The mothers keep on continuing feeding, and I write sometimes in my discharge guide is a breast addict child. At the age of 4 years, baby is only on breast milk, and then problems of constipation.
That is the problem. At 6 months, the proper complementary feeding has to start. By the time baby is 10 to 12 months, baby has to eat the same food what we are eating. Baby has to eat with their own hands. They should have a separate plate. So that thing has to start on time. Automatically they will not depend. Sometimes mother has no time, they give very watery complementary feeding, and then the baby doesn't get much calories, and then the baby is dependent on the breastfeeding. So that proper complementary feeding is very important.
Do you really feel, I personally feel that the timing of 6 months of exclusive breastfeeding has to be reduced a bit to the tune of 3 to 6 months, because I have been observing in my clinics that after the age of 3 months only on breast, and mother engaged in rest of the work also, family work with the husband, other children and family members doing a job, the amount of milk, which is the demand supply gap, goes on increasing. And then another asset to that is, another caveat rather, that between the age of 3 to 6 months, baby doesn't have some taste, not exactly sensation, but taste addiction, you may say, because he will go only to the breast. So that if we give anything which we want to increase the baby's weight, the baby will be able to.
A lot of research has been done, and World Health Organization and UNICEF has recommended. And yes, after 5 months, you will see the baby actually mouth opens, and when we start eating and looking at us, also she does the mouth movements. But their gut is not ready. You know, they have a gaps between the two cells in the gut. And if we give early any complementary food or other milk, you know, then that goes the foreign protein to the baby's body, and then the baby develops allergic symptoms, and those may not be visible that time. When the baby is suppose 7 and 8 years, baby may get diabetes, baby may get asthma. So 6 months, that gap junction, there is a closure, and it is very safe to give to anything to the baby.
Not milk, but complementary food.
Yeah, anything.
There's some online questions I can see.
Okay.
Can I? Yeah, wonderful lecture,
Hello.
Dr. Mangala.
Yeah.
Very nice.
Thank you.
I just wonder whether is there any study regarding the composition of the milk as woman goes on breastfeeding, like maybe after 6 months and later on 1 year or 2 years, you know, whatever. Is there any?
There must be. I'm not aware, but as long as I know, once the milk is there is a foremilk and the hind milk. The foremilk means
Thank you.
Yeah. Now continuing with Dr. Hemant Sate's question about feeding in 3 to 6 months, you said that the incidence of allergies would be more if we start with the earlier feeds. So I beg to differ with your opinion of starting with the earlier feeds. If you observe the recent literature, now there is school of thought that the earlier you start with some top milk, the incidence of allergies would in fact would be less. If you
First
start
thing
with
we have to
late,
see ki
and
who
then,
has done this research, because
yeah,
many
there are-
times formula companies do research like that.
No,
So
not
we have to be
not
very
talking of
careful.
any formula companies or anything. As a pediatrician,
So,
we
and
also
when
see
mother
anything.
has the milk, why we should give the top milk?
Yeah,
So we are just encouraging the top
absolutely
milk.
correct. That is absolutely correct. That if the mother has
Yeah.
a sufficient milk, there is no need up to the age of
And
6 months.
my own
one should
personal
not
experience.
be as a pediatrician. I agree with Dr. Hemant that from 3 months onwards, it would be only the weight gain of the child. Which
No,
would
not
dictate.
only weight gain. There are
And,
lots of benefits to the baby. That
there are a lot of
continue.
benefits. I am
And
not
plus
saying that we
mother's
should
milk
discontinue.
supply may not be
that-
maintained.
No,
So
no, no.
6 months, bang.
6 months cannot be the hard and fast line.
It cannot be hard.
we can
Maybe
continue-
5
we
months
can,
and 3 weeks is
So
okay.
that is what I'm saying.
You
As a
know,
pediatrician, these
it
are
is
the
not
practical
hard,
problems.
but not
we
3
are not-
months.
we can. It depends on the how hungry. We cannot allow the child
See,
to just keep on
physiological
continuing
changes.
crying like
That
that.
is
Hungry.
happening, physiological changes in the baby.
No, yes, we
So
agree.
6 months and 3 months, there is a lot of difference.
Lot of difference,
Even
absolutely.
5.5 months I can accept, but not 3 months.
No, it cannot
It
be
is
just a hard and
scientifically
fast
proved.
line. As a pediatrician, we see a lot of cases where the
Then
milk
our
is
formula
inadequate.
is not going to become less.
Sorry.
Then formula consumption will not lessen. You know, if the pediatrician
It is a
give the top
supplemental
milk,
feeding which needs to be
baby
started
doesn't
many
need
times.
supplemental
If the
feed.
mother milk is inadequate, there is no way out
Why
from
it
that.
is adequate? It is enough if we give proper breastfeeding, initiate within
Well,
1
I think
hour.
only
There is
pediatricians
never
would
a
know. I
problem.
think Dr. Hemant. Yeah.
For example, what we expect is, say in the first 3 months of after birth, I expect 900 grams per month,
Yeah.
30 grams per day.
First 3 months, there is a more weight gain.
Right.
After 3
Then
months, there is a less.
In the second half,
Yeah.
3 to 6 months, 20 grams per day.
Yeah.
And 600 grams a month. And in the next 7 to 12 months, it is
It
15
is still
to 20
lower.
grams per day. Now we can very well document it. We have been documenting it to the mothers also to convince them that their milk in output is less, and how much should be the output even in the NICU patients also. When we are trying to tell your feeding to the baby has to be still more, say 10 minutes per breast every time.
See, only time is not enough. We have to see whether there is a effective milk transfer from mother to baby, whether there is a proper latching. You know, this is all skills that everybody needs to be learned.
By electronic weighing machines, before feed, after feed, if required in NICU, stop in milk feed, and so or express breast milk feed. In spite, the baby may become exhausted while sucking on the breast, and then express breast milk given to the mother how much. So I put into 3 columns: before feed, after breastfeed, after express breastfeed, if required after top milk feed, and if the weight gain is excellent, we are not worried at all. And after 3 months, I will be in the majority chunk, maybe 10 to 20% you may take it. The demand supply gap becomes more and more, and top feedings and not milk feedings will add to the gaining the birth weight, and baby will take
Yeah,
whatever
so
milk
those
he
10
gets.
to 20%, if the milk supply is less, there are measures how we increase the milk supply. We should focus on that. Yeah.
Basically, the mother should be made aware that they have to feed the baby for 6 months. Whatever it is, they have to feed.
If we tell the benefits, what are the benefits and how it can happen, all over the world, science, you know, it has proved. And my personal experience also is the same. Our babies, particularly delivered by me or managed by me, we see a lot of women with the breastfeeding challenges, and I don't find difficulty. But once they are convinced, the mothers will do it. But if we put something in their mind, they start doubting themselves and their confidence goes down. And really, my breast milk has less, my breast has become softer than before. You know, now my one breast used to leak before, it is not leaking anymore. Now my baby is crying, that means my milk is less. You know, there are different reasons, you know, they may think that their milk supply is less. So it is the counseling. Of course, monitoring is very important. We should not be left baby starving or malnourished, but proper supervision of the weight gain is very, very important. And if the weight gain is not up to standard, we should focus on how we increase the milk supply. We can increase the milk supply by different methods.
Yes, madam, I agree with you. And basically, it is a problem in fussy mothers where they don't want to feed the child, and these mobile friendly mothers who want to be on the WhatsApp.
So that is all the
continuously.
counseling.
Yeah.
And
So
even the
that is
working
what,
mothers,
huh.
now government gives 6 months
6
leave.
months. So, working mothers
yeah.
previously 4 months we used to agree, but now government itself has given 6 months, and even the private setups have been asked to give leave for 6 months. Okay, thank you.
Madam, can you briefly answer those online questions for you?
What are those? Iron supplements to full-term baby. DHA colostrum for infants. Iron supplement may not be needed if the mother has the good iron storage. But because there is something in the mother's milk that helps the iron absorption for the baby. But DHA, yes, we say we should supplement the mother 200 to 300 milligrams per day. So that will increase the DHA content of the milk. How safe is herbal Ayurvedic Shatavari in promoting lactation? So Shatavari has scientifically proven that it is effective, but only galactogogues are not important to improving the milk supply. It is actually the proper latch, and we have to see whether there is an adequate milk transfer and whether there is a proper stimulation of the breast. These are the important. Only Shatavari or anything will not increase the milk supply. And is cesarean mother should immediately breastfeed? That is what we showed the video. I think that this Abhijit has missed that video. Yes, of course. Immediately now, during only, not after, during cesarean section. Right. Okay. Thank you. My pen, right?
Human milkman. Very good afternoon, everyone. I am very glad to be a part of Lactacon 2021. I will like to introduce Dr. Shakira Savaskar, madam, one of our favorite teacher. She is a professor and head of Department of Pediatrics, VM Medical College, Solapur. Madam had done MBBS in 1981, passed MD Pediatrics in 1985. She was a lecturer for 10 years, associate professor for 9 years. And since then, she is a professor, madam is professor in VM Medical College, Solapur. Madam had done many paper publication at a national level. Madam was examiner in at national level, state levels. Madam had done at least 15 to 16 16 inspection as a UG PG colleges, as a MCI inspector and NMC inspector. I will request Madam to deliver a lecture on a human milk bank.
जरा पॉइंटर नहीं है क्या? ये पॉइंटर
अरे वही ना. झाले? अच्छा. Good afternoon, everybody. Thank you, madam, for your kind words. And I'm here to deliver Human Milk Bank, a very apt topic in the present scenario. So, second one करूं. So let us see what is the definition of a human milk bank. A human milk bank or breast milk bank, as it is also known, is a service which collects, it is such an apt definition, a very complete definition. It collects, screens, processes, dispenses by prescription. The doctor has to prescribe by prescription human milk donated by a nursing mother who are not biologically related to the recipient infant. So this is the definition. The mother and the baby which are receiving this human milk is not related. Breastfeeding is the most, second one. Breastfeeding is the most natural, inexpensive, environmental friendly, and easily accessible. And it is the healthiest way to start the life of a newborn. It ensures that all children survive and thrive. And it is the ideal source of nutrition for the first 6 months. And it may be continued for 2 years and even more than that. Sushruta, an ancient Indian surgeon, has beautifully described mother's milk in his Samhita. One just cannot compare even water of 7 seas. See what he's saying? One just cannot compare even water of 7 seas with mother's milk, which is nothing but water ensuring optimum growth, nutrition, and healthy life of 100 years. India has the highest number of preterm babies in the world, and breastfeeding rates are suboptimal. Providing breast milk to these babies, especially those with very low birth weight, if they do not have access to their mother's own milk or mom, due to reasons such as mother's sickness, death of the mother, separation from the mother, not a proper latching, and so on. This leaves them more vulnerable for infection and death. So this has depicted India bears the highest global burden. So you can see, this is not working, I think, okay. 135 million births each year. 20 million babies have low birth weight. 15 million are preterms. 2.6 million die in the neonatal period. So you can see 20% of the global share is our birth. 38% of our global share is of low birth weight. 23% of our global share is preterm births, and 29% of global share is our neonatal mortality. So you can just imagine in what a bad scenario we are. Mythological anecdotes tell tales of Yashoda, who was a wet nurse to Lord Krishna. In 18th century, wet nursing was widely practiced for offsprings of mothers who were born into nobility because they refused to feed in order to maintain their beauty and figures. Even as I see in the OPD, we see when two co-sisters, two sister-in-laws have been delivered, the one feeds the other baby also, because if she's cooking, if she has gone for a natural call, then the other co-sister feeds it. So this is quite common in our scenario. Milk banks in India. There are currently about 80 human milk banks as per guidelines on lactation and management center in public health facility. They are non-incentive in India. So you cannot get money out of it, either by buying or by selling. It is completely voluntary. The mother has to agree to it. First human bill started in Asia at Sion on 27th November 1989 by Dr. Armida Fernandez in Sion. It is now looked after by Jayashree Monkar. 200 to 300 liters per year was initially donated and stored. Currently, they are getting 800 to 1200 ml, and which is sufficient only for their babies. They cannot give it outside. Their target is about 10,000 liters per year. It has completed 30 years. And to acknowledge it, there is a postal stamp released for this. So you can see this postal stamp is released. It not only now is known as a collection or a dispersing center, but now it is also a zonal center which helps in upcoming milk banks in Western Maharashtra. The second human milk bank was started in D.Y. Patil, Pune, in collaboration of Rotary Club of Naripan Point, Mumbai. Central India's first human bank was started in 2016 in Patangrao Deshmukh College, Amravati. In 2017, Vatsalya Matri Amrit Kosh was started in Lady Harding, New Delhi. And the importance of this human milk bank was that even in this COVID situation, a very bad situation, their donation and their distribution was the same as it was pre-COVID. 5th February, the recent one started is in Kerala. What is the global scenario? Europe has established it in 1930, Brazil in 1940s. Today, more than 600 milk banks have been established in more than 50 countries. Currently, 223 active human milk banks are there in Europe. And Brazil, which has the highest network of human milk bank, about 213 human milk banks are in Brazil. So this is the map which is showing. So first of all, we will have to have an integrated approach towards this. So many infants access to their mother's own milk because they cannot access, they cannot feed because mother's illness or death, infant's illness, inability to latch, delay in milk production. The lack of access gives to vulnerability to the disease, poor health, death in premature and low birth weight babies, and later on they become malnourished. In such a scenario, the World Health Organization and the other academies all over the world have said that human milk bank should be made available to these children, because if they are not having mom, they have to feed on this human milk. So it is screened and recruits breast milk, collects, processes, already I have told, distributes. It not only saves lives, but it also enhances the awareness of breastfeeding. This is very, very important. So the collection of the human milk not only saves while giving to the neonates, but it also creates awareness about breastfeeding and improves breastfeeding rates. As Madam has already told, we are 51% only we are having breastfeeding. So this is very important, and awareness through all levels should be done to improve this. What is the rationale? What is the rationale behind this? As part of integrated care, newborn care, human milk bank reduces death and illness, as well as lowers healthcare costs. See, I'm working in a civil hospital. where I have a 40 NICU beds. And any given time, I have about 45 to 55 newborns. Maybe even sometimes we go up to 60 also. So for us, this healthcare cost has to be reduced. The stay of the newborn has to be reduced so that we can cater more and more newborns. So data exists, we support that. Low birth weight babies less than 1.5 kg have a less death rate if given human milk. So it is 6 times more in non-breastfed than in breastfed babies. So feeding practices for newborn from best to worst as given by WHO. So what is best? Best is mother's own milk, which is fresh and there is a lot of warmth, there is a lot of love, affection, everything is there. It is the mother's own milk, which is the best. Then comes the donated fresh preterm milk, donated fresh term mature milk, pasteurized donated breast milk, preterm formula, ordinary formula, and the last to come is the animal milk, which we are rampantly using in our country, the animal milk. That is the worst that we are doing. What are the positive effects? As madam has already discussed, it reduces the risk of sepsis. So our NICUs are overburdened. There is lack of manpower. You imagine 40-45 babies looked after by 2 staff nurses only for 8 hours. So it's we are not doing a quality work, we are doing a quantity work, and that helps in spreading this infection. So it reduces sepsis. Reduces necrotizing enterocolitis, especially in the preterm babies. So it helps in reducing greater feeding tolerance. So formula feeds, and this if you compare, this is going to have greater feed tolerance. Reduced length of stay in NICUs, which I've already discussed, which we don't want. We want the babies to go home fast so that the burden on the economical burden or the burden on the staff working there comes down. Substantial cost savings, we have already discussed. So anti-infective properties, madam has already told. There are many anti-infective properties. So let us come to what is the structure of the human milk bank, how the human milk bank should be. In India, human milk banks are established as lactation management centers at 3 levels. Lactation support units at the delivery point itself, lactation management unit at district levels, functional special newborn care and comprehensive lactation management centers at tertiary levels. So these are the 6 basic steps. Comprehensive lactation management, also for second name for the human milk banking. Screening of the donor mothers. You have to screen. I'll come to later on what screening you are supposed to do. Screening of the donor mothers, milk collection, processing of the donated human milk, that is pre-pasteurization, storage, pooling, and pasteurization. Testing of the donated human milk, storage of the pasteurized donated milk, and dispensation of milk. Infrastructure, it depends upon the availability. There are multi-speciality hospitals or big hospitals, they can give up to 5,000 square feet also. But in the government hospital, we are short of space. So we have allotted about 250 square feet for this. It should be near the postnatal ward and the NICU, easily accessible and approachable. The cost of setting, you can see, we had given the proposal to government of Maharashtra, and in the least we had given is 10 lakhs. So you can see up to 10 lakhs also a milk bank can be established. Administration staff is also required, and this is a recurring we are going to have the amount we have to pay for the salaries and all. This is the major problem in starting the human milk bank. So every year you have to settle for 10 to 12 lakhs for all this. So for establishing it is 10 lakhs, but every year they have to spend 10 to 12 lakhs. So there is a director required, milk bank officer, lactation management nurses, milk bank technicians, receptionists, microbiologists, and so on. Why do we need milk banks? Basically, why do we need milk banks? Babies admitted in NICU and PICU. So they are away from the mother, they cannot be fed. We are doing the rise to feeding, and that is required. Care at the age of viability. Twins and triplets. There are twins, triplets, and mother is not geared up to feed these twins and the triplets. Street children, adopted children, destitute or deserted children. So all these are going to require, if given human milk, their chances of survival are very high. So you can see prematurity, so many surgical conditions, cardiac problems, feeding intolerance, so on. All we are going to give is human milk. Processing, who can donate? So this is very important, who can donate the human milk? A lactating mother who is good health related behavior. See, that is also important. She has to have a good health related behavior and not regularly in medications or herbal supplements. But the exceptionals are vitamins, human insulin, thyroid replacement hormones, nasal sprays, asthma, topical treatments, eye drops, and low dose estrogen, which the obstetrician has started. And is willing to undergo blood testing because she has to be tested for HIV and so many things. She has to be willing to test that. Has enough milk after feeding her baby satisfactorily, and baby is thriving nicely. So this is very, very important. She has enough milk. She has fed her baby, but still the milk is remaining in her breast, so that she can definitely give. And I tell you, our mothers are very happy to give it. So they are, you need not counsel also much. So if you ask them to give, they are so happy. They are, because this is our upbringing, which we are seeing from right from the beginning. Who cannot donate it? Using illegal drugs, tobacco products, nicotine replacement therapy, or regularly takes them 2 ounces of alcohol and has positive blood tests for HIV, hepatitis B, syphilis, or she or her partner has all these diseases, has received organ or tissue transplant, any blood transfusion, blood product within the prior 12 months. So this is very important. We are using this blood transfusion, plasma transfusions, and so on. So she should not have been received prior to 12 months. Is taking radioactive or other drugs for some her malignancies, and has mastitis or fungal infection of the nipple or areola, or active herpes simplex. After proper counseling, checking suitability for donation, getting written informed consent. This is important. You have to get a written informed consent. Physical examination and sampling of the laboratory test should be done. She should be counseled for personal hygiene. She should be taught how to express the milk, cleaning of the breast pump, and so on. So expression of milk is done in 2 forms, manual expression and expression using breast pump. We always prefer a manual expression. So this is the manual expression, and that is the breast pump. So processing is pasteurization, rapid heating and cooling, and then study for microbiological screening. The importance is that after pasteurization, COVID-19 viruses are not found in the milk. Storage, if it is stored in the room at room temperature, it can be remain for 4 to 6 hours. In the refrigeration for 4 days. And if you frozen this milk, it stays for 6 months. Physician's requisition from NICU is a must to give this milk. And it is done on merit basis, depending on the condition of the child. So this is very important now. Commercialization of this human milk. It is also called as a liquid gold. It is going to give you a lot of money. So this is going to come into scenario sooner or later. Role of the multinational companies. They are all the time after it. So now it's not, it is going to be there, they are going to start it. And if somebody is getting benefit in the form of monetary benefit, maybe some mothers will opt for it. It is a source of stem cells too, as madam has already told. And now it can be utilized for something else. The colostrum can be utilized for stem cells. Human milk powder, it is in the pipeline now. So that also will be produced. E-selling on internet. So internet, the very largest disadvantage, lot of people are used for online shopping, online this thing, and this e-selling is going to be slowly popular. But we have to say that this is not good, because you don't know whether the mother has been tested for so many infections and all. So this has to be discouraged. In some countries like Cambodia, they officially sell milk from human milk bank. 15 ml of human milk will cost rupees 400. So you can see the amount. 15 ml is going to cost rupees 400. Human milk bank in COVID-19. So most of the milk banks in China, Italy, and India suffered a lot in this COVID-19 because the mothers didn't come, they were not counseled, they are not willing to get exposed, and so on. Only the Lady Harding Medical College from Delhi, there this could not create any impact. But rest of India, it has created impact. Longer maternal stay, feasibility of milk donation by providing mothers. If the mother is staying longer in the hospitals, it is easier for her to donate the milk. So she should use face mask, she can put on PPE kit, all the proper COVID behavior should be observed. And it is already proved that vertical transmission is not there. So it is only the horizontal transmission of COVID. So that she can do. There are many government policies. So this mother's absolute affection. So this is playing a major role in this. And breast milk is universally available, and they are looking after this human milk banking. We have a 3-tier system. Already we have told. And mandatory informed consent should be there. Physician's prescription should be there. So this is the 3-tier system. At medical colleges and NICUs and district hospitals is a comprehensive lactation management center. At district levels, lactation management units, and at delivery points, lactation support units. So women named Ariel Matthews in USA has donated her breast milk more than 15 liters after the death of her first child, and more than 70 liters after losing an 11-day-old baby, a second child. So you can imagine how mothers are. So even she has forgotten that her baby is dead, but she has seen that somebody else is surviving. In Rajasthan, an IAS officer has to get an award because she has donated milk for a noble cause. So what is the scenario in civil hospital? So wet nursing is very common in civil hospital. So these are the containers. The staff nurses tell, this is a place we have identified for our human milk bank. And this is what we collect in the milk in. It is a fresh milk. Because we are having a shortage of staff, basically this whole requires a lot of dedication. Working in the NICU itself requires a lot of dedication. Because the whole, whenever the staff nurse comes inside, or even our residents, whole time they are on their feet. They cannot sit. So dedication, lot of dedication is required. And to counsel also, lot of dedication is required. Patience is required. And we are trying to do this in our small little way. See, last one we had 2,612 admissions in NICU in spite of being a COVID year. And that LBW were 896 and preterms were 661. So you can imagine if we have a blood bank, we will be, it will be help to so many children. The key points is breastfeeding, no child should be deprived. It's the first immunization, it's a must. In the mother, it helps, as madam already told. For babies, Also, it helps in so many illnesses. By helping mothers breastfeed, make sure that mothers breastfeed their babies even after discharge from the hospital. So we have every Wednesday in the ANC wards, civil hospital gives a talk on breastfeeding. So now I have asked the sister to even tell about human milk donation during that talk itself, so that let the mothers be aware that there is some concept like human milk donation that can be done. So we have started now, and we say save a life, donate milk today. So take home messages. Human milk bank is important medical social initiative to reduce the mortality and morbidity. It also promotes breastfeeding, very important, which we are lacking nowadays. It also promotes breastfeeding. Lot of, I think, the media should be used, the print media, the television media, and some hoarding should be put all around. They have to see that this is taken up. Requires good coordination between organizations and agencies. And the cost is not much. It can be started at any district level also. Thank you.
Thank you, madam, for a nice, wonderful, briefly lecture. Is there any queries from the audience, online or offline audience?
Human milk bank in civil hospital.
It is going all over in Maharashtra. They have asked us for the proposals. We have sent it almost 2 to 3 times, but it has not been approved still. We have designated a place for it. And as we are short of staff, we cannot give our staff for all that. But they have to give all the staff, and that recurring expenditure is the most important there. So every year they have to spend almost 10 to 12 lakhs. Just starting a milk bank is not okay. It has to be maintained also.
Actually, I was just talking to Dr. Tiwari sir, who is main chairperson of this Human Milk Bank Association of India. And he was saying that maintenance is not that expensive.
It is 10 to 12 lakhs per year.
And he says 1 or 2 staff or even your routine employed staff can be trained and they can just do a couple of hours extra work. You don't need extra. Even in D.Y. Patil Medical College, where I conducted the IBCSC course last year, they were also saying they have just one dedicated nurse who does everything. And maybe you can visit such banks and have a look.
Okay,
because
madam.
that is
We'll
where
try
is
to
the
do that.
obstacle. Na? Ki every year, 10 to 12 lakhs is a lot of money for government. Public-private partnership. And that is what, or you can get
No,
some
we can
donors
do
also.
private-public partnerships, but the private people who will come inside, they want so many benefits out of it, which we cannot do it.
Can be terms and conditions.
No, but they say that you should have some media speaker, then you should allot our name to this, which is not possible for us. So we have people who are ready to donate 10 lakhs. It's not a much amount. It is just 10 lakhs. But then we cannot go for these terms and conditions. And basically, madam, our staff provision is very less. So you can imagine in NICU, which is a very heavy NICU, we have 2 staff nurses round the clock. So only 6 staff. So it's very difficult. Sometimes in the night, we have only 1 staff. And in this COVID, more of a problem.
At all you have a milk bank, will it be only restricted to babies from the civil hospital or whether
it will depend on how much is the donation. If it is more, no point in keeping there. We can just give it. But we have to have lot of awareness for this. How many people know about this human milk banking and all?
And one person who is dedicated, who is more passionate.
That one is required.
It could be obstetrician, it could be the pediatrician, or it could be somebody from admin. You know, but one passionate person who will take the responsibility. कि ये मेरा काम नहीं है, ये ऐसा नहीं
मेरा 5 बज गया, मैं अभी घर जाऊंगा. So no, you need a lot of dedication for this, and which is lacking, absolutely lacking. I totally agree with you. It is lacking. Even staff nurses, which when we were housemaids, the staff nurses we used to see, they were so dedicated. But now it's not like that. ये मेरा काम नहीं है, ये मैं नहीं करूँगी. So this is happening now, and we are facing it.
Once you start now, and you will get so much goodwills, then automatically it will start rolling more. You know, but you just start, and it will keep going.
No, we have asked, we have talked also, madam, so many times in Mantralaya and all. Now I may talk to Dr. Tiwari sir also, and if he can help us in some way, so we can do it. We'll do it. We'll try to do it. But this project is pending with us since last 6 years. So we are with this project. We have at that time it was 10 lakhs. Now maybe it has increased to another 4-5 lakhs more. So I don't know, but that time we had given the project for 10 lakhs. Now it must be another 4 to 5 lakhs more.
Now we can move move our next lecture. Running shift.
Thank you. Thank you so much.
Sorry, madam.
Yeah, so we will invite the next speaker, Dr. Hemant Sate sir. I think all of us know Dr. Sate sir is one of the most senior pediatricians working in Solapur. He has passed his MBBS in 1981 and he's done his DCH and MD from VM Medical College Solapur, and is doing his private practice in Sate Nursing Home for the last 25-26 years. He has been the organizing secretary of Mahapedicon 1995. Then he has been the chairperson of Mahapedicon 2015. He was the president of IAP in 1997 when the Solapur Society got the prize for third prize for the best district in IAP. I invite Dr. Hemant Sate sir for his talk on vaccination. Thank you.
I'll just run once and then. Yeah, okay. Right. So thank you, the organizers of Lactacon, both the Obstetric Society and the Pediatric Society, and especially inviting me on a topic which is to my heart, the vaccination in children. Then we many times use in the word immunization and vaccination synonymously, but let me tell you, it is immunization is a process by which an individual's immunological system gets fortified against a particular agent, and it can be an active immunization, that's what we call it as vaccination, and passive immunization by immunoglobulins or by use of antisera. Then vaccination is what is a vaccine now? The vaccine is an immunobiological agent which produces a specific protection against a particular disease. Now, aptly, active immunization or vaccination has been labeled as one of the 10 great public health achievements of the 20th century. Now, let me ask a few questions to you. Do we need vaccination? I think everybody of us will agree that we need. How many of us are vaccinated? To be specific, or should we minimize patients? Should we immunize patients if they still get a disease? For example, this was a myth before: measles, chickenpox, and tuberculosis. Then should we give intramuscular injection if it can precipitate polio paralysis? Gone are the days. Since 2011, we do not have a case of wild polio paralysis. And should OPV be continued along with IPV? As another query. And do newer vaccines have a priority? Then I can add to this, how many of us have taken COVID vaccination? It must be all. Then there are few, what I'll try to do is, I'll try to sensitize you to the use of vaccination. And then in the subsequent slide, I will try to tell you few important messages regarding the vaccination that we go on doing on an individual basis. right? And with time slot also. So vaccines, the live attenuated vaccines are BCG, measles, MMR, MMRV, is varicella, OPV, chickenpox, Japanese encephalitis, yellow fever, live attenuated influenza vaccine, and rotavirus, and hepatitis A also we have got a live vaccine. The killed vaccines are DPT, hepatitis B, hepatitis A, HIH influenza type B, typhoid influenza, pneumococcal and meningococcal, and so on. Then what are there are a few characters of the vaccines. They may be toxin based like diphtheria, tetanus. They can be subunit vaccines. This you must be getting the news of nowadays when we are talking about the COVID vaccines, what is what and what are the details and what are the importance of it. Subunit vaccines like hepatitis B, pertussis, acellular, and influenza. Then live vaccines like BCG, OPV, I just enlisted before. Inactivated vaccines like pertussis, IPV, hepatitis A, influenza, and polysaccharide vaccines that I will come to what are the importance of this, and the conjugate vaccines, pneumococcal, meningococcal vaccines, hepatitis A, hepatitis B, typhoid, and then glycoconjugate vaccines like H influenza type B. Now, vaccination, newer vaccines are those which have been introduced or likely to be introduced in the NIP. We are fortunate, the government is going to introduce 12 vaccines now. The program now consists of vaccination for 12 diseases. Tuberculosis, the few of them we already have got. Tuberculosis, diphtheria, pertussis, tetanus, polio, measles, hepatitis B, diarrhea, rotavirus is already there. Japanese encephalitis still not there, but is likely to come. Rubella, MR we are already having. Pneumonia recently has been introduced by the government. Pneumocil will be introduced in the immunization schedule, and H influenza type B already is there, and the pneumococcal disease, as I told you. Nearly all the countries have introduced hepatitis B vaccine, and more than 3/4 have introduced rubella also. And measles and HIV vaccine, and 2/3 of them have already introduced pneumococcal conjugate vaccine. However, fewer than half have introduced rotavirus vaccine or HPV. Vaccine is a biological preparation that improves the immunity to a particular disease. Now, a vaccine typically contains an agent. Now, how the vaccine works? A vaccine typically contains an agent that resembles a disease-causing microorganism and is often made from weakened or killed forms of the microbe or its toxins. The agent stimulates the body's immune system to recognize the agent as foreign, destroy it, and remember it, so that the immune system can more easily recognize and destroy any of these microorganisms that it later encounters. That is the basic concept of vaccination. Now, this I'll just skip off these slides because I'm going to talk about influenza in a subsequent one. Then vaccination has decreased the rate of disease dramatically. Where I have tried to depict few of the examples like measles, the percentage decreases to the tune of 99.9%. Though few upsurges every 4 years or 5 years we see. Then diphtheria, mumps, pertussis, then smallpox, we have eradicated, the world has eradicated. Rubella, H influenza type B, polio, virtually 100%, and tetanus, we just don't see. We may see one case in a year or so, the pediatrician. Now, vaccine protects the people you care about. This is a slide I have just put it. Vaccination is not just a personal choice. Why ask you whether everybody you have taken it or not? Because the vaccination is not your personal choice. The vaccinated community helps to protect those who are not vaccinated, a concept known as herd immunity or community immunity. Simply put, when a person is vaccinated, they prevent disease from being spread to others in the community, including babies too young to receive vaccines, unvaccinated children and adults, pregnant women, the elderly, the individuals with weakened immune systems, such as those with asthma, chronic illness, and undergoing treatment for cancers, and individuals who are allergic to vaccine component. This is again important in this COVID scenario where children are not that affected. The reasons must be lying somewhere here. And then for this herd immunity, how much is the threshold required? I just tried to depict to you, telling you the importance of how strength of the vaccination should be. Diphtheria, we have to have a threshold of 85% of the community or eligible population has to be covered with this. Measles to the 83, anything from 83 to 94%, pertussis 92 to 94%, polio 80 to 86%. I'll tell you that's why we are continuing in spite of polio eradication, oral polio vaccine, and insistence on injectable polio, which I will tell you subsequently. Smallpox we already eradicated. Then the vaccines, whether they are cost effective or not. They are not, they not only save lives, but they save money also. It's always cheaper to prevent a disease than to treat it. The routine childhood immunization program in one birth cohort saves about 13.6 billion sterlings in direct cost. And if you add it to the other subsequent expenditure saving, it comes to about 29.2 millions. Now, another say is delaying or declining vaccination has led to outbreaks of such vaccine preventable diseases as measles and whooping cough that may jeopardize public health, particularly for people who are under immunized or who are never immunized. The risks of natural infection outweighs the risks of immunization for every recommended vaccine. What I would say is parents, just remember this, every word is important. Parents who choose not to vaccinate often do so to avoid risk. They feel there's some risk will occur, but choosing not to vaccinate is the riskier choice. Are the vaccines worth the cost? The cost of illness tries to figure, I already told you, researchers have found that 16 US dollars were saved for every $1 spent for vaccination. Now, according to Johns Hopkins Bloomberg School of Public Health, vaccines can prevent the loss of 3.7 million lives and over 63 billion US dollars. Therefore, I would say vaccine preventable diseases can and do kill, but in spite of this, vaccine preventable diseases can and do kill children. Vaccines protect most children from contracting these diseases. Vaccines are not always 100% effective. Children have got reactions trivial to severe to the vaccines. Then how to take a decision? The use of vaccines has prevented and will continue to prevent tens of thousands of deaths and millions of episodes of diseases in children, not only in India, in US alone. This type of studies are never done in our country. In a database decision about vaccine use, the benefits overwhelmingly outweigh the costs and thereby support routine vaccination of all children. I personally consider vaccinating our children as a part of social contract we have with the communities we live in. And children should not be harmed by things that can be very well prevented. Now, if a slide about combination vaccine. Combination vaccines are good, valid, and equally effective. They do not interfere with the immune response. Otherwise, they would not have come into the picture. They are good and immunogenic. They decrease the hospital visits of the patient. They quickly cover the backlog, if any. And only thing is, one should follow the manufacturer's recommendation. This herd threshold, I already told you. This choice also appears to be a repeat slide. Then immunization, therefore, is a great success in vaccine preventable diseases, VPDs. Eradication of smallpox has paved the way. Outstanding success is in neonatal tetanus, diphtheria, measles, whooping cough, and now in polio. And therefore, we can proudly say that there is a proven track of vaccine preventable diseases. As again, the same story is as far as hepatitis B is concerned. And I think in all obstetric wards also, we give hepatitis B within 24 hours of birth, and it's a good way. And we are seeing cases of hepatitis B decreasing to a very significant extent. So is the story with HIV. So is the story with oral polio combined with injectable polio. And we are hopeful, if used meticulously, for cervical cancer vaccine. I think probably is an appropriate stage where obstetricians and pediatricians together, and I'm talking on vaccines. And I would love to use this cervical cancer as just a story. My daughter was given all the 3 doses of the cervical cancer vaccine before IMA programmed Cervarix schedule for daughters of their IMA members, and her friends also were already vaccinated 0, 1, and 6 months. That's the importance of early recognition and early awareness about taking a vaccine. Then just a word about, because almost every obstetrician must be keeping vaccines in this freeze. Nothing is to be, I'll just show a photograph also, but nothing is to be kept in the door of the refrigerator, because maintaining a cold chain is absolutely important. Or OPV, measles, MMR, BCG can be freezed, so don't waste them. Then the first compartment contains varicella. Those vaccines which are heat sensitive have to be kept nearer to the chiller tray. Those who are heat stable can be kept away from the freezer. So then the first compartment contains varicella. Second, DPT, TT, DT, hepatitis A, typhoid. and the third compartment contains hepatitis B. All live vaccines are heat sensitive and therefore should be kept closer to the freezing compartment. So this is a photograph of a domestic refrigerator. In the door, I have specifically shown nothing is to be kept in the door. Then, therefore, treatment of disease and its complications, treatment of drugs involves a lot of money, human working hours, issue of morbidity and mortality continues, long-term impacts on individuals continue, and the immunity develop is short-lasting when you are trying to treat a disease. Whereas the prevention of a disease by vaccination, disease is prevented, immunity is robust and longer in duration, saves money and human working hours, and we have got virtually negligible side reactions. Now, a few other points like bugs are becoming more powerful and resistant to antibiotic. Mind you, in the last decade, we may not have got a single individual new antibiotic. Haphazard use of antibiotics is defeating. No new effective antibiotics are in the pipeline. And whatever new antibiotics are coming, organisms are sparing no efforts to conquer them. And self-limiting diseases are bothering us by their mutilating after effects like long-term complications. Therefore, vaccination of every child is a responsibility to be shouldered by government agencies, parents after one-to-one discussion with the doctors, and gone are the words like optional vaccine and something, and vaccine manufacturers, third party, where vaccine has to be highly effective, safe, reasonably cheap, and therefore cost effective. India contributes, I'll show you a photograph of that slide also in the later picture. India contributes 25% to the global under 5 mortality with significant deaths which are due to vaccine preventable diseases. This is more important and which can very well be prevented. So should we not move ahead to step down our mortality from VPDs? Now, about the few vaccines, I think this much is enough for the sensitization of you to go and encourage vaccines to every individual eligible child. And then I will show you in few subsequent slides the way we go on doing vaccination in an individual. Say, for example, at birth, we go on to give BCG, oral polio, and hepatitis B, say at the age of 1.5 months, DPT, and so on. So in the same sequence, I will go on putting the slides. The BCG is a live vaccine. 0.1 cc of intradermal injection, all we know. The prevention of tuberculosis is to the tune of 50%. And mind you, the tuberculosis BCG, when we were born, the same BCG is still continuing. Prevention of biliary and bone tuberculosis is to the tune of 50 to 80%. And in spite of adequate coverage, we are still unable to control tuberculosis. And therefore, we need a more powerful BCG vaccine. And few facts, they may be frightening to you every year, but just see, every year 1.8 billion people develop tuberculosis, 0.8 million are sputum positive, hence infectious to others. Annual risk of getting infected with tuberculosis to the tune of 1.5%. Once infected, 10% risk of developing tuberculosis. 2 out of 5 people are infected with tuberculosis, and every day 5,000 people get the disease. Infectious patients infect 10 to 15% per year, and tuberculosis kills about 0.32 million patients per year. Is it not frightening? Then what are we going to do? Sorry. Then what about the future of BCG? BCG future vaccines, there have been a lot of research going on in improving the quality of the BCG, like subunit vaccine using anti-AG85 protein, DNA vaccine. And the third one is the modified vaccine, the Ankara vaccine. And with this modification of BCG, maybe when the governments aim to cover tuberculosis by 2025, we may be able to do that. Then second vaccine that we give routinely after birth is hepatitis B vaccine. Hepatitis B virus is transmitted by percutaneous and permucosal spread. The WHO guidelines state that the countries with less than 2% of the prevalence of chronic hepatitis B infection can take up a selective vaccination program. The WHO dropped this condition in recent years in favor of introduction of a new vaccine, but then we are ahead of this. And what we do in giving, there are a lot many schedules of hepatitis B vaccine. 3 doses at 0 at birth, 1 month and 6 months, or you can make it at 6, 10, 14 weeks with in combination or separate, or 0, 1 to 12 months to babies of hepatitis B surface antigen positive mothers if they are unable to procure immunoglobulin. But if they get immunoglobulin, we can just go on to use 0, 1 and 6 months schedule. Then efficacy is very high, no need of boosters for hepatitis B, and should be given to every individual. And those who are already 10 and 20 years old after taking hepatitis B immunization, the immunity levels are still much ahead of that 10 microinternational units per liter, the basic level of protection. Then vaccination, this vaccination is 95% effective in preventing infection and the development of chronic disease and liver cancer due to hepatitis B. That's why we insist on giving it as early as possible also. And the majority of hepatitis B carriers go throughout the life unaware of the presence of hepatitis B surface antigen in their body and unaffected
last
by
2 minutes, sir.
Okay. And then the hepatocellular carcinoma. Then let us forget about all these slides because we have to cover with DTP in pregnancy. I would like to just put it tetanus toxoid in pregnancy. What I would suggest all of you to use Tdap in pregnancy. We have to avoid a cellular use of avoid the disease of neonatal pertussis. And then many of us, our people are already started doing it anytime between the age of 27 to 30 weeks of gestation, at least a single dose. Then too many of tetanus toxoids are also facing immune complex reactions, so we do not want that. Secondly, that is about what I insisted on Tdap. Then regarding OPV, the end game, I would say that injectable polio will have to continue and inject, and along with oral polio, but injectable polio we have to cover to the tune of 80 to 85%. This is the table which I talked about. But then about the pneumococcal vaccine, this has been introduced by the government in the schedule, and the schedule will be 8 weeks, 14 weeks and 9 months. This is from programmatic point of view. Not IIP doesn't recommend this, but IIP recommends 3 doses that I already depicted, and your pediatrician knows it. Then about the rotavirus vaccine, the important thing is from the mother you do not get any rotavirus disease immunity. So also the rotavirus incidence is high. The baby's immune system is not mature enough, and therefore the baby is a virgin character. So much about that. Then I would stress about the influenza vaccine. Only important point right now, what is being circulating in the community is influenza has to be taken just to decrease the COVID incidence. It is not like that. But the symptomatology of influenza and COVID is similar. If you get influenza in changing seasons, there is an additional burden on the COVID system, and therefore, the efficacy of this vaccine is almost to the tune of 90 to 94%, so that we will be able to remove influenza from the community, so that only COVID will remain. And therefore, the influenza vaccine, if at all is to be given, it has to be quadrivalent vaccine and not trivalent vaccine, which has been unfortunately the message spread. It has to be the latest one. Then typhoid conjugate, just a word, we can give typhoid vaccine now at the age of 2 months also. Rubella, government has already introduced, I can just skip it. Hepatitis A in private is available. Then Japanese encephalitis, Karnataka, it gives in the government schedules, and whenever there is an endemicity. So I'll just skip that. Human papilloma, this is another cervical cancer vaccine which is to my heart and to the obstetrician. I have been insisting wherever I go that you insist or promote or propagate the need of taking this vaccine, because the cervical cancer is the second highest cancer in India next to breast, and is very, very preventable just by taking 3 injections worth 2,600 each to the tune of 93%. And therefore, and I am ready to give it. Your pediatrician must be ready to it. Only there is two-way communication is required. This is what I personally feel. Then this is about the rabies. I think I may just put a slide that if you want to pet an animal, you have to take a pre-exposure prophylaxis. And too many doses of rabies vaccination are not needed. This is what just, and a word about COVID and COVID vaccine and Covishield and Covaxin. I think everybody of us must take it. I have taken on the second day. I'm just to check the immunity levels in the next 6 months. On 18th, I'll be completing 6 months of the second dose and so on. You must take the vaccine 2 doses at an interval of, I took at the interval of 4 weeks, now 85 days from programmatic prison point of view, but academically 9 months, and academically 3 months. This is a poster we tried IIP regarding COVID, and you can just see at the right front from my side, we have put SMS and vaccine as social distancing, mask, sanitizer, and vaccination are the keywords. And to this, I add, I identify and isolate the patient. This sanitizer, mask, social distancing, identify and isolate the patient, and fifth is the vaccination. So SMS and V is going to help you a long way. Now, the same slide as I repeated, parents who choose not to vaccinate often do so to avoid risk, but choosing not to vaccinate is a riskier choice. Now, many vaccines are in the pipeline, but DNA vaccines are going to change whole of the picture, and they are going to come soon. Then in development, I have said I'll just skip, because once whenever they come, we will be able to know. Then about the thought of the day, the vaccines are highly effective and essentially safe. Modified BCG may determine the success story of eradication of tuberculosis. Pneumococcal vaccine, serotype independent whole cell vaccine is the need of the day, and serotype specificity remains the fact. Use of Tdap in pregnancy instead of TT will eliminate neonatal pertussis. Use of influenza vaccine will decrease the burden on the economics of the COVID management. Taking COVID vaccine and implementing SMS and I and V will help in curtailing or flattening the third and the subsequent waves of COVID. Therefore, do not hesitate, vaccinate and get vaccinated against COVID. The decision is yours, but let me remind you, the goal is achievable. Thank you for your patient hearing.
Thank you, Dr. Sate, sir. It was a nice presentation. Now I invite questions from the audience, both online and offline.
Can you just highlight on what you said about DNA vaccine?
No, DNA, see, the problem is we are having wholesale vaccine, a vaccine component impregnated into a virus, so that that virus is identified that. Now the problem is there are vaccine reactions. Now, once you change the DNA, the reaction, the side reaction will be virtually nil, and you will be able to put any vaccine to anybody with very, very, very negligible side reactions, because you are changing the DNA. And you are using messenger RNA problems. If you are using whole cell vaccine, few reactions, AEFIs, this I did not touch, maybe because they are virtually negligible. So DNA vaccines will change the whole of the picture, and then very, very minimal reaction. So the uptake by the individual will be to the almost to the tune, it will escalate like anything. Right. Sure, thank you.
Many thanks for wonderful lectures by Vani Madam, Savaskar Madam and Sate Sir. Now I would like to request Dindore Madam to felicitate our speakers to be on dais. Vani Madam. I would like to request Dabde sir to be on dais to felicitate Savaskar Madam. Savaskar Madam. Okay. I would like to request Sate sir to be on dais. There is a lunch break. At 2:10 sharp, we will start with our lecture by Dr. Kabras. I request Dindor Madam to be on dais. I will request Archana Madam to felicitate Dindor Madam. Hello. Dr. Pawar sir, many thanks for chairing the session online. I think, yes. We will disperse for the lunch. We will be starting our session by 2:10 a.m. sharp, 2:10 p.m. by Kabra sir. Thank you.
हो लावतो इथे दादा लंच नंतर माझा आहे 1 मिनिट
Welcome back, everyone. Starting with our post-lunch sessions. I request Kiran Sada madam to come on stage and chair our next sessions. Sada madam is a very well-known obstetrician in Solapur. She is the immediate past president of Solapur OBGY Society. She is also a member of FOGSI Breast Committee. I welcome Dr. Kiran Sada madam. Over to you.
Good afternoon, one and all. I hope our next speaker won't allow us to sleep in post-lunch session. In this session, we are going to listen from Dr. Nandikishore Kabra on the subject, improving outcomes of premature newborns, what all obstetricians and pediatricians can do the best. Welcome, Nandikishore.
Hello, welcome. Thank you.
It's my great pleasure to introduce Dr. Nandikishore Kabra, an international speaker, my MBBS classmate from Government Medical College, Aurangabad. We all batchmates feel very proud to read his newer heights of achievements regularly. His name meaning is God Krishna. He is really Krishna for all the low birth weight babies. When I visited his NICU at Surya Hospital, Santa Cruz, it was really very thrilling to see 565 grams weighing baby sleeping in a prone position and discharged after few days in its pink of health. Nandikishore is a director of NICU Surya Hospital, Mumbai. This NICU is having well-equipped 65 to 70 units for neonates, also having its own breast milk bank. Besides his super specialization DM in neonatology, he has done his MSc in clinical epidemiology from Canada. He is having fellowship in neonatology, RNS Hospital, Sydney, Australia. He also done fellowship in neonatal perinatal medicine from McMaster University, Hamilton, Canada. Till date, Nandikishore has 108 research publications in different indexed journals. He is a very good orator and has been delivered more than 300 guest lectures at national and international level. He is reviewer of Cochrane Neonatal Group. He was organizing secretary of IAP Neocon 2015. Areas of his interest are neonatal critical care, randomized controlled trials. He is very instrumental in teaching health research methodology. So now, presenting Dr. Nandikishore Kabra to enlighten us on improving outcomes of premature neonates, what all obstetric and pediatric team can do the best. Over to you, Nandikishore.
Thank you very much. Can I get a permission to share my screen? My slides are visible.
Yes, now it's visible.
Thank you, Kiran, for very kind introduction. I'm not sure whether I completely deserve it or not, but thanks to you and the Society of Obstetrics of Solapur and Society of Pediatrics at Solapur for giving me this opportunity to connect with you all. When it comes to preterm babies and low birth weight survival, we always keep on struggling, and we always keep on learning new and new things every passing day. You are initially worried if this baby is going to survive. If this baby survives, where there will be a short-term problem like bronchopulmonary dysplasia, intraventricular hemorrhage, necrotizing enterocolitis, retinopathy that may lead to blindness. And you are also worried whether the long-term outcome will be completely normal or not, whether you would have a survival, which you can proudly say that it's an intact survival or not. And let's go through some of the important things. So babies who are born before 37 completed weeks are called preterm. Those between 32 to 37, we call them late preterm. Those who are between 28 to 32, we call very preterm. And those who are less than 28 weeks are called extremely preterm. Generally, we tend to do very well here, and this is where area extremely preterm, where we struggle. And of all the preterm births, extremely preterm account for maybe just about the 1%, but that's the one which takes the most number of beds in NICU and most amount of time of a neonatologist or a pediatrician in the NICU. India is a large country. We have the largest number of births across the globe. We account for about 20% of live births worldwide, amounting to 2.7 crores per year. Our rate of prematurity is about 13%, and we have 34 to 35 lakh preterm babies which are born every year. As per current data, just checked last night, the infant mortality rate is 28, and of this, 22 comes from the newborn mortality, and the major important cause of neonatal mortality currently is prematurity, apart from infection, asphyxia, so on and so forth. Now, when it comes to preventing newborn deaths, which are due to prematurity, there are few simple things that have been suggested and reviewed in this paper, where it talks about 80% of preterm birth, those between 32 to 37 weeks, they would be fine with simple level 2 care and essential newborn care, where you just keep them warm, provide nutrition, prevent infection, and you would be fine. And more than 75% of deaths following preterm births can be prevented without provision of this intensive care. Most important thing here is prevention of infection, provision of warmth, resuscitation, and early initiation of enteral feeding, that too with human milling, and providing breastfeeding support are extremely critical. Now, if I ask a question, I wish I had an opportunity to present physically, but suppose if I ask a question, which country has the best survival rates for preterm babies less than equal to 24 weeks? And some of you may choose US, Canada, UK, Japan, Australia, or France. But in reality, the best survival for these small babies comes from Japan. 22 weeks survival is 37%, 23 weeks it's 64%, and 24 weeks it's 78%, and 25 weeks and beyond it's 86%. Japanese were the worst cards in the world at the time of Second World War, and currently they are considered the best cards. And this is because they do the things simply, keep on refining what they are doing, repeating same thing again, having protocolized things. And this is the reason why Japan is doing so well with even preterm babies. Now let's look at what is happening in India. So this was the paper published from All India Institute of Medical Sciences last year in February 2020. And they looked at the data for the period of January 2013 to September 2018 for babies who are less than 1 kilo. So 24 weeks survival is about 10%, 25 weeks 33%, 26 weeks 33%, and starting to pick up after 27 weeks. This is data from our hospital from Mumbai from 2012 to 2017, where we had 49 24-weekers, of which 40% went home. And generally, like each passing week, you go from 24 to 25 to 26, there is improvement by tune of 10 to 15% at every gestation. In year 2018, we had 16 24-weekers, of which 8 survived and 8 did not, and 4 were DNR. Next year, 2019, we had 16 24-weekers and we had 12 survivors. And this year, we also had 7 23-weekers, of which 5 survived. Year 2020, we all know that was a difficult year for obstetricians, and so was for the pediatricians and newborn intensive cares. We had 24-weekers, of which 3 survived. And year 2021, we already had 8 23-weekers, of which 6 have survived. So every passing year, the outcomes are steadily improved. Although our numbers are good, we generally, when we talk to family, when we do the counseling, we try to portray a modest picture, not making them over optimistic or over pessimistic. And you would say that at 24 weeks, we have a 50% chance of survival, and those who survive 50% are likely to be normal. And each passing week, you would increase that by 10%, from 24 to 25, from 50 to 60%, 26 weeks, 70%, 27, 80%. And really 28 weeks and beyond, its survival is just like any full-term baby, 90-95% survival, and 90-95% of those who survive are expected to be normal. This is data from our own unit. Although numbers are better, we try to portray a little modest picture. Now, this was one of the papers of RCT where we looked at role of paracetamol and indomethacin for treatment of PDA, and this was a study carried out between 2012 to 13. So there were like 29 weekers, or approximately weighing 1 kilo, and the survival that time was about 80%. Then subsequently, this is another paper from our own unit where we try to look at if you do the cord blood sampling versus sampling at admission, you would reduce the sum amount of blood that you are draining from these babies, and you would reduce the need for subsequent transfusion. Now, in this population, which are all are below 1 kilo, the antenatal steroid use was 97%. They were like 26-27 weekers on an average, weighing about 800 grams. And when you look at the survival of this cohort, these 80 babies, 95% survived. Okay, of the 80 babies, there were 4 deaths. So giving us a survival of 95%. So just the milestones. First 24 weeks we sent home in 2010, and then we were learning. And 2015, 23 weeks baby, 2017, 22 weeks. And so far we have 61 babies who are less than equal to 24 weeks who are in our long-term follow-up, who are discharged and appears to be doing well when they are 10 or 11-year-old. Smallest survivor by gestation is 22 weeks and by weight is 410 grams. So generally when we talk about 24 weeks, although last few years survival is amounting to 75-80%, we generally say we have a 50% chance at 24 weeks. So this is one part. The second part is what happens to these babies when they are in NICU, and what kind of morbidities these less than 1 kilo babies face. So if you go to the standard papers worldwide, risk of chronic lung disease is 44%, requirement of oxygen at discharge 20%, intraventricular hemorrhage any grade 40%, usually grade 1 and grade 2 bleed are inconsequential, severe hemorrhages like grade 3 and 4 11%, abnormal brain sonography like severe echo densities PVL or ventriculomegaly 24%, and retinopathy of prematurity 60%, but this is all grade, even 1 and 2, which are generally inconsequential. Then you would say that what happens to these babies at 1.5 years, either death or impairment is expected to happen in about 47%, of which 20% is the mortality and 27% is impairment. And the commonest impairment is their Bailey scores, which are less than 70, that is commonest. This is followed by cerebral palsy, and the hearing loss and vision loss is expected to be less than 2%. So when we deal with the deliveries at our unit, we have a simplified approach that if the baby is more than equal to 25 weeks or so, we would go ahead with the full support after discussion with the family. If they are less than 23 weeks, then we would offer them comfort care only. But if the family is willing to go all out, understanding what is involved, then it is left to them. At 24 weeks, between 23 and 6 weeks, there may be parents who want to do everything. There may be parents who may not want to do anything. So this is the gray area where we spend maybe a few hours of counseling, talking to them, meeting them again, and helping them decide, and the things will be done as per their wishes. So generally we know that female infants do better than the male infants, and they have approximately 1 week or 100 gram advantage. So what a 23.5 weeker girl will do, the boy would be like 24.5 weeks. So girls always do better than boys. Then what are the things that are going to influence intact long-term outcomes among those infants who are surviving and who are like 23, 24, 25, 26 weeks? So if you are a girl, you do better. If you are not being a SGA, it's an advantage. If you are AGA, you are likely to do better. If you are coming from a higher family income and you have an educated mother, you are likely to do better. If you do not have complication like chorioamnionitis, a major bleeding in the brain, or extensive PVL, or hydrocephalus, or you need any surgery, or you don't need any steroids, sepsis, infection, necrotizing enterocolitis, BPD, ROP, you are likely to do well. And if you feed these babies with mother's own milk or donor human milk, you would do better. So one of the important question is, we see our colleagues talking about this baby is not going to make it because he's just 25 weeker, 26 weeker, somebody even say 28 weeker. So one of the interesting question is, are we accurate in predicting the survival and long-term outcomes of premature infant? So this was a study done in the US, and people who just passed out their board exam, pediatrician, obstetricians, and they were asked with a questionnaire, define the survival at various gestational ages. What you are seeing on the top is actual survival rates. So they are here. And then the estimates are given by pediatricians. So pediatricians are pessimistic. And here is the line by obstetricians. So they are more pessimistic. So actual survivals are far higher than the survivals that are portrayed by pediatricians and obstetricians. And obstetricians were more conservative and more worried. Similarly, are we able to predict if the children are going to do well or not subsequently? So these are handicap rates on the top. We are seeing handicap-free survival rate, that means intact survival. And when you are asked as a pediatrician or obstetrician, you are underestimating that by a good 20-25% at each gestation up to at least 32 weeks. So another interesting thing we kept on learning is that, oh, babies IUGA or ESGA and you don't need steroids. Is that true? The answer is no, because we have a large observational study which shows that the odds of various bad things happening in IUGR babies, like death, like NEC, like RDS, like IVH, or severe IVH, is higher. And that's why we should give steroids to them also, because when you give steroids, it reduces the risk of RDS, IVH, severe IVH, and mortality. Now coming to the crux of my talk, how can we improve outcome of newborn who happens to be less than 1.5 kilo or less than 1 kilo? So before the delivery and in utero transfer to a tertiary care center where mother and infant both can be looked after. And what is the evidence for this? This is a paper from Canada published in early 2003 showing that the risk of death and respiratory distress and other morbidities are reduced if you are born in a place where mother and baby both can be looked after. Very interesting study done from UK NHS by Neena Modi and her colleague, where they have shown that if you are delivered in a hospital where mother and baby both can be looked after, the risk of severe brain injury is reduced. And so what they concluded is that if you have babies who are 28 weeks and less, and if you are born in non-tertiary hospital and you are transferred, you are likely to do bad. So better thing is to rationalize and streamline your services so that these babies are delivered in the place where mother and baby both can be looked after together. Another interesting paper from US published just last year, where they looked at babies who are less than 32 weeks, if they are coming to tertiary hospital, or they are just transferred prior to delivery, or those who are born and subsequently transferred. And what they actually have found is that if you are basically if you are presented to level 3 hospital and if you are antenatally registered, the risk of death is 10%. Whereas if you are born somewhere else and then you get transferred, the risk of death is almost double, So the simplest and easiest thing that one as an obstetrician can do is transfer this all to a place where mother and baby both can be looked after to give their best chance. And this is not something new. This has been told from 1976 and it's like 45 years and we still have to tell the same thing to all of us again, remind that transfer in utero to the highest risk ones, those one with the highest risk. Now, second thing what we do in our unit is that we have what we call as assessing the risk, and we also look at exact gestational age, estimate the fetal weight, and whether there are any risk factors in the mother or the fetus that may improve or make their outcome worse. And joint counseling session are especially very important, where because obstetrician had spent a lot of time talking to this family and the patient will blindly trust obstetrician. So if you together discuss the case and talk out the plan and give all the options to the family, it is their wish whether they want to do it or not, and stick to that plan, you are likely to do well together. Generally, when you talk to this family, rather than saying 5%, 10%, 15%, it is better to tell them in 1 in 3, 1 in 4, 1 in 7, so that they understand it a little better. This percentage can sometimes be very, very misleading. So in a simplified chart, if you look at the gestations, lower the gestation, higher is the risk, higher is the gestation, lower is the risk. Within the week itself, if you are beginning of the week like 24 plus 1 week versus 24 plus 6 weeks, those with 24 plus 6 weeks are likely to do better. If you are having growth restriction, if you are a boy, if you are multiple pregnancy, you are likely to do bad as against compared to if you are a normal weight or a female or a singleton. And if the steroids are given, and if you are delivered in the hospital where there is a NICU, you are likely to do well. So generally, the plan would be that if it's a moderate risk or a high risk or extremely high risk, your plan should be tailored to improve the outcome of that particular pregnancy. Now, what are the limits of viability? And generally, most countries would have 24 weeks and beyond providing complete care. There is gray area between 23 to 25 weeks. And generally, before 23 weeks, most countries would say you need to be very, very cautious. So these resuscitation not recommended or not offered. These are gray areas between 23 to 25 weeks where you would respect parents' wishes, and beyond 25 weeks, do everything. We do not have any clear-cut guideline in India. And you know that when there was a case in Max Hospital, New Delhi, there was a lot of hue cry, what is right, what is wrong. And simply what Japan did in 1977, they cut off the gestation for viability from 28 to 24 weeks. That improved their survival. And in 1991, they cut down from 24 to 22 weeks. So they are the world leaders in terms of saving the smallest and sickest. Canadian Pediatric Society in 1994, more than almost 30 years ago, came out with the guidelines like this: 22 weeks, no resuscitation, C-section intensive care, 24 weeks, avoid C-section, and give lots of respect and to parents and respect their wishes, and 25 weeks offer everything. Last year, they were in the process of revising this, reducing it further. So 23 weeks would come here, and 22 weeks will come here, and below 22 weeks will be kind of no resuscitation. But we have to take this case by case basis. We cannot blindly follow what is happening in Canada or what is happening in America here. So generally 24 weeks and high, 24 weeks and more, we do everything in Surya, and 23 weeks and lesser, we would discourage parents unless they are really desperate. Second thing the obstetrician can do is use of antenatal steroids. And we know the NHS guidelines that between 24 to 34 weeks, you have to use it. But then the question comes that at 24 weeks, when you do not have good lung development, whether they will work. And there are studies in literature which shows that the mortality risk would be reducing if you use steroid from 70% to almost 57%. So 13% benefit there. And this has been reflected in the SOG statement that came out in 2017, saying that if you are between 23 and 24 weeks and you are likely to deliver preterm, consider it after talking to the family. And again, the systematic review showing that even at 22 weeks, 23 weeks, and 24 weeks, it reduces the risk of mortality. So just going a bit more deeper into the steroids, whether we should offer this, and this is a large database of Vermont Oxford network of more than 300 NICUs across the world from developing countries. And generally the practices are that at 25 weeks, you would do everything, give steroids to the mother and provide care, even at 24 weeks. But when you start to go to 23 weeks and 22 weeks, generally you would say that don't give postnatal support, don't give steroids. So that would, but even at that gestation, some 10-20% may be provided with antenatal steroids and postnatal life support and postnatal steroids. Now looking at if you are just given postnatal life support at 22, 23, 24 weeks, and if you give with steroids, your outcomes would be better off. So if the parents desire to do everything, then give steroids also and provide support also. The additional intervention as an obstetrician can do is use of magnesium sulfate. And this has been backed by Cochrane systematic review, although the number needed to treat are small, like you have to treat 63 humans to get one benefit. But anybody who is 33 or 34 weeks, depending on which guideline you follow, you should use magnesium sulfate. And if there is opportunity, use tocolysis to prolong the gestation. If there is an infection, using antibiotics will help this fetus do better. So this finishes the part what is can be done prior to delivery. During delivery, having a trained neonatal team available for resuscitation. And this team meaning it's just not one doctor or a pediatrician, meaning pediatrician, assisting nurse, and maybe another person in case if you need. So generally for babies who are 27 weeks or less, we would have 3 people attending the delivery, and all deliveries which are less than 28 weeks are attended by consultant in the, whether it's a day or night or 3 a.m. So if you go with the intention that I want to save the baby, I think God also helps in the whole process. Then intrapartum fetal heart rate monitoring, very important. And delivery by cesarean section, it benefits outweigh the risk. Although the literature is very limited and very old, we do not have a clear guidance even from Cochrane review, because number of women who are randomized are small. But the common sense is that beyond 24-25 weeks, if the family is willing and the fetus is otherwise well, and we want to give best chance, and if you feel by doing cesarean you are going to have a better outcome, then you can consider that. What can you do after the delivery? Delayed cord clamping. Once the baby is born, we are all in a hurry to hand our baby to the pediatrician. So if the baby is otherwise well and there is no concern, then wait for at least 60 seconds. Let this baby get the benefit of extra blood that is going to come from placenta to the baby to build his blood pressure, to maintain his hemoglobin store, to build his iron store for life. Then comes the regulation of temperature, use of delivery room CPAP. Instead of using bag and mask, using TPs resuscitators, which you can control the pressures, they may not remain unregulated. And instead of using just straightway 100% oxygen, use blended oxygen. We spend millions and millions of rupees to have the best hospital and LCD TV and internet. But if you don't have blender, which costs maybe 40-50,000 rupees, we are not doing justice to this whole outcome of the pregnancy. So generally you would say that during resuscitation, use only 30% oxygen, not 100% oxygen. So blender should become the part of your labor and delivery. Cases where babies gets intubated and has a respiratory distress, use surfactant in the delivery room. And maybe for babies who are less than kilo, use it with steroids so that the risk of bronchopulmonary dysplasia is reduced. And pediatrician can consider using less invasive or minimally invasive surfactant in babies who are spontaneously breathing and who have respiratory distress. And we generally say no sustained inflation. Earlier, it was believed that if you give 1 or 2 deep breaths, that would recruit the lung and reduce the risk of bronchopulmonary dysplasia. It is known from the time 1801 when the grandchild of Charles Darwin, Erasmus Darwin, said that most important thing to do is delay the cord clamping. And we have large data now which shows that delaying cord clamping reduces the risk of death, although it does not reduce other things. But if something is going to reduce the risk of death from 9% to 6%, why not take that opportunity? So delayed cord clamping reduces the risk of death, it builds the iron stores, and it has better hemoglobin and better blood pressure regulations. Now, another option which was considered was cord milking, but more recent studies actually have shown that cord milking in very small babies can be very, very harmful. It can reduce the risk of severe intraventricular hemorrhage. So below 28 weeks, you should practice only delayed cord clamping and not umbilical cord milking. And we did this systematic review and published in Archives last year, where we shown that if you do the umbilical cord milking, instead of delayed cord clamping, the risk of intraventricular hemorrhage is going to increase. So cord milking, strictly no for babies who are less than 28 weeks. Use these blenders, which may cost you 40,000 rupees or at the most 65,000 rupees in the labor and delivery room. Sustained inflation, no, because it increases the risk of death. So you would not be practicing sustained inflation again and again. Now comes what do you do during transport? So that is one of the area which remains the gray and list monitored. Most important thing is infection control, regulating temperature with using various thermal mechanism like transport incubator, and resource limited testing. You can use whatever is available to you, and maybe you should have a transport ventilator or TP's resuscitator. Now coming to my pediatrician colleagues, what do you do in NICU? Invest in nursing staff. They are going to give you more returns than your equipments. Nursing care with adequate nurse-patient ratio is going to give you the best results. Because if you have enough nurses, you would be able to prevent infections. Then you should use caffeine, providing parenteral nutrition, and early enteral nutrition with breast and human milk. Mother's own milk, and if it's not available, donor human milk. From the time in our unit, we have started using mother's own milk for any baby who is less than 1.6 kilo. Our risk of surgical NEC is zero, no perforation whatsoever in last 2.5 years. Then use of probiotics, management of PDA, ventilation if you need, use lung protection strategies, prevent pneumonia by using bundle, prevent infection by using CLAPSI bundle, reduce the number of samples you do, use erythropoietin, and you would have strategies to prevent all bad things like BPD, IVH, ROP, and kangaroo mother care and developmental supportive care. Now, just recently we had a paper from India and other developing countries published in NEGM showing that kangaroo mother care is in fact possible for babies who are like 1 kilo, 1.5 kilo also. And then restricting the use of postnatal steroids. Sometimes things may not go as we wish, and the baby's got, say, grade 4 hemorrhage, or it's persistently dependent on ventilator, and we should be frank enough to sit down with the family and give them the option of discontinuing remaining within the legal framework of the country. So one of the very interesting paper which showed that if you have a good number of nurses, your outcome would be far better. So please start investing in your nurses rather than the equipments at this time. Caffeine citrate for all babies who are 33, 32 weeks or lower. And we know that this caffeine started right from birth is going to reduce the risk of bronchopulmonary dysplasia, reduce the risk of ductus arteriosus. It is going to reduce the risk of death or disability. It is going to reduce the risk of cerebral palsy. These children, when they are 5-year-old, they are likely to do better. And when they are at 11-year-old, they are less likely to have significant motor impairment. Their sensory neurodevelopmental outcomes are likely to be better. There will be few babies who would not be managed with non-invasive ventilation and would go on ventilator, especially the smaller ones. And you would say that rather than using straightforward, simple ventilation, use volume targeted ventilation where you are giving only a restricted volume in the lung to avoid injury to the lung. And by doing that, you would be having less risk of death or BPD, less risk of pneumothorax, less risk of more days on ventilator, less risk of hypocarbia, less risk of IVH, severe IVH and PVL. And if you are able to count the morbidities, you can predict the long-term outcome. If you have BPD, brain injury or ROP, then you know that the odds of doing bad subsequently are bad. If you have no morbidities, the risk of baby doing bad is 20%. If you have 1 or 2 or 3, it will go from 20 to 40 to 60 to 80%. So it becomes possible to predict. When you are giving surfactant, especially for babies who are less than 1 kilo, and if you give it budesonide, the risk of BPD is going to be reduced from something like 50% to maybe 25-30%. So you should consider that. In our unit, we use erythropoietin regularly for babies right from first week. It reduces the need for RBC transfusion, reduces the risk of necrotizing enterocolitis, and maybe it is protective with the neurodevelopment because erythropoietin also works on the brain. So our job is not over as long as only babies are in ICU. Post discharge, our job continues counseling the family, enrolling them into Harris follow-up, and then having regular checks with neuro, ophthalmology, etc., making sure that they are immunized. And most important things, some of the most rewarding returns you would find with providing regular maintaining temperature, providing kangaroo care, good umbilical cord care and preventing infection, and maintaining hygiene and skin care and breastfeeding support. So those who are listening from the hall, these are take hospital messages or take home messages. And those who are listening from hospital, these are take home messages. Outcomes of infants depend on many factors. As obstetricians, you can think about timely in utero transport, use of antenatal steroid, use of magnesium sulfate, use of tocolysis, and sending these mothers to the place where mother and baby both can be looked after to improve the outcome. It's extremely important to have the precise estimate of gestational age. We talked about steroids and magnesium, and more very important thing is spending time talking to the family. A lot of times otherwise they would be running here and there, and it's better that we tell them what is expected and what is not expected. Extremely important, respect their wishes, make them understand if things are not good, and if they are not willing, not to push into things. And one of the very critical part with this COVID pandemic, everybody's hard pressed for money, so always look into the finances. Don't push them into something that is going to put them into more debt. Having pediatrician and neonatologist antenatally at delivery is very important. It should not happen that you have a 25-26 weeker who is born, and then you say that, like, this baby is born and is alive at 1 hour, now you take it, because we are then giving a bad start to that baby. And investing in nurses, very important. This gives a dramatically rewarding result. And I can tell from our own experience that having the number of times we have one or two few nurses, your rate of infection dramatically goes up. And most important thing, whatever we are able to achieve, it's not because of you alone. It's a teamwork of doctors, it's teamwork of pediatricians, obstetricians, neonatologists, nurses, and your support staff. You know that when you are talented, you can win the game, but if you have to become a champion, you have to be a team player. Thank you. Hello.
Yes. Can you see this?
Hello, now I can hear you.
Yes, yes. Please accept our e-bouquet from Lactacon 21.
Thank you.
Thank you very much for your excellent presentation.
Thank you.
Shall we move for next lecture in the session? National Mission Health Program for Mother and Child by Dr. Mohan Kisan Shegar. He is MD Community Medicine, MBBS at KIMS Karad, MD in Community Medicine at MIMER Medical College, Talegaon, Dabhade. He is Medical Officer, Group A, 6 years, District Tuberculosis Officer since 1 year, District RCH Officer since 1 year, Medical Superintendent RH Akkalkot since 10 months, now working as Additional Civil Surgeon since 4 years. I welcome Dr. Mohan Shegar, sir.
Follow after such a wonderful lecture of Honorable Dr. Nanda Kishore Kabra sir. Now we will discuss on the different programs related to mother and child. We know that as we know that National Health Mission, which was launched in 2005, the aim was to decrease child mortality and maternal mortality. In this, Public Health Department, Government of Maharashtra, under the guidance of Minister of Health and Family Welfare, Government of India, running these national health programs very smoothly since 2005. We know that this reproductive and child health program was also initiated in 1962, and it was scaled up in different phases in different states and districts stepwise. Our aim of this public health department is to reach the unreached population, to reach the poor and urban poor and underserved population. That is the aim. That's why second slide. Okay, yes. In this, sorry for interrupt. Government of India, USA and UNICEF has given promise that global child survival call for action. It is a promise to keep. So in February 2013, India launched a strategic approach to reproductive, maternal, newborn, child and adolescent health, that is RMNCH+A. These are the different partners, and these are the 5 pillars in this strategy, as just we discussed, that is reproductive, maternal, neonatal, child and adolescent. What is this plus? Plus includes adolescent group. We know that from adolescent we have to take care so that that healthy mothers will be born. In this, there is a linking maternal health to reproductive health, family planning, adolescent health, HIV, gender, precipitancy. All programs are linked here. And important is that home-based and community-based, the care is taken by Asha Anganwadi worker. And the most important is that referral services to the facility. Our aim is to continue the services with constant innovative ideas and with monitoring and supervision. As we know that in these goals, we have the target was set up in different aspects, mainly that institution deliveries to be increased. That was the main aim of this NHM. That is why from village level, sub-center level to all community-based centers level, all the facilities were increased. And in this institution deliveries, ANC care, postnatal care, delivery by skilled birth attendants, then exclusive breastfeeding, then reducing prevalence of under 5 children, then also reducing the unmet need of family planning, increased met need for family planning, reducing anemia, and total fertility contributed by adolescent that is to be reduced, and raising child sex ratio. All these aspects were considered, and the target was set up increasing 2 to 6% increase per annum. This RMNCH strategy mainly focuses on high priority districts, but now it is scaled up in all districts in the states, all states and country. These are the different areas where we have to, the focus is on, in public health department, the focus is on spacing methods. And we mainly review the programs by giving the targets, like how many PPI should is done against deliveries. At least 25% PPI should be done against the total number of deliveries. Then, because interval spacing in rural area, in slum urban area, the problem is that is spacing of birth. And that is one of the reasons that we can reduce that infant mortality rate as well as maternal mortality. Then there is also fixed focus on interval ISUD. Important is that now Asha, one of the important component, accredited social health activist, actually, who is the field worker, which is the grassroots level worker. Actually, the more important focus is on Asha's. Asha mainly focuses on this home delivery of contraceptives and ensuring spacing of birth. Also, pregnancy testing kits and maintaining quality sterilization services. All this comes under reproductive health. Maternal health, mainly there is now research portals are there, HMS data is there, where the as early as possible early registration is done. And to detect in early registration, there is a line listing of high-risk pregnancies, to detect high-risk pregnancies, and line list including severely anemic mothers. And those anemic mothers are tracked and treated also. And also important is that equip delivery points, because now from sub-central level, now when we discuss that that different types of levels are there, village level, sub-central level, primary health center level, rural hospitals, sub-district hospitals, government medical college, likewise primary to tertiary level services we are providing there. And here at all level, the important focus is on, if you want to reduce maternal mortality at all levels, skilled, trained, and with all availability of logistics staff should be there. Then important is that reviewing of all maternal, child, neonatal deaths, so that we can take corrective actions to prevent further deaths, identifying villages with low institutional delivery, and that distributing misoprostol. And important is that to promote, to encourage ANMs at subcentral level to conduct the deliveries and refer to the higher center whenever possible. In newborn health component, important is that early initiation and exclusive breastfeeding. As the theme of this today's conference is to encourage breastfeeding practices as well as nutrition in childhood. That is the most important component. That's why in newborn health, in RMN such a program, it is added. There is a home-based newborn care also by ASHA. ASHA visits those PNCs regularly, see the newborn, take the newborn care and implement those strategies which have been adopted by Government of India. Then essential newborn care and resuscitation services at all delivery points. Newborn care is there, newborn stabilized unit is there. Essentially at all level, there is a newborn care corner. That's why all resuscitation procedures are carried out so that early golden seconds and minutes are very important in this reducing the infant mortality. Then special newborn care units, highly trained human resource and training. Capacity building is the most one of the important part of this program. In child health, again, complementary feeding, weaning practices, that is also complementary feeding. And important in this is that to encourage mother to continuously weaning, that give the proper diet to the child, because the most important part is after 6 months, the weight loss of the child is there. Then important is the IGD shape, that is diarrhea management, that is integrated diarrhea control program is there. In this, after every ASHA, every mother is trained how to prepare the solution of ORS, zinc and give the child. Management of pneumonia, diarrhea, then also malaria, all this comes in IMNCA program, that is integrated management of neonatal and childhood illnesses. Full immunization coverage. Now we know that from birth to first year, all the important vaccines are given, immunization. Even if coverage is less in sub-center level, village level, then we implement intensified mission in the Indradhanush program, so that missed children are found out and we take the further actions to improve the coverage of vaccination. One of the important program, we know that RBSK, Rashtriya Bal Swasthya Karyakram. In this, 4 Ds are identified. 4 Ds means that developmental delay. Second is defects at birth. Third is the deficiencies, and fourth is the diseases. All these 4 Ds are, for these 4 Ds, our all the teams go to the Anganwadi centers, schools, and screen those children, and then find out whether any problem is there. They list the heart surgeries to be done, other surgeries to be done, SAM, MAM children, all the different types of children, they are screened there and they are managed also. And now the most important component which was added in this program was the adolescent health. This is very important, as in rural area, in urban slum area, there is a lot of school dropout children. In this, what happens? In this, we have to address this adolescent group, and different peer educators, we educate them. And for us, that is, there is the URSH program, URSH, that is adolescent reproductive sexual health. In this, the Maitri clinics are there, where at interval levels, this adolescent age group is screened, educated, and these clinics are that implemented. And whatever the high-risk groups are, they are found out there. And the most important point, all this area is also that National Iron Plus Initiative, and now the name of that program is a Anemia Mukta Bharat program. And this program is a very ambitious program. In this, mainly 6x6x6 strategy matrix is used here. Here, 6 different types of beneficiaries are there, from 6 months to 59 months, then 5 years to 9 years, 10 years to 19 years, pregnant women, lactating women, and reproductive women. Likewise, 6 beneficiaries are there, as well as there are 6 interventions. In this, mainly we provide mainly prophylactic iron and folic acid supplementation. Also, secondly, we do the testing. Also, third, in this 6x6x strategy, in intervention, we do mainly in intervention, mainly deworming is done, behavioral change communication, that iron, that dietary pattern is taught. Also, there is a testing and fortification of foods with this iron, and different types of these mechanisms from Government of India to periphery level we do here.
Sir, just 2 minutes.
Okay, 2 minutes. Okay. So this is a continuum of care in these different types of in continuum of care, that is clinical, in outreach activities and family planning. These different types of services we provide in reproductive care, then pregnancy and childbirth care, newborn care, reproductive health care, antenatal care, postnatal care, child health care, then WIPS, then counseling, and HNBC, then IYSF, that is infant young child feeding. So different types of programs are there. And just 1 minute, I want to add here that there is another program, that is Pradhan Mantri Matrutva Vandan Yojana, where we give 5,000 rupees that women who is not working in government or any private sector. The first 1,000 installment we give at the time of registration. Second installment of 2,000 we give after 180 days of that pregnancy, and third installment we give after delivery and after giving the first dose of pentavalent. We give 2,000. Likewise, 5,000. Also, another scheme is, it is for primary, and another scheme is Janani Suraksha Yojana, that we know that delivery that that is BPL families, SCST families, we give them that 700 rupees and 500 rupees each. Likewise, another scheme is, that is JSSK is there, Janani Shishu Suraksha Karyakram is there. We provide the free pickup and drop back services to the women. So in this way, our National Health Mission trying to reach to the poorest poor people and to the marginalized population. And with the help of this all these societies, we are providing care to this society. I am very thankful to our obstetric society, pediatric society, and organizers. Thank you.
Thank you very much, Dr. Shigar, for excellent information.
Thank you, Shigar sir, for a nice lecture. I would like to request Sada madam to felicitate Shigar sir. I would like to request Savaskar madam to be on dais, and I would like to request Sada madam to felicitate Savaskar madam. I request Rohini Deshpande madam to be on dais and felicitate Sada madam. I request Mr. Krishna Sule from Indoco Remedies Limited, who wants to share his few words with us.
Yeah, thank you, madam, for giving a chance for us. Myself, Krishna Sule, Indoco Remedies. And before moving ahead, I would like to say thanks to SOGS and Pediatric Society, who gave us a wonderful chance to represent ourselves. Yeah, please. Actually, all of aware about that in that pandemic situation, the D3 use is increased, but many of people's are not aware about that, the dosage and who will take, how long they will take. So Indoco has taken some initiative to sort out such kind of issue, and we launch one website. The name is Shakti for Her. We are a Spera, Indoco Spera. We are having a service in gynec segment. So that's why we gave a name of Shakti, which belongs to Lord Durga. Yeah, please play the. I request to Kiran ma'am, on the behalf of SOGS, please allow us to launch the Shakti for Her website. Please give us permission. Yeah, and in that website, you will find three windows. In one windows, whatever question will be raised by the peoples, we can sort out over there. And even we are the another windows over there, expert talks are there. And then third window is there, where suppose if you have some case studies, so you can share over there. So next. And I request to all the doctors, please share this website with your patient, which is beneficial to you and your patient also. Next. And this is the brand recently which we were launched, Mythical 60K, and all of you are aware about the mode of action and everything. I will not talk about that. Just I will talk 2-3 unique thing which we have. Please move. When we launch Mythical 60K, we did some survey and we found that in that combination, the major task is to remind the dose of vitamin D3. So for that, company has introduced QR code and toll-free number. If patient can scan this code, they have to just put how long they are taking and when they are starting the vitamin D3, then definitely they will get reminder from our end. And few patient don't have a smartphone, for them we are given toll-free number also. So, and it is in regional language. So thank you. Yeah, thank you very much once again for giving a chance for us. Yeah.
Thank you. Moving towards next session, I would like to request Dr. Rohini Deshpande madam and Dr. Savaskar madam to moderate our next session. Welcome.
Check sound check. Hello. चालूच राहून
इथे पण आहे माझ्याकडे. Good afternoon, everyone. Now we are going to have a very exciting panel discussion, and we have got wonderful contributors as well to this panel discussion. So may I invite to start with our chief guest, Dr. Mangala Vani, who has come all the way from Pune. She's a lactation consultant and she's a director of Hirkani Breastfeeding Medicine Clinic. She is also president of BPNI, and she has got many more achievements to her credit. We already listened to it in the morning, and she's a very distinguished person in the field of lactation, and she's doing a very good work at all the levels. She has been very busy, but still she managed to come to Sholapur. Thank you, Mangal, for being with us. Can I invite Dr. Kiran Sarda, past president of SOGS. She is at the moment president of IWC, that is Innovative Club of Sholapur. Welcome, Dr. Kiran. May I invite Dr. Mrs. Varsha Kirpekar. She's a senior obstetrician and consultant, Utkarsha Hospital. She has contributed a lot to city of Sholapur. She is a wonderful writer as well. She writes a lot of blogs. Thank you, Varsha, for being with us. Now, may I invite Dr. Shakira Savaskar, professor and head of the Department of Neonatology and Pediatrics of Dr. VM Medical College, Solapur. She is, I'm very happy to be her co-moderator. I will request her to invite panelists from IAP.
Good afternoon, everybody. So we are going for the last session now, panel discussion. I would like to invite Dr. Hemant Sathe, sir. He's my colleague, my classmate, my dear friend, and I don't know how many adjectives I should give. Table mate, everything. He needs no introduction, and he's a very well-known pediatrician from Sholapur. Very well doing. Next, I invite Dr. Sheetal Gandhi. Again, a very close friend, colleague, friend, everything. Please do come. Classmate, yes. So he again needs no introduction. So can we bring? Huh? Co-classmates. Yeah. And my co-moderator also is my dear friend and my classmate, everything.
We
Okay.
can have one click, huh? Mohan. Thank you.
Thank you. So I don't know whether Dr. Bhori madam is going to join us. She was to join online. Madam, are you there? No, probably she is not joining. Nilofer Bhori. Join झालेत का बघा? नाही, ते बोलले असते की.
आहे, she's there.
She's there?
Yeah.
So Bhori madam, are you with us? Anyway, let us start now.
Can we have a next slide, please? This is for Dr. Varsha. We'll set the ball rolling. A young primary gravida, age 24 years. She has just delivered at 33 weeks by cesarean section. And she's just recovering. Her baby is shifted to NICU for the treatment of transient tachypnea of newborn. How do you, what is your plan of management for feeding of this baby? Can you just give your thoughts?
Because she is a primary gravida and breech, it is expected that she will deliver by cesarean section. So, and might be it will be a premature baby. So it is better to have both deliveries and in neonatal care at one center only, so that the baby need not be shifted. And if the baby is nearby, and if she can feed the baby directly, then it will be good. Because generally transient apnea is generally not long lasting. I think it will be 2 or 3 days maximum. Yes. So better to have direct delivery, direct lactation. But if it is not possible, then it can be expressed milk from the baby. It will be colostrum, and that will be enough for 2 to 3 days. And then when possible, when mother can be moved, then she can go and feed the baby.
So what do you think for next day she feels that the breasts are getting little heavy, baby is still in the hospital.
The baby in mother is also there because it is a cesarean section.
Yeah, but the baby is shifted to some other hospital.
Yeah, but it should be as far as possible in the same hospital. Actually.
Yeah, it should be, but it is not.
If it is not possible, then you have to express the milk and carry there and feed, I think so.
Okay. So Dr. Sheetal, the milk has been sent.
Yeah.
And how do you actually feed? Do you feed directly with the spoon or rice tube, or what do you do?
Yeah, this is a 33 weeker. So I expect a weight, if it is a AGA baby, somewhere around at least 1.5 kg minimum. So, or it may be even more than that. So if it is possible, it depends on this is a TTN. So TTN usually is because of just fluid accumulation in the lungs. They may have some minimal hypoxia on day 1 only. After day 2, they show recovery. Maybe for first 24 hours, I would just wait and give IV fluids. And from the next second day onwards, I would start with straightway with oral feeds rather than the tube feeding or anything like that. That would be my plan. So
Dr. Sathe, what is your practice? Do you put these patients on intravenous fluid, or do you, whatever colostrum we have sent, will you feed baby with that?
Definitely. As far as possible, when the milk is available and the baby is ready to accept the feed, we must feed the baby directly by oral route, the colostrum, the best possible source of milk available to us.
Professor Madam is also here to give her opinion.
Yes, I would feel it is a transient phenomenon. Most of the babies, they come after 6 hours and by 24 hours, they settle down. And if the milk is available, we can definitely go for rice tube feeding for this child instead of starting with IV fluids. If of course, if the tachypnea is maybe it's above 75 or so, it's better not to feed the child, start on IV line. And once the tachypnea comes down, we can start direct feeding, or we can go by if the mother is unable to be shifted. spoon vati, if still the baby is a 33 weeker, we don't know whether the baby is going to swallow properly. So we can go by a trials tube feeding also.
Okay, thank you. Dr. Kiran, could we have prevented this TTN by any chance? Antenatally?
Yes, we can.
Yeah, can I repeat the question for you on the mic? Could we have prevented TTN at all by some antenatal management?
Yes, when we come to know that she is to be delivered prematurely at 33 weeks, better we should give 2 doses of steroids. And when we have planned LSCS, then even myself, as we give in eclampsia, the 1 dose should be given of these two, Maxelf and steroids can be of little helpful.
Dr. Mangal, do you how do you give Maxelf? Like, what is your logic of giving Maxelf for this?
Yeah,
33
because
weekers?
the research says that it helps the neurodevelopment of the baby, and that is why it is recommended magnesium sulfate.
But is it?
But I'm not sure whether
33
we
weeks?
give 33 weeker.
Yeah.
I think it is 28 to 30 weeks up to we give, not at 33 weeks. It is mainly the steroids. And regarding the nutrition of the baby, because 33 weeker, yeah, she has a transient tachypnea, but once it settles, but at 33 weeks, the sucking, breathing and swallowing reflex is not still well established. So for a few weeks, maybe we just have to get the regular expression of the milk by the mother and feed the baby. And as we discussed earlier, we can either give by rice tube if baby really not able to swallow. Otherwise, just by directly by spoon feeding is okay for me, I think, for this 33 weeker. And preferably if the mother can also come to the same hospital and visit the NICU, and the skin to skin contact will be very important for this baby, the kangaroo mother care also.
Dr. Sheetal,
Yeah.
is there any difference between TTN and RDS? Like,
Yes,
how-
yeah. Before that, for your first question, how to would have prevented the TTN? There are two main things. Cesarean itself is one of the etiology for TTN.
Yeah.
Then second thing is if the mother is having a gestational diabetes, the chances of TTN are more. So if if the diabetes is well controlled, if she has a diabetes, gestational diabetes, and if it is well controlled, then maybe that the TTN may be avoided. If one can avoid the cesarean, then also the TTN may be avoided, because the TTN doesn't occur mainly with vaginal deliveries, because of the vaginal forces. They cause the fluid to come out from the lungs. So TTN is avoided in most of the vaginal deliveries. Sorry? No, this is okay. If it is, it could be avoided. I'm not saying that it is avoidable every time. These are the two main causes, things which may prevent TTN. Now, second thing, you ask about TTN and what? RDS. RDS has got multiple etiologies. RDS just means respiratory distress syndromes, which is not synonymous with hyaline membrane disease of newborn. This has got multiple etiologies, right from the streptococcal infection and many other congenital infections. So RDS is a general term which includes TTN. So if are you talking about hyaline membrane disease? So HMD and TTN on day 1 in a 33-week older may be difficult unless you are able to see a complete whiteout lung on the X-rays. So even completely whiteout lungs may be there even with TTN. They can be there even with streptococcal pneumonia. They can be there with mycoplasma pneumonia. So, or they can be there with some congenital heart diseases like TAPVD, total anomalous pulmonary venous drainage, or a partial anomalous pulmonary venous drainage. So you just on day 1 can't say that it is TTN. It is a diagnosis of exclusion, basically. It is how the baby recovers on day 2 usually, but if it is a TTN, they would start recovering from day 2. So that is how we deal with it.
Thank you for contributing to this question. Can we have a next slide, please? Dr. Mangal, This is a second gravida who has delivered a term, and she was okay with the breastfeeding when she went home, and she comes back with fever, engorged and inflamed right breast. So how do you manage now? And how do you manage feeding of the baby as well?
Okay, so how many days you think? But with the fever, engorged and inflamed right breast. So if the breast looks inflamed also, so it is not only engorgement, and she has a fever also. So looks like she has a mastitis. So mastitis happens probably because of the mismanagement of the breastfeeding in earlier days. And she probably has the nipple trauma also with that. So we have to, now you have asked me about the management. So it is a management of the mastitis. She doesn't need admission for the mastitis again, but she will need a rest. She will need some analgesia and she will need antibiotics. And that antibiotics would be for 10 days mastitis. And she can continue the breastfeeding on the both sides, even from the mastitis side also. There is no harm to the baby at all. In fact, the more the milk is drained from that breast, she will recover faster. That mastitis will resolve earlier.
Okay, so antibiotics for 10 days. And which is the preferred antibiotic?
We prefer either combination like augmentin, or we also give flucloxacillin we give preferably, and that is for 10 days. But even if she's sensitive to that, then we can give clindamycin. But we avoid tetracycline and ciprofloxacillin because they are not good for babies.
And she also has got nipple crack.
Yeah, so again, the latching and the positioning is somewhere wrong. So we have to review again the diet and watch the latching and
Nipple pain and soreness, what do you do?
yeah, so if the baby is latched properly, then the baby is not holding on to nipple. The nipple is inside near the baby's palate. So then the breastfeeding is not painful if the latching is proper. So even if there is a nipple trauma, she will manage the breastfeeding. And
She should be encouraged to
yes, that is the main line of treatment.
I think on that side you can use the different which is good, not that routine one, the one you showed. That will be better on one side for healing.
In a sense, ask them to take the care of the nipple, use nipple shield so that the baby's gums do not put additional trauma to the nipple and the areola. And immediately after the application of the ointment or nip care or whatever, we ask them to feed.
But you know what happens with the nipple shield? Baby again latches only on the nipple because, and then the latching doesn't improve.
Yes.
And
But
that is the problem. So we always prefer without nipple shield first. And if still is not helping, then of course the nipple shield may be one resort.
If it is unbearable, she should avoid. If it is bearable, she can do it.
Trauma, no problem. If the mother is, the mother will wince with pain the moment the baby is sucked.
No, but that is what I said. If the latching, the nipple is way inside baby's mouth, it believe me, it is not painful then, even with the nipple trauma.
I think that the technique of breastfeeding matters.
Does.
Also,
that's the message that we get from this case.
Also, she can.
The technique of breastfeeding should be put it on.
I showed also the video in my presentation where the baby had a difficulty because the baby was not turned towards the mother. The mother was holding with the 2 fingers. So the areola baby was not on. So these are the things, and the baby has to do complete, and then we should not push to the baby's head. We should support at the baby's neck, and the baby's head should be extended. So that way the baby is able to latch better.
Thank you, Mangal, for emphasizing on the technique of breastfeeding. That's very, very important. The position of the nipple inside the mouth.
Basic emptying of the breast only is going to help her the most.
Yes.
Even cold compressions means cold fermentation, what you say, this also helps to reduce the inflammation. And antibiotics, we usually give cefixime for 5 days. We don't give very higher antibiotic and for longer days for to avoid antibioma or something breast abscess. If we are 100% sure it is mastitis, then we should go for antibiotics. But if there is a little bit doubt in our mind, so we should give only analgesics and anti-inflammatories. So there should not be any formation of antibiomas.
So unfortunately, after 6 days, this patient has developed a localized abscess. So how do you drain it? How do you drain that abscess? Under ultrasound guidance, or what do you do? It's around, but it refills again.
Yeah, what I do with my experience, yeah, it is not possible to drain this abscess just once, like with the incision and drainage we do, because that is done under anesthesia and we explore the hole and we break the loculi. But here we cannot go into multiple loculi. So that is why we have to do the multiple times the aspiration. I do alternate days. So
Okay.
normally 2 or 3, I have done even 4, 5 times also in one mother. So after doing 3, I again review, just examine clinically and see how it is. And she will feel better as the pus becomes less and less. Her fever will go away, and because the breastfeeding is continuing. And then we get the sonography done again and to see.
So
And
basically
if
we have to
small
counsel.
amount is left, 1 or 2 centimeters, that will resolve. We don't have to take completely the
I think
pus,
it's
all
a
the
very
pus out.
non-invasive method, and I think
Very.
patient, it is very acceptable to patients as well.
And you
because
know,
it is an
obstetricians
outpatient.
are surgeons also, so it is not difficult to learn those techniques.
Yeah, we are also doing in our OPD.
Yeah, why we refer to the surgeon? I don't understand the breast abscesses.
Multiple aspirations similarly, but we do it daily.
Okay,
I in my OPD do it
Great.
daily. I call her, and within 2 or 3 settings, as you said very correctly, ma'am, within 3 settings, the amount of pus is decreased a lot, and she's very happy and starts breastfeeding. And that again reduces the abscess. And it is in one study I have read that it is said, if the abscess, part of abscess is also ingested by the baby, it is no harm at all, but on the contrary, it is beneficial.
Yeah, she can continue breastfeeding on the same side. But what I say, ki suppose pus is coming directly through the milk, then the mother or the family doesn't like it. Okay, so for few days, don't breastfeed, but just express, and she can breastfeed from the non-affected.
Dr. Mangal, in one of the patients who had actually treatment done for drainage of abscess, open
incision
open
and
method,
drainage.
and following that there was a milk fistula.
There was milk fistula.
Yeah, so how do you tackle this?
No, but
Any
as
idea?
the wound is healing, automatically that closes down.
So we will
But
have
you
to
need
just
a
wait and see.
patience, and she has to express the milk, and even lot of milk drains through that dressings also. But slowly that will dissolve and it gets healed.
So I think
it is not
basically
the
counseling
concern.
of the patient
Yeah.
before we do all these procedures is very, very important, so that the acceptance will increase.
One more thing I wanted to tell, that while doing the dressing of after IND, after packing of that wound and all that, we should keep the nipple area open so that she can feed from that side also. Because I regularly do IND myself. I have worked in surgery, maybe because of that. Since last 20 years, I am doing IND whenever my patient is having
And if
abscess.
at all we
But
are
now
doing
have you
IND,
changed
you
for
know
this,
that
aspiration you said?
Yeah. No, but
No,
when
IND
IND
she
is
said
required, whenever IND is required, we keep nipple areola open for breastfeeding from that side.
Try to keep the incision away, because the surgeon normally takes the junction at the areola and the skin junction, and then that is very close to the nipple areola complex. So if we try to take the incision little bit further away,
I think that is only because of for the cosmetic reasons they do it.
Yes. But now, if we take radial incision, that is better for breastfeeding. And we should not consider here cosmetic purpose. What I think, breastfeeding is more important than her beauty.
Again,
That depends
counseling.
on the lady.
No, counseling. Your counseling
So the
skills.
anatomy of the breast is not disturbed to that extent.
Exactly. With radial incision, I have been taught like that in surgery. You should take radial incision for IND of breast sepsis.
Thank you for contributing.
Radial
tips
incisions
for
means
this.
like this.
No. According to the nipple, if this is a circle, then we should go from nipple to outer base
you
of the
are
breast.
parallel to the ducts.
You mean to say
Not
circumference?
multiple ducts are
Like that.
severed.
Like this.
Yeah, centrifugal.
Yeah,
correct, correct.
radius.
Come and approach the
Correct.
Yes. So ducts are.
not injure the ducts.
Yes, sir. There is less chances of injuring ducts also.
And next time they can successfully feed. Or
Yes.
maybe next time is next week.
Yeah,
they
and
are
even when we put finger while breaking the all breast sepsis loculi, that time also it is we do like we circulate our finger so that ducts are not broken.
like this rather than like this.
Yeah.
Thank you, Kiran and Mangal for highlighting all these important points. Can we move on to the next question, please? Right. This elderly primary gravida has recently delivered about 6 weeks ago. She herself is a self-employed and she wants to get back to work, and she wishes to continue with the breastfeeding. So how do you manage her breastfeeding and what things can be done for this? How can it be handled? Dr. Mangal or Varsha?
Yeah, 6. Yeah, let Varsha say something. I will talk on your behalf. So 6 weeks is too early because nowadays the government law is there that every woman delivered, the maternity leave is 180 days, that is 6 months. So she will get the leave for 6 months. So
She's
she will.
self-employed.
She's just.
Yes, that is the reason.
So that is good. Now, self-employed means what work does she? Does she work from
Private,
home?
private.
She's doctor. Let us consider. We have one gynecologist in our Solapur. She joined very early. I know her.
We have to first counsel her during the pregnancy, the importance of breastfeeding, so that once she's motivated, there are so many benefits, not to baby, but to her also. Then automatically she will plan accordingly.
No, she is
Sir,
motivated. She is motivated to breastfeed the baby. It's not like
So that is what I said, at least 6 months. Yeah.
No,
no.
One, if she is a self-employed lady, and
Yes.
she can take the baby with her
Yes.
and
But
feed
she
the baby.
wants to return back to
One
work.
thing I wanted to tell, she can manage her working hours.
No, that's what.
She
If
can
she's
manage her
self-employed,
working hours, self-employed,
what is
2
the
or
problem?
3 hours. After 2-3 hours,
Every
she
2
can
hours
take
she
a break.
can take a break, feed the baby, and
Yes. If not possible to take any break and go to home, she can carry her baby and have some room or space like Hirkani Kaksha, which are available in.
But can she express and store the milk or
Yeah,
not?
That is
yes,
also-
yes,
that
that
is
is
also-
also.
that is also
That
possible.
is also.
That is also
She can
possible.
express her milk.
Yes.
Yes, yes. She can
The
express.
first option would be to take baby with her
Right.
and nurse and take some breaks in between her
Jaga
work.
असायला पाहिजे तिथे.
And then if it is not possible,
It-
the
she
work
is
is
self-employed, so she
continuous,
should
then
be able to
probably
manage.
as baby grows and the work is continuous and demand of the baby also gets more, then in that case, as Varsha says, then maybe she can express the milk and then it can be used by anyone who is around.
Yes, like in Mumbai, like cities when traveling and carrying baby, both are not possible. This is a very good option for her to express milk in the morning while leaving home, and that milk can be stored for 24 hours without any harm to baby, and that can be given to
Some countries prime minister also carried the baby with her, no?
Yes, Australia.
So
Right. Now then you want to ask any questions?
No, I feel basically she's a elderly primary gravida, so she should more focus on the breastfeeding rather than going out for work, because that is a very important issue she is having, and maybe other time she is not going to conceive again. So the nutrition of the child is most important than any other thing.
So that is why I was focusing. The research says that once a woman starts working, the rate of successful breastfeeding goes down because she will have a stress of the work, coming back, baby, the household work. So that is why the longer she stays first at home, then there is a more success. And then later on, if she has to go, then these are the options that we discussed.
rather than storing, sucking is also important for
More
more.
getting
So that is
enough
what,
volume.
before she goes to work, she should breastfeed the last thing. And when she comes back from work, the first thing she should do is the breastfeed the baby. And the baby also has the reverse cycle. The baby breastfeeds more in the evening and in the nights. And the daytime, it sleeps most of the time when mother is away. So the baby's requirement also more when the mother is with the baby.
So which kind of expression would you advise, hand or pump in this case?
It depends which kind of mobile you are using, the small one or the smart mobile. So
which is
now
the
there are
smart?
such a good pumps in the market, you know, so electric breast pumps I would advise, because with manual, with hand expression also good, but it is tiring and many mothers are very sensitive and they then may not do the proper expression. And not no manual breast pumps also. I would suggest the electric breast pumps.
Because for my daughter, younger daughter, she was there, and it was she had some problem. She delivered here only normally, and she had problem of feeding. So she was very firm. I have to do breastfeeding. She was not ready for outside feeding. So she came all the way from Pune, stayed with us for 2 days, taught her how to feed, and then she went. Still, she is feeding. The baby is 2 years old.
That's great.
Good.
So
Just the timely help always helps. And they are very small little problems, you know. So we have to do the counseling and increase the mother's confidence. And then they just fly off, you know.
The last question.
Pump helps you uniform expression of the milk. Sometimes the ducts are blocked. My daughter had the same problem.
And how
And
long
that
can
is
they-
why
Suction, and then the ducts were open.
Yeah, even that's why the donors, you know, who express the milk by breast pump or where there are milk banks, in your lecture also you said by hand expression, but actually they do by breast pump. In the milk banks, there are always few breast pumps and that too hospital graded pumps. So mother are very happy. They have plenty of milk also. And in the wards also now in DY Patil, you know, Dr. Shailaja Mane, who is in charge. So she says ki we have no any breast issues like engorgement and nipple trauma or less milk. And the mothers are generally quite happy. In spite of donating milk, they have plenty of milk because they're using this electric hospital graded pump.
And how long would you use this pump for? Like, is there a time limit?
1.5 to 2 years. My daughter
No.
used for 1.5
Like
to
at
2
one
years.
given time. At one given time, 10 minutes, 15 minutes.
What we say is, it is, I just suggest ki 5 minutes on one side, then 5 minutes on the other side. And then you do the second cycle again for 2 to 3 minutes each. So not more than 15 minutes at a time. They should not be like half an hour, 1 hour. The frequency is very important. That every 2 to 3 hourly they should express the milk, because they feel sometimes nahi 6 घंटा हम रुकते हैं तो थोड़ा सा ज्यादा दूध आता है, but then the milk supply will not improve. So like when the baby on exclusive breastfeeding, sometimes baby demands even after half an hour. So we should do the pumping also like that frequently, and then definitely the milk supply is increased.
Okay. Can we have a last question now?
No, finish. Thank you now.
Okay.
Thank you na.
Okay, then we will end. So thank you very much for being with us, Dr. Sada, Dr. Mangal, Dr. Varsha, Sheetal, and Hemant. It was a great panel, and on behalf of myself and
Thank you,
Shakira,
Dr. Rohini, Dr. Shakira. Thank you.
Pediatricians ला question आहेत की अजून? Pediatricians ला questions आहेत ना?
She is going to ask questions. You have not said enough.
तू याच्यात हे केली आहे का मोबाईल वरच आहे? अच्छा ठीक.
Feeding, we could contribute.
We allowed you to call.
Right.
Thank you.
You have also experience.
Anyway, we enjoyed.
याच्यावर नाही केलेले.
So I can ask one question to the pediatrician. When the mother and the baby in the hospital are delivered, how do you count? Tell the mother, because mother says my milk is less. So how do will you tell her that her milk is enough for baby? What are the parameters you ask her to see?
I'm sorry. Can you please repeat the question?
In when mother is in the hospital, for example, day 3, and
Day
she is
3.
little bit worried ki her
Right.
milk is less for baby.
You are talking about normal delivery?
Yeah, normal delivery.
Okay.
So what parameters you will tell her to watch out? How do you know that the milk is enough for baby?
Yeah, there are some few things which we advise. First, this is day 3 you are talking of. So the day 3, I expect if she is a primary, I expect milk to start flowing. Then second thing, I would positively tell her to feed the baby on breast and not to give any other feeding like say sugar water or other formula milk or animal milk or anything, booty grape water and
She's
anything.
doing all that.
And then assess if the child is feeding for 1.5 to 2 hours comfortably after each feed, and not waking up every now and then immediately after feeding, say 15-20 minutes. Second thing, what is the frequency of passing of urine and motions per day? So 3, 4, 5 times in a daytime, and 3, 4 times or 4, 5 times at night. Urination, urine, right? Yes, on day 3 also. For every 2 to 3 hourly, the child should pass urine on any day. It doesn't matter on day 3 or day 4. So and motion, yes, transitional stools. It depends on if the baby has passed meconium right on day 1. Maybe transitional stools will start forming from day 3 onwards. So maybe it's some change in color from black to say gray, and then day 4, 5 or 6, I expect the stool color to turn to yellow if the baby is exclusively breastfed. And milk flow, again, she can check for herself after pressing manually. If the milk is started flowing, there is usually a congestion of the breast, and the breast hardening is there on some first 3-4 days. So which the breast gets softened, and as she can feed easily. This is problem mainly for primaries. For the multis and other things, the milk feeding is not at all a problem, because they know the things already.
Yeah, that's good, wonderful. Only thing is about the urine output, because
Yes.
day 3, yes, she doesn't have that milk has not started coming. Usually that happens after 72 hours. So it is said the stool, the baby will pass plenty, but the urine output, generally we say maybe once in first 24 hours, twice on the day 2, and 3 times on day 3. So first 5 to 6 days, baby doesn't pass much urine. Only after week, then baby starts passing urine 6 to 7 times or more in 24
maybe
hours.
the
Not on day
obstetricians' views
3.
about
Because
urination
if
may be
you
different
tell
than the
mother-
pediatricians.
Yeah.
The first urination has to be before 24 hours.
Yeah,
First
once in
urine. If the
24
child is not
hours.
passing
That is true. But
urine
day
in first
3
24 hours, we suspect
Yeah.
if there is some
Yeah,
obstruction to
correct.
the urinary
But
tract.
day 3, not 6 to 7 times. It is
6 to 7 times in full 24 hours, definitely.
be after 1 week.
No. So
we can also look for
we will
other
strongly differ with
aspects.
this.
We can
Because-
also look into the other, as he has rightly
Yeah.
said, the consistency of the stool, the color of the stool, whether the child is sleeping,
The
whether
main
the
thing
child
is
is
to observe
comfortable.
not only the frequency of urination, the color of the urine also is important. This is mainly important because as Dr. Shakir also would agree, and Hemant would also agree, because the neonatal jaundice is a major problem in many of the babies who are inadequately fed. So one of the main and simple indication is to ask the color of the urine and the frequency of the urine. These are most important thing for the pediatricians. We always ask about stool and urine.
If they are not fed properly, they get jaundice early.
Yes,
Yes,
one of the cause of the increase in the jaundice is inadequate feeds. Is one of the aggravating factors for jaundice.
That is breastfeeding jaundice. It is known as breastfeeding
Then
jaundice.
why do they ask to stop the breastfeeding?
That is
No,
breast
nobody,
milk
no,
jaundice, and even that you are not supposed to stop milk.
nobody asks.
That
Unless
also you are not
breastfeeding is one of the causes of jaundice is galactosemia.
Yeah.
So in that case, only breastfeeding is advised to be stopped. For breastfeeding jaundice, also most of the times it is not advised to stop.
Non-breastfeeding jaundice, because
breastfeeding milk is less for baby.
We practically never advise for breastfeeding to be stopped unless it is absolutely contraindicated.
Any other questions?
So there is question for Dr. Hemant Sathe. Do vaccination in lactating mothers lead to any ill effects on the newborn?
No, but except for a few incidences in case of smallpox and yellow fever. They have in yellow fever, it's a live attenuated vaccine. Two case reports in the literature are there where this has caused harm to the fetus, harm to the newborn baby after feeding the breast, but otherwise there is no problem. So no, the smallpox, in smallpox, the literature says.
Literature is long back. Smallpox now is eradicated.
Smallpox is eradicated from the world. From the world. But I'm telling you, this has happened in smallpox and yellow fever. Yellow fever vaccine we do not routinely give. We give to those who are coming from, who are going to those endemic areas, like part of America and Africa. So there is the question. There also in the literature says two cases, because it's a live vaccine, the virus can always go from the breast milk to the baby and infect. That is the only problem. Otherwise, in a lactating woman, vaccination is no contraindication at all.
COVID also can be.
What about COVID vaccine?
For our daughter-in-law, we did not give. Let me tell you the facts. Because everything is novel. What is going to happen, we do not know. That's why we kept the moment. At 6 months, we gave the first dose of the COVID to her. So
After delivery or
6 months later.
6 months.
6 months. But initially we did not give COVID because otherwise.
No, but you should give.
I know.
You should give after.
I know, but then the government and these agencies were also not accepting. We were ready for it. We knew for sure nothing is going to happen, but everything is novel. Corona is novel to everybody.
Nobody has studied that much.
And that's why. But the moment it was 6 months and milk feeding was decreasing, we opted for taking the vaccination, and she has completed it.
Kiran, what is your opinion? Can you give at around 6 weeks or 4 weeks just after delivery?
What?
COVID vaccine.
Yes, we are giving and we are advising for lactating ladies. Just complete after completing her puerperium, no harm in giving. On the contrary, we are promoting now. Foxy also advised, given us guidelines to promote this vaccination.
Not in the beginning.
No, not in the beginning, but they have.
But now they have changed the
invited our some data reviews. Whether somebody has any problem with lactating lady or even after COVID infection also, we are asking to.
Which one would you use, Covaxin or Covishield?
Both vaccines are equally potent, but actually there is no difference in Covaxin or Covishield. Equally. Yeah.
So basically, some basic thing about vaccination, as we pediatricians know it better, I think. First, let it be any vaccine, COVID or any routine vaccines which are given. Thing is that we have to find out what type of vaccine it is, whether it is a live attenuated vaccine or not a live vaccine. That is the only differentiation which we need to make when you are giving a vaccine to anybody for any age. If it is a killed vaccines, as you are talking, this COVID vaccine is not a live vaccine. So it can be given safely at any time, either in pregnancy or in lactation or at any period, if it is indicated for the adult age also. So regarding similar to, there are plenty of other vaccines which can be given in pregnancy, but which I don't know if they are given routinely by the obstetricians. Like say hepatitis A vaccine can be given safely, hepatitis B can be given safely, tetanus toxoid also you are giving definitely routinely. Then except perhaps MMR and varicella, chickenpox, because these are live attenuated vaccines, they are avoided in pregnancy. And the BCG is also live vaccine, so these are avoided. Rest of the things.
No, we are talking about lactating mothers.
Yeah, lactating,
so
same
BCG
principle.
can be given. Everything can be given.
Yeah,
Why
for
not?
lactating, I'm
Lactating
talking about.
mothers.
Yes,
it
yes,
can be
absolutely.
given.
For pregnancy, I'm talking. Right.
Sorry, I thought we were talking. Okay. Next question is for Sheetal. Breastfeeding promotion is on large scale. Still majority newborns are receiving top feeds. Where are we lacking?
If you compare with Western countries, I don't think we are lacking. I think if you compare the figures with the Western countries, the breastfeeding figures, we are at least 50-60% of the girls here, they are breastfeeding. Nowadays, the buzz is coming in Western countries, but still, I would say the figures and the not that it is mostly I think the affluent class of people or girls who are reluctant to feed the babies on the breast, and the many of the recently then absolutely I agree that there are many things which can still be done at the family level, at the community level, at the national level. So at the family level, definitely one has to provide a comfortable atmosphere for the lady to feed the baby whenever she wants, and not to put her on any domestic work and other things. Second thing, at the community level, the community must provide the ladies with arrangements to feed their baby, like say isolation room at in the. Yes, that is what I'm saying. That Shakira is asking same thing. What can be done to promote?
So basically, first month it is all a teething problems between the mother, the child, the mother-in-law. If she's in her mother's place, she's happy. But if she's in a mother-in-law's place, she's unhappy about everything. And if she's
more of a social problems rather than feeding problems.
And madam had already put latching has to be there, and counseling. That is the most important thing.
Primary has to learn. The most important error, I think, what we are observing, the ladies think that they know everything about the breastfeeding when they don't know anything. Especially this happens with the primaries. We have to, most of them, we have to teach them how to hold the baby. We have to just teach them how to first hold the baby properly, how to hold the baby after the feeding. For how many they are under impression that if the baby burps after within 3-4 minutes, they can immediately make the baby lie down. Not like that. So these are some of the concepts which the ladies carry, that they can feed in the. I have to first teach the mother-in-law that she has to sit in front of the girl and teach her how to feed the baby.
You have to teach the mother-in-law first.
Yes, absolutely.
Because she will say, मेरे जमाने में तो ऐसा नहीं था, मुझे क्यों नहीं?
You have to take interview of mother-in-law whether she had breastfed the baby or not.
No. She will say, मेरे जमाने में तो ये था ही नहीं, हम लोग तो लगाते थे, वो feeding हो जाता था.
I just wanted to have a.
No, the experienced lady, who has breastfed, she has to just sit in front of the lady. She has to she has to, someone who is trained in breastfeeding has to train. They have to train the mother. First, we have to check with if the mother, the primary especially I'm talking, they check the right from the nipple, whether it is retracted, flat or something. If she is having, there can be inadequate breast milk secretions also for first few days. So, and a lot of diet problems also. There's the mother-in-law prohibits everything for that girl. So she doesn't get any food which she likes.
So can I just say that, when we actually, it is a common observation that we see women coming from rural area, naturally the breastfeeding goes without saying and without any complaints. But when it comes to metros or maybe urbanized population, then
you see the figures, rural areas also breastfeeding is less. It is not never full 100%. Those figures, they have done the data from all over the India. So, and we've been visiting to Anganwadi so many times, and there are so many mothers who are not able to.
I think the most important cause of less.
And another thing, what we are lacking, one thing is establishing the lactation, and another thing is sustaining it. What doctor from NHM, he said, like they have community nurses, but when patients come to private, we don't go over to them to find out what is happening, which happens in maybe some of the countries like UK, because they visit, to find out what is happening. So that follow-up needs to be done very scrupulously. At least phone call or something.
The barrier is this IMS Act, which is not being followed. Formula in many hospitals routinely prescribed
To every mother's room, it is sitting there. That
Yes,
debba.
yes.
So if the debba is sitting there and the baby is crying, immediately mother-in-law or somebody will say, you have no milk, so you give one thing.
No, actually, it should not be available over the counter. Some of the things are available over the counter. That should be only
No,
on a
I don't think
prescribed.
I don't think any pediatrician prescribes that powder.
It
and
is over the,
and who
no,
prescribes
it is over
this?
the counter only
Sorry?
they get it. They get
No,
it over the counter.
these are usually given as
Dr.
OTC.
Patil wants to say something.
Almost everybody in India wants to feed
Right.
on breast, but problem is about patience. Initial 3 days, when mother has very less breast secretions,
The baby is crying at
right
night.
from the obstetrician and few pediatricians maybe, right from obstetricians and few, pediatricians, family members, everybody wants that baby is not getting anything. And here doctors also don't know the capacity of the baby's stomach. They feel that secretions are not enough for baby. Whatever the secretions, we have to tell them that those are going to be enough. We have to observe the baby. If it is passing the urine, if it is showing satisfaction by it is sleepy after the feeds, it is okay. आपल्या लोकांनाच वाटतं त्याने भरपूर पिलं पाहिजे असं.
So basically, the beliefs and the practices have to be improved.
Staff also believes right.
She doesn't want the headache, no? She's.
No, that should be totally prohibited.
And that's why I insisted in the last trimester of pregnancy, you should have a lecture on successful lactation.
It needs.
Somebody prescribes now.
It needs establishing a breastfeeding needs perseverance and patience. So if we are in a hurry, आपण दुसऱ्या कोणावरती ढकलून देणार. If sister is not motivated enough, if the family members are motivated enough, it needs patience and it needs perseverance.
Yes, totally
So
agree
I
with
think
Pradeep.
we all have to contribute to that. You have brought out a very good point. Thank you.
हा सोपा मार्ग ठरतो ना, कुठला तरी फॉर्म्युला फिट द्या आणि ते वेळ मारून
नाही तो बेबीला पण खूप सोपा असतो. Baby also likes it because baby doesn't have to work.
Once
baby
given
also likes
formula
it.
feed, it refuses to suck also.
Detrimental to him in long run. So he's not getting the.
It creates a nipple confusion. It creates, he doesn't have to put a lot of efforts to suck the milk, and even the baby likes it.
So thank you very much, all the panelists. It was wonderful. All the ideas, suggestions, and everybody's contribution from the audience as well, Dr. Patil. Thank you very much, Dr. Aboli, Archana, and Dr. Arkal for giving us an opportunity to be with you all. Thank you very much and have a successful breastfeeding for all your patients. Thank you.
Thanks a lot, all of you, for inviting us and giving us this opportunity.
From all
Thank you.
panelists, thank you for organizers and for moderators.
So let us, everybody should stressfully insist for successful lactation. This will go a long way.
Yes,
Prevention of infection in the baby.
Madam, very nicely shown the.
Yes, very important.
Yes.
So, like a supervised bath, it has to be one supervised breastfeed by an authorized person.
Very nicely said by Mangala Madam for teaching the positions when the patients and their mother-in-laws are asking to keep the nipple in both the fingers. When they are teaching like that, hold nipple and breast like that, I tell them, तुम ये ऐसा कैंची क्यों लगा रहे हो, ब्रेस्ट मिल्क को कट क्यों कर रहे हो, अपने को काटना नहीं है, अपने को देना है. तो गिविंग पोजीशन, C or that position to hold breast, and this then
how to hold and how to.
Maybe Mangal, you can share so that we can show it to the patient.
4 fingers should raise the breast away from the nostril.
Yes, but they feed like yes.
मॅडम बरेच मिसकन्सेप्शन असतात. आता ब्रेस्टने नाक जर प्रेस झालं तर त्यांना वाटतं ते बाळ असं कॉन्टिन्युअस प्रेसिंग म्हणून नक्की होईल. एक मोठा कन्सर्न असतो त्यांचा. त्यामुळे
Yes, many myths. It is yes. Our role is very important to rule to correct these myths. डावीकडे पाणी असतं, उजवीकडे दूध असतं, उजवच पहिलं पाजायला पाहिजे असतं, नॉर्मल नंतर लवकर दूध येतं. सो मेनी मिथ्स.
Thank you, Savaskar madam and Deshpande madam for moderating the session. Thank you all panelists for such a wonderful panel discussion. Thank you. And I will ask Dr. Sudeep to continue.
Dr. Mandal is the president of BPNI, so she's going to of Maharashtra. So take us into the
Hello. I would like to call Aboli madam to felicitate Kirpekar madam. Hello. Hello, ma'am. Would like to felicitate Kirpekar madam. Thank you. Thank you, ma'am. Now I would like to conclude the session with the vote of thanks. I would like to thank the chief guest, Mrs. Sri Kanchana Yannam, madam, all the speakers, the chairpersons, and the sponsors, Indoco Spacer and Dr. Niharika Raghoji, madam, and the online partners, DigiShield. Thank you. And also our audiovisual partners, Shedjali. Thank you.